Let us start with the session. We talked about Euler-ACR criteria, which was done. Now let us talk about the autoantibodies, which are seen in SLE. That is a table which is asked in the exam. It's a very, very important table. And you will find this table being important not only in in medicine, but also in pathology part. So multiple times questions have been asked. First of all, what is the autoantibody which is essential for diagnosis of SLE, which is the best screening test, high sensitivity, but poor specificity. Poor specificity means it is not specific for SLE. It can occur in other conditions also. The name of the antibody is anti-nuclear antibody. Most specific antibody, it is anti-Smith antigen antibody. SM stands for Smith antigen. So anti-Smith or anti-Smith antigen antibody correlates. Which antibody correlates with disease activity? It is anti-double-stranded DNA. Anti-double-stranded DNA high titer indicates disease is active. Anti-double-stranded DNA low titers, it indicates that disease is under control. So when you are treating the patient, which antibody titer should be done on every follow-up visit? This is how question will be asked in NEET PG exam. It has already been asked. It can be asked in FMGE. See, you can remember simply correlates with disease activity, double-stranded DNA. But examiner will put question like this: which antibody needs to be checked on every follow-up visit to see response to therapy and whether the disease is active or quiescent? The answer will be anti-double-stranded DNA. Drug-induced SLE is a FMG MCQ. Anti-histone antibodies are commonly seen. So drug-induced SLE, anti-histone antibody. Now, which condition has strong association with lupus nephritis? So according to Harrison 22nd edition, strongest association with lupus nephritis is seen with anti-C1q antibody. Anti-C1q is a complement component against which autoantibody is formed, and about 85% association is seen with lupus nephritis in these patients. So anti-C1q is being used as a biomarker also in established patients of SLE. 𝗘𝗶𝗁𝗁 syndrome, producing recurrent abortion. You will be reading about 𝗘𝗁 syndrome in pathology also, in OBG class also. 𝗘𝗁 syndrome is associated with anti-beta-2 glycoprotein 1 antibodies. You can simply write anti-beta-2 glycoprotein antibody. It is also associated with LAC. What is LAC? Lupus anticoagulant. Lupus anticoagulant. Then neonatal SLE, what are the antibodies? Anti-Rho, anti-La. Anti-Rho, anti-La. रोला. बच्चा अब दुनिया में आया, SLE हो गया. सो रो ले बच्चे, हम ऐसा कहते हैं. तो रो ले नहीं है, रो ला है. So रो and la antibodies are seen in neonatal SLE. ANA will be positive in all of them. Lupus cerebritis and seizures will be associated with anti-glutamate receptor, anti-GD2, in bracket I'm writing glutamate receptor antibodies. Glutamate receptor antibodies. I hope you know that from physiology that there are two types of neurotransmitters, inhibitory and excitatory. Glutamate is an excitatory neurotransmitter, and it is seen that anti-GD2 binds to glutamate receptor and activates it. And excitatory becomes active. What does it do? It causes seizures and inflammation in the brain. So anti-GD2 antibody. Depression and psychosis is associated with anti-neuronal antibody. Remember that cerebritis can have neuronal also, and psychosis patients can have GD2 also. So but they are the ones which are specifically mentioned separately in the textbook. Autoimmune hemolytic anemia, you have anti-erythrocyte antibody. And finally, petechial thrombocytopenia are associated with anti-platelet antibody. You need to understand that not every patient will have all antibodies. These are the autoantibodies, and because different patients have different types of antibodies, so different manifestations of SLE are seen in the patient, right? So different types of manifestations you will be seeing in the patients. I am my own worst enemy. This disease is most applicable. This dialogue is most applicable in a patient of SLE. Now, one-liners. What is the most common pulmonary manifestation is SLE? It is pleuritis, that is inflammation of pleura. Chest pain will be there. Most common cause of death, it is MI, myocardial infarction. Earlier, it used to be lupus nephritis. All these new standard textbooks say MI. Second common cause is infections. And third common cause is thrombosis. So in decreasing order, these are the three causes. The list has slightly changed in the recent years. So you can get a fresh MCQ on this. Fresh MCQ on this. What are the drugs causing SLE? There is a mnemonic of this known as SHIP. SHIPP. Sulfonamides, including dapsone. Dapsone is a type of sulfonamide. Hydralazine, INH, that is isoniazid. It is a anti-tubercular drug. Procainamide, as well as penicillin. Penicillamine, not penicillin, penicillamine. That is D-penicillamine. Some books write phenytoin also as the list. It is actually a very long list, but these are the important drugs which have been asked, and this is pharmacology integration. Then if antiro-antilla is present in a pregnant lady, what will the baby develop? Suppose mother has antiro-antilla in mother can cross over and they can damage the AV node in the baby, leading to congenital heart block. Very, very important. Congenital heart block. And why congenital heart block occurs in SLE related pregnancy? Because there is damage to AV node. Remember, SA node is more resilient. AV node is the one which bichara gets damaged in most of the autoantibody induced damage. So AV node damage will be occurring in these patients. All of them are one-liners and very, very important. This entire page, in fact, is full of previous year questions and possible future questions also. Let us go further, talk about the management of SLE. Now, management is huge, but we will try to simplify, and because it is a revision session, so I will try to write in a way that you can remember it better. First of all, every patient requires photoprotection. So you need to apply sunscreen, you need to, cover the exposed parts, and sunscreen should be a good one, SPF 50 or so. And girls are better in photoprotection compared to men. Now, girls will be, covering their face, covering their glove, they'll be wearing gloves. The typical, as I'm telling it to you, you can imagine, girls going on a scooty, covering their body well. If they're a SLE patient, they can manage themselves well. If a boy develops SLE, it is a big problem because men are very poor in photo protection. Even on a summery day, they will just wear a vest and shorts and go out into the sun. It is just nature which protects them because SLE is a disease of girls. But if it occurs in men, again, men have a lot of flares because men are very poor in photo protection. I'm not being gender specific. It is a praise for the girls that yes, girls are better in photo protection. So whether you are a man or a woman doesn't matter. In SLE, photo protection is very important because sunlight exposure triggers acute exacerbation, that is acute worsening in the patient. And second part will be immunosuppression. You need to suppress the body's own immune reaction against itself. Now, how you will do immunosuppression? Now, it is often very tempting to write prednisolone and hydroxychloroquine, but there is a proper way to write. So we will be writing in a way Harrison wants us to learn. And if you remember like this, you will never forget, and your future MCQs will also be correct. So let us assume the first condition is non-life-threatening SLE. Non-life-threatening means SLE is there, but there are no life-threatening feature. Can you give an example? For example, skin involvement. For example, joint involvement. So in these patients, what is the initial drug of choice? The drug of choice in these patients will be oral hydroxychloroquine. Oral hydroxychloroquine. I'm writing in short, HCQ. That is given on a daily basis, regular basis, sometimes lifelong you need to give as a maintenance therapy. But for any flare means any worsening, you will be adding oral prednisolone in these patients. The duration of prednisolone will depend how long the flare is, how long the worsening is. Flare means a worsening. And you will give prednisolone for about 1 to 2 weeks and then you taper and stop it. And if there is no response, if there is severe or non-responding, then there is a monoclonal antibody you can use in these patients. The name of the monoclonal antibody is belimumab. Belimumab inhibits B cell proliferation. It inhibits B cell proliferation. So it's a inhibitor of BAFF. There is a factor known as BAFF. It inhibits BAFF. It is a B cell proliferating factor which is inhibited by belimumab, right? Now, what if the patient is having life-threatening SLE? Second possibility, patient has life-threatening SLE. The example of a life-threatening SLE will be lupus nephritis. For example, lupus nephritis. What you will give in these patients? First of all, you need to induce remission. Means response should come. So you will induce remission. The disease should come under control. फिर maintain करेंगे. तो remission के लिए क्या दोगे? You will use a combination of steroids. So you will use IV methylprednisolone in all of these patients. And bracket you would write, add cyclophosphamide. When you will add cyclophosphamide? If there is severe renal involvement. For example, if there is class 3 or class 4 lupus nephritis. Remember, I told you the severe forms are class 3 and class 4. So the biopsy findings I told you. So if that is there, you will add cyclophosphamide in these patients. But IV methylprednisolone will be given to induce remission plus minus cyclophosphamide. Two possibilities. If the remission comes, you will switch to oral prednisolone. And slowly you will taper it. And then you will switch the patient to hydroxychloroquine with azathioprine. What is azathioprine? It is another immunosuppressive agent. On the other hand, if there is no remission doesn't come, you will consider biological agents. Two biological agents you can consider. Either you can go for belimumab, the same drug we wrote above, or you can go for rituximab. Try to see the reason we are using it. There is a small concept behind it. Most of the problems in SLE are mediated by autoantibody. End of the day, they are antibody. Antibody is formed by plasma cell. Plasma cell are produced from B cell. So if you want to control the disease process, what antibody you will use? All those antibodies which target B cell specifically. Belimumab targets B cell and rituximab targets B cell because rituximab is anti-CD20 monoclonal antibody. It's a very small concept, will not be asked directly, but ideally when you are preparing for competitive exam, this is the way you should be preparing. So rituximab and belimumab are the ones that you will be using, right? So this covers the summary of what you need to know. This is easier to revise and it covers all the MCQs asked in any competitive exam in SLE in the last 10 years, whether it is NEET PG, FMG or INI set. They can be solved by this summary. This is not a perfect summary, but this covers the major aspects that you need to know as a rapid revision student in the last few weeks. Okay, so remember it, add it to your notes and please read it 2-3 times. ये पढ़ने में अच्छा लगता है, लेकिन you need precision because if a question will be asked, it will not be directly. They will make a scenario and ask you what next needs to be done. So SLE is done. Okay, let's move further. Now we move over to scenarios. Now we can increase the speed a bit. Now easier things will come. Next scenario, adult female, generally slightly older female, 50, 60, 70 years. She presents with symmetrical leather-like skin thickening. There is a scenario question based upon this asked in FMG. There is skin induration. There is contractures in the hands. And there is dysphagia or Raynaud's phenomena. What is Raynaud's phenomena? On exposure to cold, initially the fingers become pale. Then they become blue. And then recovery happens. That is redness occurs. This phenomena is called as Raynaud's phenomena. And there is lung fibrosis or interstitial lung disease. Interesting thing to note, SLE does not have ILD. So if ILD is happening, it is not SLE that we are talking about. So if you have a presentation like this, the likely diagnosis in the patient is scleroderma. Scleroderma is an autoimmune disease where sclerosis of the tissues occurs. It is also known as systemic sclerosis. In short, it is written as SSC. These are the various names of the same condition, that is scleroderma. So if scleroderma occurs, what is the most common type of ILD occurring in scleroderma? It is NSIP. This is something I discussed with you yesterday also. Non-specific interstitial pneumonitis. Full form, full name we have already written. What are the autoantibodies seen in scleroderma? Two types of autoantibodies are seen. See, scleroderma can be of two varieties. Either it is limited cutaneous. Limited cutaneous is the one which is affecting only the peripheries and head and neck. Whereas diffuse cutaneous will be involving the entire body. Limited cutaneous scleroderma is associated with anti-centromere antibody. इसको याद करना पड़ेगा. There is no logic here. You have to mug it up. Diffuse cutaneous is associated with two types of antibodies. It is associated with anti-topoisomerase 70 antibody, also written as SCL70 antibody. And secondly, it is associated with anti-RNA polymerase 3. Anti-RNA polymerase 3 antibody. Anti-RNA polymerase 3 antibody. And what is the most common cause of death in scleroderma? The most common cause of death is ILD. That is why we are talking about ILD. Second common cause of death in these patients is PAH. ILD is interstitial lung disease. PAH is pulmonary arterial hypertension. Okay, so this is the cause of death. What about the treatment of scleroderma? Interesting thing to note, scleroderma is the only connective tissue disorder, autoimmune disease, where steroids do not have a role. I repeat, the only autoimmune connective tissue disorder where steroids do not have a role in management is scleroderma. So what do? We use other agents. So let us talk about the summary of treatment. Now in treatment of scleroderma, in bracket you would write steroids have limited to no role. And in fact, they should be avoided. Why? Steroids can trigger scleroderma renal crisis in these patients. What is scleroderma renal crisis? In these patients, there will be a rapid increase in BP. So malignant hypertension can occur along with fall in GFR, oliguria. So oliguria with massive rise in BP is called as scleroderma renal crisis, which can occur in steroid use in scleroderma. It's very, very important. So what are the therapies that you are going to use? First of all, the most efficacious agent in these patients is always cyclophosphamide. So most efficacious agent is cyclophosphamide. What are the other agents you can use if cyclophosphamide is not tolerated? Others which can be used, they include MMF, full form I told you yesterday, mycophenolate mofetil. You can use azathioprine. And you can also try methotrexate. And what is the biological agent which is useful in scleroderma? There is a biological agent by the name of tocilizumab. Tocilizumab is very important. It is a pharmacology MCQ asked 1 year back in NEET PG. Tocilizumab is anti-interleukin 6 receptor R word miss nahi karna, monoclonal antibody. And second part of therapy will be supportive therapy. तो supportive में हम क्या करेंगे? For Raynaud's phenomena, you will use calcium channel blockers, for example, nifedipine. For ILD, you will be giving antifibrotic agents, for example, nindatinib. I told you the name yesterday also. Nindatinib will be useful. And what if scleroderma renal crisis occurs? What if this crisis occurs? For scleroderma renal crisis, we can use ACE inhibitors. What are ACE inhibitors? Enalapril, captopril, lisinopril, etc. can be used in these patients. So this is the treatment of scleroderma. Interesting thing to note, no role of steroids in scleroderma. Right? Topic is done. Let's move further. 40-year-old woman presents with difficulty in eating due to persistently dry mouth. She also has a gritty sensation in eyes, dental caries, and enlarged lymph nodes. Dry eyes, dry mouth, lymphadenopathy. Which connective tissue disorder will you think of? It is not scleroderma, it is not SLE. Sjogren syndrome is what you will be thinking of. The patient is likely suffering from Sjogren syndrome. So, what is the summary? What are the key points you should remember? That whenever examiner makes a case scenario, the examiner will say 30 to 50-year female, dry eyes, dry mouth, and parotid swelling along with the lymphadenopathy. The likely diagnosis in the patient is Sjogren syndrome. S is silent in these patients, so we call it as Sjogren syndrome. And dry eyes are also known as 𝗘𝗱𝗶𝗁𝗃𝗃 𝗔. These patients have high risk of developing corneal ulcers. So sometimes they will use the word 𝗘𝗱𝗃𝗃 𝗔. So which condition has primary Sjogren syndrome or dry eyes, dry mouth as the primary presenting problem? Among autoimmune diseases, it is Sjogren syndrome. What is the autoantibody? ANA is positive, but it is non-specific. I told you it is never specific. It can occur in multiple autoimmune conditions. Anti-Rho antibody can be seen, but it is anti-Rho 52 specific antibody and anti-La antibody. They are found to be more specific in such patients. They are more specific in such patients. What is the most common cause of death in Sjogren syndrome? It is lymphomas. Which type of lymphoma is common? Marginal zone. Marginal zone B-cell lymphoma. Lymphoma is the cause of death. Remember, which connective tissue disorder? Lymphomas are very common. Sjogren syndrome, they are very common, and it is the cause of death as well. Treatment in these patients. Treatment has two parts. First of all, you will do supportive immunosuppressive therapy, immunosuppression. For immunosuppression, your drug of choice will always be oral prednisolone. So steroids will be indicated. Other drugs, if steroids are not to be used, you can go for 𝗍𝗗𝗏𝗄𝗏. And because B cells are involved, B cell lymphomas are common, which antibody will be useful? You tell me. Which autoantibody will be useful? I've already told you the funda behind it. Rituximab can also be used. Good. I hope you have understood the funda. Rituximab is anti-CD20. CD19, 20, 21, 22 are present on B cell. CD1 to 8 are present on T cell. Right? So rituximab will be useful. Apart from that, you will be giving symptomatic therapy, supportive therapy. As a part of supportive therapy, in the eyes, because dry eyes are there, you will put 0.3%, 0.5% methyl cellulose drops. Methyl cellulose drops. 0.5% methyl cellulose drops. And secondly, for dry mouth, you will be using an agent known as cevimeline. Or you can go for 𝗘𝗱𝗶𝗁𝗏. Both of them increase saliva production. So cevimeline or 𝗘𝗱𝗶𝗁𝗏, they are called as secretagogues. Secretagogues means they will be increasing the therapy. Why not belimumab? Data does not say. So when you say ki why not this drug, studies have not shown it to be effective. Simple thing, right? हम जनरलाइजेशन खुद बना सकते हैं, लेकिन ह्यूमन बॉडी जनरलाइजेशन से नहीं चलती. ह्यूमन बॉडी को ट्रीट अगर करना है तो हमें एविडेंस चाहिए. SLE अलग डिजीज है, स्क्लेरोडर्मा अलग डिजीज है, और जॉगरन सिंड्रोम अलग डिजीज है. तो कुछ डिजीजेस, कुछ ड्रग्स कॉमन होंगे, लेकिन उनका मैकेनिज्म ऑफ एक्शन एंड रिस्पॉन्स जो रहेगा वो अलग अलग रहेगा. ये क्वेश्चन मुझे MBBS में भी सुनने को मिलता है, MD में भी सुनने को मिलता है. सुपर स्पेशलिटी के स्टूडेंट्स होते हैं, वो भी पूछते हैं, सर ये ड्रग क्यों नहीं देंगे? इसका सिंपल सा रीजन है, जब स्टडी किया गया तो ड्रग इफेक्टिव नहीं पाया गया, इसलिए नहीं देंगे. In other words, if a drug is used, it has been found to be useful, benefits outweigh the risk, and safety data is available. As simple as this, right? This is the blanket statement. If you ask me 10 years later when you are doing super specialty, and I will have probably some gray hair at that time, you will ask me the same question, my answer to that time will also be the same. Okay? So this is the summary of Sjogren syndrome. Let's move further. Rheumatoid arthritis. Rheumatoid arthritis, name itself is saying arthritis, but it is an autoimmune disease. It is a chronic inflammatory disease characterized by a symmetric polyarthritis. Symmetric polyarthritis means both sides of the body joints are involved, and there are extra-articular manifestations which are seen. Remember, extra-articular manifestations are seen in 40% patients. So almost 40% patients have not only joint involvement, other organs also show inflammation. What is the most common HLA association in these patients? The most common HLA association is HLA-DR4 as well as HLA-DRW1. If you have to choose one, the strongest association has been found with HLA-DR4. HLA-DR4 followed by HLA-DRW1. Okay. So HLA-DR4 followed by HLA-DRW1. These are the HLA associations. Moving further, what are the autoantibodies that you will see? There are two types of autoantibodies you will find in rheumatoid arthritis. Most sensitive antibody of rheumatoid arthritis is anti-CCP. Anti-CCP. CCP stands for cyclic citrullinated peptide. Cyclic citrullinated peptide antibody. Anti-CCP antibody is the most sensitive antibody. It is seen in 85 to 90% patients. Less sensitive but still done is RF. What is RF? Rheumatoid factor. Rheumatoid factor is, the full form is rheumatoid factor. This is not specific for rheumatoid arthritis. It has a sensitivity of only about 70%. And rheumatoid factor क्या होता है? IgM antibody. It is IgM antibody against Fc portion of IgG. Antibody against antibody is called as rheumatoid factor. So these are the antibodies that you need to know. Anti-CCP, cyclic citrullinated peptide, is an antigen found on the inner surface of synovial membrane, and the antibodies against it mediate rheumatoid arthritis. What is the most common joint involved? Two joints are almost equally involved. You have the proximal interphalangeal joint, proximal IP joint, as well as metacarpophalangeal joint. But which joint is spared? Distal interphalangeal joint is generally spared. And most common tendon involved is flexor pollicis longus tendon. Flexor pollicis longus tendon. So flexor pollicis longus tendon is the most common tendon which is involved. Now, a lot of questions are asked, spotter images on the deformity produced and identifying it in rheumatoid arthritis. First of all, many patients look at this image, look at this page, and we will also have a look at the image side by side. So first deformity which occurs in rheumatoid arthritis is rheumatoid hand. There will be ulnar deviation of all the fingers. It is also called as ulnar hand or rheumatoid hand. So rheumatoid hand will look something like this. Can you see there is a ulnar deviation of all the fingers? They show like this. It is ulnar drift or rheumatoid hand seen in rheumatoid arthritis. Second feature will be hitchhiker thumb, also called as Z thumb deformity. What is hitchhiker? You have to ask for lift. How do you do? That is hitchhiker thumb. See, what happens in these patients is this is adducted thumb. This is abducted. So thumb is abducted and the distal part is hyperextended backwards like this. This is called as hitchhiker thumb. The distal part is going hyperextended. You need to understand the important aspect here. Arthritis does not involve DIP joint. I repeat, arthritis does not involve DIP, distal interphalangeal joint. But deformity can involve distal interphalangeal joint. Why deformity can occur if no arthritis? Because the tendons attached there can be involved. So it's a very interesting funda, and it is generally taught in medical colleges at MBBS level. I'm quite sure your medicine teacher would have told you this. If not, listen to this funda again. Which joint is not involved due to arthritis in rheumatoid arthritis? It is distal interphalangeal joint. But can deformity be produced here? Yes. The reason for deformity is not the joint involvement, but because of the other tendons and contractures and other things which are happening around this area. Okay, so these are two small little things that we can remember. Third is piano key deformity. Piano key deformity occurs on the ulnar aspect on dorsum. There will be tenosynovitis of extensor carpi ulnaris, which leads to prominence of the ulnar styloid process. Have a look here. This is piano key deformity. Can you see this particular deformity? This particular ulnar styloid process area becomes unduly prominent. So keep these photos in your mind. First is ulnar drift or rheumatoid hand. Second is hitchhiker thumb. Thumb is abducted and distal part of the phalanx is hyperextended. It is going backwards. And third is piano key deformity due to extensor carpi ulnaris involvement. Then fourth deformity is mallet finger. T is silent, mallet finger. Only flexion occurs at distal interphalangeal joint. This is mallet finger. Then we have swan neck deformity. Why do we call it as swan neck? Because the patient's fingers, the fingers of the patient look like a swan. To explain, it is looking like a swan. And that is why it is called as swan neck deformity. Swan neck deformity and boutonniere deformity are often mistaken by students when questions are asked. To remember the deformity in swan neck, you can remember the funda 𝗘𝗱𝗶𝗁. Swan neck deformity is 𝗘𝗱𝗶𝗁. So extension at proximal interphalangeal joint and flexion at distal interphalangeal joint. That is all you need to know. Reverse of this, reverse of swan neck deformity is boutonniere deformity. So my advice to you is only remember swan neck deformity. If boutonniere deformity gets asked, you reverse what we read in swan neck deformity. So now you will have extension at the distal interphalangeal joint and flexion at the proximal interphalangeal joint. That is called as boutonniere deformity, right? So these are the deformities which are produced. Photo can be asked, description can be asked, or close options can be asked. I'm putting a big star here. Very, very important. Even if you may know well, you are supposed to revise it close to the exam as well. So they are often asked in the exam. So this is your types of deformities. Now, I told you extra-articular manifestations, they can be seen in up to 40% of rheumatoid arthritis patients. What are the extra-articular manifestations? Patients can develop rheumatoid nodule. What are rheumatoid nodules? They are painless nodules which typically occur on extensor surfaces. So you can label extensor surfaces. Extensor surface क्या होते हैं? Back of the dorsum of the hand. They can occur on dorsal surface of the arm. They can occur on the elbow. They can occur on the shin bone, and they can occur on the back. So they will occur on the extensor surfaces. And it is considered to be the most common extra-articular feature. Second is secondary Sjogren syndrome. Primary Sjogren syndrome is a standalone disease. Can dry eye, dry mouth, mimicking Sjogren syndrome be produced in any other condition? Yes, it can be a feature of rheumatoid arthritis. So you can highlight secondary Sjogren syndrome. Reason is rheumatoid arthritis. What is the most common cause of death in rheumatoid arthritis? It is myocardial infarction. Inflammation happening in rest part of the body. Who's dying? Don't be like heart. Heart is a very fragile organ. Yes, it is important. And a lot of poetry has been written on heart. But let me tell you, heart is a very fragile organ. It's a very useless organ. Like it is useful, no, but useless in a very different way. Like, you say useless in the way that कुछ मतलब उसके अंदर resilience ही नहीं है. Think of liver. इतना डैमेज होता है उसके बाद भी रीजनरेट कर जाता है. What about heart? पोटेशियम 5.2 हुआ, अरिथमिया हुआ, डेड. SLE हुआ, what is the cause of death? Heart attack. Rheumatoid arthritis हुआ, what is the cause of death? MI. We will see many other conditions. Disease happening elsewhere. Who's dying? Heart. So when life makes you an internal organ, don't be like heart. Be like liver. Resilient, strong, adapting, and ability to regenerate. And transplantation also possible. Heart transplant, again, it's more of a theoretical thing. It does happen, but again, not as good and as popular and as possible as liver transplant, right? So most common cause of death in RA, MI. What is 𝗘𝗱𝗶𝗁 syndrome? 𝗘𝗱𝗶𝗁 syndrome is a triad of three things. It is a triad of three things. So 𝗘𝗱𝗶𝗁 syndrome, what is 𝗘𝗱𝗶 syndrome? It is a triad of three things: rheumatoid arthritis, splenomegaly, and neutropenia. Splenomegaly and neutropenia. Which is more specific for RA? Anti-CCP is more specific. Not only sensitive, specific also CCP. Both sensitive and specific if they ask. It is anti-CCP. Okay. Management of rheumatoid arthritis. What is the management we are going to do? First of all, you will do pain relief. So for pain relief, what you will be giving? You can use non-steroidal anti-inflammatory drugs or aspirin. And you can also try, plus minus, you can try colchicine derivatives. Colchicine derivatives can be used. Second is disease-modifying anti-rheumatic drugs. DMARDs. What is DMARDs? DMARDs stands for disease-modifying anti-rheumatic drugs. The most commonly used drug is methotrexate. The most commonly used drug is methotrexate. If methotrexate fails or it is contraindicated, you go for hydroxychloroquine plus minus combined with leflunomide. This particular thing is important, and there is a case scenario asked in INI set exam. The case scenario was a patient with rheumatoid arthritis was started on methotrexate along with non-steroidal anti-inflammatory drugs, but there was inadequate response. What is the next step in management? One of the option was start biological agents. Another option was add hydroxychloroquine with leflunomide. That is your answer. Okay. So first you give a trial of the more easily available biological agents, then you move further. And third, if these also fail, if DMARDs are not working, severe rheumatoid arthritis, biological agents will be used. Now, what are the common biological agents which can be used? In these patients, you can go for anti-interleukin 1 drugs For example, anakinra can be used. Second, you will go for anti-interleukin 6 R, that is receptor. Example, I just told you the drug, tocilizumab can be used. Tocilizumab can be used. Third, you can go for anti-TNF alpha. Typical example for that is infliximab, that can be used. And fourth, you can use anti-interleukin 17 alpha. The drug is ustekinumab. So if you see this condition, the biological agents we are using are different. Rituximab is not useful in these patients for the simple reason that B cell activation is not the primary disease process. It is just a bystander effect which is happening. And so you need to target the T cell mediated or interleukin 1, 2, and 17 alpha pathways. For that, we need these biological agents. So rituximab is not commonly used in patient of rheumatoid arthritis, right? And what about the role of steroids? You can write on the side, steroids are useful as bridge therapy. What is the meaning of bridge therapy? I'm not writing the detail, you just need to understand this funda. Bridge therapy means any DMARD if you start or biological agent you start, they take about 1 to 2 weeks for action to come. So what if the patient is having severe inflammation? So steroids are given for that temporary period in between, so that till the time of DMARDs and biological agents come into play, you can give some cover to the patient. And that is why steroids are not used regularly, but they are used as bridge therapy. So जहां पर भी word मिले bridge therapy, we are talking about steroids, intermittently used, small period we are using till the effect of the actual drug we are targeting comes into play, right? That is how we are going to treat using steroids in these patients. Okay. Now, moving over to gout. Quick summary. Gout is associated with what underlying condition? It is a severe inflammatory condition of the joints of the foot, which is associated with underlying hyperuricemia. Hyperuricemia. So gout associated with underlying hyperuricemia. In hyperuricemia patients, due to a variety of reasons, sometimes triggers, sometimes unknown reason, there is deposition of MSU crystals in the joint. What are MSU? Monosodium urate crystals. Monosodium urate crystals. And how do they appear? These crystals appear as needle shaped. These words are important. There is an MCQ on this. Needle shaped, negatively birefringent. Needle shaped, negatively birefringent crystals in the synovial fluid. They are seen best by what? They are seen best by polarized microscopy. So on polarized microscopy, they are seen. So remember this funda that if there is a needle shaped, I'm just zooming out a bit. If there is needle shaped crystals, it is MSU crystals seen in gout patient. But if there are rhomboid crystals, then they are CPP crystals, calcium pyrophosphate crystal, indicating pseudo gout in the patient. So two types of MCQs can be asked. Needle-shaped crystals are monosodium urate, gout is the diagnosis. Rhomboid crystals in synovial fluid, rare disorder, pseudo-gout. These crystals are composed of calcium pyrophosphate. Calcium pyrophosphate. These are the crystals which are seen. What is the most common joint affected? The most common joint affected in these patients is the first metatarsophalangeal joint, first MTP joint. And the first MTP joint is swollen, that is called as podagra. There is severe pain. This pain is nocturnal in nature, and overlying skin is also inflamed, causing pseudocellulitis. Remember that gout is a condition which is more common in males compared to female. Abhi tak humne most of the conditions we have read today, SLE, rheumatoid arthritis, scleroderma, Sjogren syndrome, more common in female. This condition is more common in males. And it is a very, very painful condition, affects the first metatarsophalangeal joint in the patient. And recurrent attacks lead to permanent deformity and tophi deposition leading to a sign known as Martel sign. So remember, Martel sign is not a sign of acute gout. It is a feature of chronic repeated episodes of gout in the patient. So deformity produced, bone erosions produced, and tophi deposition in the subcutaneous region is called as Martel sign. तो मार्टल साइन में पेन नहीं होता है. मार्टल साइन इज अ पेनलेस कंडीशन. Podagra is a painful condition. Remember the word podagra is acute gout. Martel sign is chronic gout. It is not a acute gout. Small little thing you need to remember. What is the treatment of gout? Treatment has two parts. First of all, you have to do the pain management. First, you have to do the pain management. For pain management, you have to avoid aspirin because aspirin can lead to deposition of more crystals in the joint. You can use endomethacin, that is non-steroidal anti-inflammatory drugs, plus minus colchicine derivatives, and very severe cases, you can use a short course of steroids also. You can use a short course of steroids also. Second is management of hyperuricemia. Management of hyperuricemia. Remember that management of hyperuricemia is always done after acute attack is over. क्योंकि अगर ये the drugs which are used to lower the uric acid level, if you start them early during the acute gout, actually the acute attack becomes more severe. So always started after the acute attack is over. Generally, it takes about 7 to 10 days. And after 7 to 10 days, the acute attack is over. Pain is gone. Now you start management of hyperuricemia. Now, for hyperuricemia management, there are two types of patients you can use. If the patient is overproducer of uric acid, then the drug of choice in these patients, in fact, the first line drug is always allopurinol. What is allopurinol? Allopurinol is a xanthine oxidase inhibitor. It is a xanthine oxidase inhibitor. And second line drug is generally febuxostat. Febuxostat. Remember that rasburicase is rarely used in hyperuricemia, and it is more commonly generally it is reserved for use in another condition known as tumor lysis syndrome. When you will be reading oncology, you will be reading about tumor lysis syndrome. वहां पे rasburicase use होता है. So first line agent is always allopurinol. Second line agent is febuxostat, right? And what if the patient is under excretor of uric acid? If patient is under excretor, some patients के अंदर the problem is the renal function is normal, but only uric acid is not getting excreted properly. In these patients, we will add a drug which prevents reabsorption and enhances renal excretion of uric acid. So the drug used in these patients is probenecid. It can be used orally, and oral probenecid is the drug which is used in these patients. And is there a new drug? I'm putting a star here. Harrison update, new IV drug to lower urate levels. To lower urate levels. It was recently approved for use. It is 𝗘𝗱𝗏𝗂𝗋𝒾𝑠e. 𝗘𝗱𝗏𝗋𝒾𝑠e. What it does is it converts the uric acid into allantoin. This allantoin is water soluble and it is excreted from the body. It is excreted from the body. So 𝗘𝗱𝗏𝗋𝒾𝑠e is the new drug which has been added. So you need to add this new drug in these patients. The topic is done. Gout topic is done. Let's move further. Ankylosing spondylitis. Now, ankylosing spondylitis is again a condition which is more common in males compared to females. So this is a condition which is associated with males compared to female. Strongest association of ankylosing spondylitis, it's a MCQ point already asked in FMGE exam, 𝗘𝗱𝗶𝗁. Strong association is seen with 𝗘𝗱𝗶27. Males are more commonly affected than female. Age of onset is generally 20 to 40 years. So age of onset is 20 to 40 years. Ankylosing spondylitis also associated with other associations of ankylosing spondylitis include psoriasis. There is a skin disease known as psoriasis. It is also associated with inflammatory bowel disorder. It is associated with uveitis. Rarely it may be associated with aortic regurgitation as well. So these are the associations for ankylosing spondylitis. What will X-ray spine show? Various types of X-ray findings have been described. Initially, the patient presents with squaring of the vertebra. Later on, long-standing cases, the entire vertebral column becomes stiff. It produces the so-called bamboo spine. Photograph of bamboo spine you must have seen already in your radiology class, and you will be reading about it as well. Bamboo spine is a one-liner question of ankylosing spondylitis. Schober's test is a classical test done to check the stiffness of the spine, but these days it is no longer done because the test only checks the stiffness. It doesn't tell you the reason for stiffness of the lower back. But yes, you can say that historical test, I will write like this, historical test which was done for ankylosing spondylitis was modified Schober's test. Modified Schober's test. It only checks for the stiffness of the lower spine. Modified Schober's test is the one which is done. Now, what is the treatment in these patients? Treatment has two parts. First part will be, so treatment of choice in these patients, first of all, for pain relief, for analgesia, you will be giving non-steroidal anti-inflammatory agents, and you will be combining it with physiotherapy. So physiotherapy targeting lower back will be needed. And second will be use of biological agents. Which biological agents can be used in these patients? TNF alpha inhibitors can be used. For example, TNF alpha inhibitor, I'm writing TNF alpha I. That is the short form of writing TNF alpha inhibitor. For example, infliximab can be used. And some patients benefit from anti-interleukin 17 antibodies, for example, ustekinumab. So, ankylosing spondylitis is done. And then we come to sarcoidosis. There was a case scenario question asked in July 25 FMGE exam. It was a very simple question actually. I will summarize in the end. So, case question scenario asked in July 25 medicine part. It was a case scenario, 3-line long question which was asked in medicine this time. So what is sarcoidosis? Sarcoidosis is a granulomatous condition. It is an inflammatory condition where non-caseating granulomas form in various organs. The cause is not clear. Many theories have been given and many triggers have been identified. So sarcoidosis क्या है? Granuloma formation in the tissue. These are non-caseating granulomas, and these non-caseating granulomas have the ability to synthesize vitamin D. And this vitamin D, because it is on the higher side, it has a tendency to cause hypercalcemia. Hypercalcemia. The question asked in July 25 was something like this. I have not written here. Listen to the question. There is a middle-aged patient who's having some lesions in the body. He has features of hypercalcemia, but no exogenous cause is identified and parathyroid hormone levels are normal. Which of the following condition can produce this picture? One of the option was sarcoidosis. All the other three options were not the answer. One of them was parathyroid adenoma. Obviously, that will be ruled out because parathyroid hormone levels are not. So the answer, logical answer in the question was sarcoidosis. All you need to know is one granulomatous inflammation where vitamin D is produced by the granuloma cells and leading to hypercalcemia, that is sarcoidosis. What is the most common infectious trigger of sarcoidosis? The most common infectious trigger of sarcoidosis is Propionibacterium acnes. Propionibacterium acnes. Earlier, we used to think that Propionibacterium acnes only causes acne in adolescent. This is true, but this is also a wolf hiding in the garb of a sheep. भेड़ की खाल में भेड़िया. We now know that Propionibacterium acnes in adults can be a trigger of sarcoidosis in predisposed individuals. It's a very important point, can be asked as a fresh MCQ, and Harrison gives a lot of time talking about how and the mechanisms which are involved in this. Clinical manifestations. Let's go one by one. Most common involvement is lung involvement. There will be hilar lymphadenopathy at both the hilum of the lungs, and that will obstruct the bronchus. These patients will have cough and dyspnea. This occurs due to hilar lymph node enlargement. Skin involvement is seen in 24% patients. These patients can have two types of skin manifestation. Either they can have erythema nodosum. This is a dermatological condition I'm quite sure you will be reading in derma class. Or they can have lupus pernio. These are purple papules, purple colored papules occurring on the face. Remember the funda. Lupus is SLE. Lupus pernio is sarcoidosis. Right? Lupus pernio is sarcoidosis. Don't get confused. Lupus vulgaris is tuberculosis. You will be reading about all these in the upcoming sessions as well. So erythema nodosum, lupus pernio are the skin manifestation of sarcoidosis. Third, parotid gland can have granuloma formation, so it can get enlarged, and palsy occurs of seventh cranial nerve. Which nerve passes through the parotid gland, dividing into its branches? It is seventh cranial nerve. So facial palsy can occur. What are the investigations? Twice MCQs have been asked. So there will be hypercalcemia and raised levels of enzyme known as ACE. What is ACE? Angiotensin converting enzyme. It does not play a role in the disease, but it acts as a marker. Its levels are increased in the blood. Right? And chest X-ray shows what? Look at this photograph. Can you see that there is bilateral hilar lymph node enlargement? This part and this part. This is lymph node enlargement which is happening. So there is bilateral hilar LAP. LAP is lymphadenopathy, and these patients you find there is eggshell calcification. So what you find in the patient is eggshell calcification. Eggshell calcification. And what will HRCT test show? HRCT test will show the presence of a sign known as galaxy sign. Look at this. This is the part where granuloma is there and a lot of calcification is happening. If I zoom it, it is looking something like a galaxy. So this is the so-called galaxy sign. This particular thing is called as galaxy sign. It is seen on HRCT chest. What is the test we do? Bronchoalveolar lavage fluid analysis. And bronchoalveolar lavage fluid analysis will show CD4 cell by CD8 cell ratio. It will be more than 3.5 ratio 1. And there is an MCQ asked on this as well. So you put some fluid through bronchoscope and then take it out and you check the CD4 by CD8 ratio. It is more than 3.5 ratio 1 in these patients. Yes, Garland sign has also been described. And what is the investigation of choice? It is tissue biopsy. Which tissue is taken? Lymph node biopsy is generally taken. And that will show granulomas. And these granulomas, non-cystic granulomas, will have vitamin D producing cells. What is the treatment? Drug of choice in all these patients is oral prednisolone, that is corticosteroid. What are the second line agents you can use? You can go for hydroxychloroquine and you can go for methotrexate. And in refractory patients, you can go for infliximab. Okay, some of you are asking me about gallium scan. Gallium scan as well as Queem's test. Queem's test. They both have been described in sarcoidosis, but they are less commonly done clinically these days. They are less commonly done. They are the the scans which have been described. They are the tests which have been described, but they are not very commonly done these days, and that is why we are not talking about it. Okay, so the topic is done. Sarcoidosis is done. So dermatomyositis, what are the things that you need to know? Dermatomyositis, first of all, which gender it will be more common? It will be more common in females compared to males. So female more compared to males. And the peak age for dermatomyositis, what is the peak age of Samantha? It is about 36 or 37. So peak age is again the same. It is 30 to 50 years. So more common in females compared to males. So dermatomyositis, it is an autoimmune inflammatory disorder predominantly affecting muscles and skin. Now, what is the skin involvement? 5 types of skin involvement is seen. First of all, these patients can have purple colored rash on the upper eyelid. We call it as heliotrope rash. Some patients can develop these scaly lesions on the knuckles. They are called as Goutron papule. Some patients can have photosensitivity and erythema on the sun-exposed parts. What are the sun-exposed parts? This neck region and this V region, which is forming in the front. So we call it as V sign. In the back, this erythema is there. So we call it as shawl sign. And some patients can develop small dilated vessel and occasional ulcer around them. These are nail bed telangiectasia. Photograph as well as these lesions. You need to remember the name and you need to. So skin involvement is seen in 99 to 100% patients. And this is considered the hallmark of dermatomyositis. Second is muscle involvement, which is seen in about 90% patients. So both occur together, so we call it as dermatomyositis. But out of the two, which is more common and generally the presenting part, it is skin involvement. What about muscle involvement? It typically involves the proximal muscles symmetrically. So there will be muscle weakness along with raised CK enzyme in the blood. Plus, many patients can have Gower sign positive as well. I hope you know that Gower sign has been described for Duchenne's muscular dystrophy. Can it occur in some other condition? Yes, it can occur in dermatomyositis as well. So symmetrical muscle weakness. I hope you know that these muscles and the hip muscles are proximal, finger muscles are distal. So proximal muscles are involved. That means they have difficulty in raising their hand above the head and they have difficulty in climbing up and down the stairs. What are the complications which can occur? Interstitial lung disease can occur and carcinoma ovary can occur in the patient. Carcinoma ovary can occur in the patient, right? What are the investigations that you will do? First of all, the serum CK will be elevated in 70 to 80% patients. ANA is positive but non-specific. Specific autoantibodies. 3 autoantibody names you need to remember. Anti-MDA5 is positive. Second is anti-MI2 is positive. And third is anti-TIF. They are the specific antibodies found in these patients. What about anti-Jo1 antibody? There is another antibody known as anti-Jo1. It is rare but seen. Anti-Jo1 antibody, Jo1, JO1. It is rare but seen if patient has mechanic hands. What are mechanic hands? Rough hands, calluses, scaly lesions in the hand are called as mechanic hand. So this is something you can remember for future exams also. It's a very, very interesting and important thing. Right, it is there in your notes also. And what about gold standard investigation? It is always muscle biopsy. What is the treatment that you will do? Now, treatment in these patients, drug of choice is always corticosteroids, oral prednisolone. Second line drug, the 2 M's you can use. Either you can go for methotrexate or you can go for MMF. What is MMF? Mycophenolate mofetil. And if it is refractory, you can either use biological agents. For example, rituximab can be useful here. Or you can give a trial of IVIG. What is IVIG? Intravenous immunoglobulin. The only autoimmune disease in which IVIG is useful is dermatomyositis. It's very, very important, and IVIG has been given in many refractory patients with good efficacy. It's a mixture of antibodies. It's a blood product. It is commercially available. It has immunomodulatory properties. So trial of IVIG can be given in these patients. So this finishes our discussion of dermatomyositis. And we move into the small but important world of vasculitis. It's a big world of its own, but we are keeping it small and discussing only the relevant parts because there is a huge overlap with pathology. I will discuss some relevant parts of pathology, but my focus will remain on the clinical aspects, that is medicine. So what is vasculitis? Vasculitis refers to inflammation of the vessel wall, that is called as vasculitis. Vasculitis can be primary or it can be secondary. The primary vasculitis is the one where no cause is found, and primary vasculitis is divided according to the size of the vessel. So if you have large vessel vasculitis, Then we have medium vessel vasculitis, small vessel vasculitis, and variable vessel vasculitis. So let's discuss some examples. Large vessel vasculitis will be involving the aorta and its branches. So large vessel vasculitis, aorta and its branches are involved. So two example, Takayasu and giant cell arteritis. Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis includes visceral and muscular arteries. It includes PAN and it includes Kawasaki disease. Kawasaki disease. Refractory means something which is not responding to first and second line therapy. Usual therapy, something does not respond, we use the word refractory. Third is small vessel vasculitis. Small vessel vasculitis will involve small vessels like arteriole, venule, and capillary. It is of two subtypes. You can have immune complex associated vasculitis. The typical example is HSP, Hanoch-Schönlein purpura. It's a pediatric vasculitis. And second is ANCA associated small vessel vasculitis. Example is GPA, MPA. Details of this full form we will be writing separately. And finally, we have variable vessel vasculitis. The example for this is Behçet syndrome, also known as Behçet's disease. Behçet syndrome or Behçet disease. Now, can there be secondary vasculitis? Yes, a huge list of causes is there. Two are important and they are asked in the exam. Both of them are NEET PG and INISET MCQs. So I'm putting Qs on top of them. Hepatitis B, chronic hepatitis B virus is associated with which vasculitis? PAN, polyarteritis nodosa. Polyarteritis nodosa. And hairy cell leukemia, it's a malignancy which can lead to which vasculitis? Again, polyarteritis nodosa. Remember, PAN can be primary vasculitis, PAN can be secondary. If it is secondary, what are the two causes? Chronic hepatitis B virus, you can write like this, chronic hepatitis B virus, and malignancy. Which malignancy? Hairy cell leukemia is the malignancy. Let us discuss this in a scenario format, one by one. So first of all, we'll be starting with first scenario. Only the important scenarios I'm discussing. Scenarios which have not been asked in NEET PG or FMG, I am excluding them. Reason is very clear. We don't have the time. If you have time, more scenarios, more topics you should read. But these are the ones which have been asked in the previous year topics. So let us look at the first scenario. Examiner will say age more than 50 years, fever, high ESR and CRP. So something inflammatory. एक तरफ का unilateral severe headache will occur. There will be pain in the scalp. Even the overlying scalp will be painful. Claudication of jaw and tongue will occur. Very, very important. What is claudication? Pain on exertion is called as claudication. It is like angina. When you do exertion, you have chest pain. That is angina. So angina-like pain in the calf muscle, in the skeletal muscle, in the smooth muscle, in jaw, in tongue, that is called as claudication. What it means is if somebody chews a lot, speaks a lot, there will be pain in the jaw and in the tongue. You take rest for some time, you take Maun Vrat for some time, the pain goes away. This is a very important phenomena. So claudication of jaw and tongue. And there will be, when you palpate, there will be a tender cord-like तार के जैसा vessel will be palpable on one side where the pain is happening. This is a patient of temporal arteritis. This is a patient of temporal arteritis. Temporal arteritis, right? Also known as, yes, giant cell arteritis. Giant cell arteritis. And what is the most common vessel involved? It is superficial temporal artery. Superficial temporal artery. Apart from that, it can involve the other branches of ECA. What is ECA? External carotid artery. Other branches of external carotid artery can be involved. There is a risk of developing blindness in these patients if involves the ophthalmic artery, because many of these branches of ophthalmic artery are end branches to the retina. And what is the treatment that we give? It requires biopsy. You will do biopsy, you will find inflammation and giant cell formation in the biopsy sample. Treatment in these patients. Drug of choice is prednisolone. Prednisolone. You can give a trial of methotrexate in them. The biological agent which is approved for use is tocilizumab. The biological agent which is approved for use is tocilizumab. Right, so this is the first scenario in vasculitis. Let's move further. Second scenario in vasculitis, age 30 to 50 year, female more than male. It is a younger age slightly. Loss of radial pulse or femoral pulse means a large vessel is getting occluded and claudication occurs on arm and leg. Remember the keywords. This is very, very important. Claudication, see, headache and claudication of jaw and tongue is giant cell arteritis. It is temporal arteritis. Claudication of arm and leg means when you move the arm or when you move the leg, there is pain. You take rest, it goes away. And radial pulse and femoral pulse are missing on the affected side. It indicates a large vessel is getting obstructed. Subclavian arteries are getting obstructed. Aortic branches are getting affected. This is a patient with, what is the diagnosis? Yes, it is Takayasu arthritis. Takayasu arthritis, also known as aortoarthritis, because it involves the large aortic branches. It is also known as pulseless disease. Pulseless disease. What is the most common vessel involved? It most commonly involves the subclavian artery. Second, commonly, it involves the common carotid arteries. And thirdly, it can involve the descending aorta itself. This is the list based upon the table given in Harrison. What is the treatment? Obviously, the treatment will be steroids. And many patients, if the complete occlusion happens, you need to perform bypass surgery as well. So let's move further. Third scenario. This scenario is one of the favorites of FMG as well as NEET PG as well as INI set exam. So till you keep giving exam, this scenario and variations of this scenario will keep getting asked. Age 30 to 50 year, female more than male, granuloma formation is always there, and triad of three things: upper respiratory involvement, for example, sinusitis, nasal polyp, otitis media, recurrent sore throat, upper respiratory involvement. Lower respiratory will also be involved. So pneumonia-like involvement, hemopsis, decreased SpO2, lower respiratory involvement. And third will be kidney involvement, glomerulonephritis, in bracket I'm writing acute nephritic syndrome. Acute nephritic syndrome. If you have a presentation like this, the patient is likely having GPA. What is GPA? It is granulomatosis with polyangiitis. Granulomatosis with polyangiitis. So granuloma formation will always occur. It was previously known as Wegener's granulomatosis, but this term is not used anymore because later on it was found that Wegener was a person who was involved in Nazi activities. Like, this is the theory, and so the name was changed. This is the more popular theory. The actual thing is they just changed the nomenclature of entire vasculitis, and so this was the new name given. And these patients, not all, but some patients can have, if you look at their oral cavity involvement, oral finding, you will find strawberry gingivitis. So strawberry gingivitis or strawberry gums will be seen in granulomatosis with polyangiitis. Which is the most common autoantibody involved? It is 𝗘𝗈𝗁𝗃, which is found in a lot of these patients. 𝗘𝗈𝗃 positivity, MCQ. 𝗘𝗈𝗃 is also known as anti-PR3, proteinase 3 ANCA. This is the other name for these patients. So 𝗘𝗈𝗃 means cytoplasmic anti-neutrophil cytoplasmic antibody. It is also known as anti-PR3 ANCA. Is the alternative name. Very, very important. And what is the treatment? What is the treatment in these patients? First line therapy. For induction of therapy, we start the patient on steroids with cyclophosphamide. Steroids with cyclophosphamide. Alternatively, if the patient is not responding, you can go for rituximab directly as well. And then for maintenance, see, maintenance के लिए steroid नहीं देंगे. You will be shifting the patient to MMF. You can shift the patient to azathioprine. They can use singly or in combination, or you can go for 6 monthly rituximab also. 6 monthly rituximab can also be tried in these patients. So there are a lot of questions asked on this, and some tricky questions are also asked. If you're active on the Telegram group, there was a INISET style question, modified INISET question on this particular thing I had posted some days back, and there is also an audio explanation. So once this class will be done, just have a look at that question and see if you can answer it correctly or not, right? So this is GPA, granulomatosis with polyangiitis. Now remember the important thing. If they say upper respiratory, lower respiratory and renal involvement, GPA. If they say no upper respiratory, no granuloma, but lower respiratory with nephritis, then it will go in favor of MPA, that is microscopic polyangiitis. So 30-year-old female presented with recurrent episodes. Now see the question, read the question. Recurrent epistaxis, rhinorrhea. So recurrent epistaxis and rhinorrhea, what does it indicate? Upper respiratory involvement. There is hemopsis with cavitary lesions in lungs, lower respiratory involvement. And what is the third thing we are seeing? Intermittent passage of cola-colored urine. Cola-colored urine is gross hematuria, renal involvement. So what is the likely diagnosis? 30 to 50-year female, triad completed. This is GPA. What antibody will help you in diagnosis? The answer is 𝗘𝗱𝗶𝗁𝗃. 𝗘𝗱𝗃. Okay, next question. Age 30 to 50-year, female more common than male. Now see the interesting thing. It is like GPA, but upper respiratory not involved, granuloma not seen. What is seen? Lower respiratory involvement in the form of hemopsis due to alveolar hemorrhage and glomerulonephritis. What do we call it as? We call it as quasi-immune glomerulonephritis. This is the picture fitting into MPA. What is MPA? Microscopic polyangiitis. Microscopic polyangiitis. So microscopic polyangiitis. What is the autoantibody seen in these patients? It is 𝗃𝗀𝗃𝗃 which is seen. 𝗃𝗀𝗃𝗃 which is seen. 𝗃𝗀𝗃𝗃 is perinuclear ANCA. It is also known as myeloperoxidase. These are the alternative names for the same autoantibody. ऐसा ना हो कि tomorrow they repeat the question and the name is changed, so you are unable to identify it. Why not GPA? Why not GPA? Because there is no granuloma and no upper respiratory involvement. Upper respiratory involvement in GPA is seen in 95 to 100% patients. Remember this. Upper respiratory is never involved in microscopic polyangiitis. And so you can easily rule it out. Treatment, good thing. Same for GPA. So whatever we did there is applicable here as well. Right? Let's go further. So age 30 to 50-year, female more than male. Now, asthma is there, eosinophilia is there. Granuloma formation is there and neuropathy is there. So small vessel vasculitis, where asthma is there, allergies are there, so eosinophilia will occur. Granuloma formation similar to GPA, but nerve involvement, which was not seen in the other two varieties. Which small vessel vasculitis has allergic tendencies with neuropathy along with vasculitis? It is EGPA. What is EGPA? Eosinophilia. Or eosinophilic granulomatosis with polyangiitis. With polyangiitis. What is the older name? It was also known as Churg-Strauss syndrome. Churg-Strauss syndrome. Autoantibody, here also 𝗃𝗀𝗃𝗃. So people will say, sir, how do we distinguish? Do biopsy. If you find granuloma, it was EGPA. If there is no granuloma, and then it goes in favor of MPA. If there is asthma and raised eosinophilia, EGPA. If there is no asthma, no eosinophilia, but nephritis is there, it goes in favor of MPA. This is how you distinguish between them. I'll summarize. Treatment, again, is steroids. Treatment in these patients is steroids. Okay. So let us quickly revise here. Unilateral headache, cord-like palpable tender lesion, pain on movement in jaw and tongue. We call it as jaw and tongue claudication. Risk of blindness. What are we dealing with? Temporal arteritis. Okay, superficial temporal artery is involved. If they say one side pulse is missing, radial pulse or femoral pulse is missing, patient is having other constitutional symptoms and fever, etc. And patient is also having claudication of the limbs. The answer will be Takayasu arthritis. It will involve the subclavian artery and other aortic branches. If the question says small vessel vasculitis, look at the pattern. Triad of upper respiratory, lower respiratory, and renal involvement, it is GPA. Granuloma always there. C ANCA is the antibody. P ANCA is positive in the other two variants. If there is GPA-like presentation but no granuloma, no upper respiratory tract involvement, it is MPA. And if there is asthma with neuropathy but renal involvement is plus minus, it is EGPA or Churg-Strauss syndrome. And our pharmacology one-liner, that Churg-Strauss syndrome can also be a side effect of a drug. It's a NEET PG pharmacology MCQ. Have you heard the drug montelukast? So it is a side effect of montelukast in some patients. So it's a pharmacology integration that we are doing. Right? Topic is done. Let's solve some MCQs. Rapid fire MCQs. NEET PG 24. 45-year-old male presented with fatigue, hemopsis, current HB8. Actually, this question came here, but bronchial lavage is red in color, serum creatinine 1.7. Biopsy revealed paucity of immune complexes. So there is lower respiratory tract involvement and glomerulonephritis in a middle-aged person. It can occur in males also, although females are more commonly affected. What are we dealing with? The patient is likely having microscopic polyangiitis. Why it is not Gout-Pasteur syndrome? Gout-Pasteur syndrome will have anti-glomerular basement membrane antibody and immune complex will be present there, right? This is the topic we will discuss in a few minutes from now. So microscopic polyangiitis, C is your answer. FMG January 23. Female presented with difficulty in standing up from sitting position and combing her hair. There is proximal muscle weakness. She also has violaceous rash around the upper eyelids bilaterally. This was the typical rash occurring in dermatomyositis. What is the likely diagnosis? Postmenopausal female, knee pain, joint aspiration revealed. See, now people will say कि sir knee में हो रहा है. Knee can sometimes be. Although first metatarsophalangeal joint is most commonly involved, the important thing you have to look for, needle-shaped, negatively birefringent crystals in polarized microscopy. What is the likely diagnosis? These are MSU crystal. So what is the patient having? Gout is the diagnosis. Right, good. FMG January 23. 60-year-old male patient presented with throbbing unilateral headache, nodular thickening along the temporal artery, giant cells, granulomatous vasculitis present. What is the diagnosis? What is the diagnosis? This is temporal arteritis in the patient. Questions are looking easy because we have just done the topic. If you don't revise, the same questions will become tough in the actual exam. 30-year-old woman presented with slowly progressive dysphagia since past 1 year, no weight loss but has thickened leather-like skin and oral mucosa with hypertension. There is reduced exercise capacity due to lung fibrosis. So fibrosis happening, dysphagia happening, leather-like skin texture. What is it fitting into? Scleroderma is the likely possibility. So if you look at the buzzwords, keywords, read them well. These are all actual questions. So it is not that we are doing randomly. These are the previous year topics that I have selected for discussion in all these sessions. Just a sprinkling of NEET PG questions, just a sprinkling of updates of Harrison we are adding. Okay, topic is done, system is done. Let us move into nephrology. Now, nephrology, less questions are asked from medicine directly. More questions are generally asked from pathology part. So pathology is more important in nephrology. But here some scenarios and some flowchart based approaches we will be forming. Let us start with nephrology. First of all, examiner will say there will be a case presentation which will be made. There is a spelling mistake here. They will say edema is present, but not on the entire body, face or around the orbit of the eye. So patient will come to you and he will say, when I'm getting up in the morning, I am finding my face is becoming puffy. The puffiness initially started around the orbit. It is more in the morning hours and it is gradually increasing. And my entire body, I feel it is becoming heavy. So this is edema starting from the face involving the entire body. And when he passes urine, urine is abnormally frothy. When you check urine protein is very high. Normally, you and me, we have zero protein. Okay, urine protein is negligible. In some patients, it can be 1 plus or 2 plus. We call it as mild. But if it is 3 plus or 4 plus, it is severe proteinuria, massive proteinuria. So edema on face, frothy urine, massive proteinuria. What is the likely diagnosis? You know the answer, absolutely right. We are dealing with nephrotic syndrome. nephrotic syndrome. Let us do a rapid fire review of the clinical aspects of nephrotic syndrome. Now, nephrotic syndrome, what is the three important characteristics? What are the three important characteristics of nephrotic syndrome? First, these patients have massive proteinuria. Massive proteinuria. Second, these patients have edema. Edema typically occurs on the face or periorbital region. Later, it involves the entire body also. If you don't treat, obviously entire body will be involved. And thirdly, these patients will have hypoalbuminemia. What is hypoalbuminemia? Decreased serum albumin level. These patients, they may or may not have two other characteristics. They may or may not have hyperlipidemia. Hyperlipidemia means the serum cholesterol in these patients, it is more than 200 milligram per deciliter. And they may or may not have hypercoagulability of blood. What is hypercoagulability of blood? They have increased risk of thrombosis. So these are the interesting things, important things related to nephrotic syndrome that you should know. Nephrotic syndrome, if you try to see, it is broadly of two types. We have primary nephrotic syndrome, also known as idiopathic nephrotic syndrome, where no cause is found. Idiopathic means just bad luck, it happened. And second is secondary nephrotic syndrome. It is secondary to something. Secondary can be drug induced, it can be SLE induced, it can be due to hepatitis B, hepatitis C, HIV, TB, UTI, anything can cause secondary nephrotic syndrome. Primary or idiopathic nephrotic syndrome is more common in children compared to adults, whereas secondary nephrotic syndrome is more common in adults compared to children. Primary or idiopathic nephrotic syndrome, there is generally no hematuria. There is no hematuria or hypertension. These patients have nephrotic with hematuria and hypertension. Primary, when you do biopsy of the kidney, if it is a child, you will find a disease known as minimal change disease. Why do we call it as minimal change? Because light microscopy is normal. Only on electron microscopy you find effacement of food process of podocyte. MCQs are asked in FMGE from pathology part and people jump and mark wrongly. देखो दो तरह के questions आएंगे. Two types of questions will be asked. If they say what is the light microscopic appearance, you will say normal glomerular, no change. That is why the name is minimal change. But when you do electron microscopy, changes will be present, and that is effacement of food process of podocyte. And if it is an adult with primary nephrotic syndrome, the patient is likely to have FSGS, focal segmental glomerulosclerosis, is the common biopsy finding you will see in these patients. Okay. What is about secondary nephrotic syndrome? The biopsy findings vary according to underlying cause. They vary according to underlying cause. What is the treatment in these patients? What is the response to therapy? Primary form shows good response to steroids. Secondary form shows variable response to steroids. Variable response means steroid response may come or it may not come. In primary nephrotic syndrome, the serum C3 level is always normal because C3 is not involved. Complement mediated damage is not happening. Here, serum C3 can be normal depending upon the cause, or it may be decreased. So some patients can have complement activation. Here you find selective proteinuria to be present. Selective proteinuria means only albumin is getting filtered. Albuminuria is happening. Here you find non-selective proteinuria to be present. This looks like a very simple flowchart to you, but trust me, this entire page, at least 4 to 5 previous year questions I have covered here. Statement based also, one-liner also, case scenario based also. If you will be solving your MCQs, pathology questions will also be solved. I'm not teaching pathology, but pathology questions in this will also be solved based upon this table. It's very, very important, right? What is the most common type of nephrotic syndrome in children? For quick revision, idiopathic, also called as primary form. Most common biopsy finding in childhood nephrotic syndrome, minimal change disease. I hope you know that minimal change disease is also known as null disease and lipoid nephrosis. These are the other names of the same condition. Most common type of nephrotic syndrome in adults, secondary nephrotic syndrome. If you do biopsy in nephrotic syndrome in adult, which pattern will be found? FSGS will be found. FSGS can occur in primary also in adults. It can occur in secondary also in adults. This is a FMGE MCQ. Which is the most common type of disease seen in age more than 60 years producing nephrotic or lymphoma leukemia patient developing nephrotic? Membranous nephropathy. Membranous nephropathy. What is the most common antibody? Very, very important. Potential MCQ. Which is the most common antibody which produces nephrotic syndrome in adults? There is an antibody known as anti-PLA2, phospholipase A2 antibody. It produces primary membranous glomerulonephritis. Very, very important. What is the most common nephrotic syndrome which is associated with hepatitis B virus? It is membranous nephropathy. But which is the most common variety associated with hepatitis C virus? MPGN. What is MPGN? Membranoproliferative glomerulonephritis. And most common associated with HIV, FSGS. Many of these points are Robbins points as well. And you will find them in FMG in the pathology part as well. Steroid resistance. Some patients will not respond to steroid. How do you define steroid resistance? MCQ. If you have given steroids daily in full dose for equal to or more than 6 weeks in children and equal to or more than 4 weeks in adults, we call it as steroid resistant nephrotic syndrome. Remember, the time to define nephrotic syndrome resistance is different in children, different in adults. What is the drug of choice in steroid resistant nephrotic syndrome? There are drugs known as calcineurin inhibitors. In calcineurin inhibitors, tacrolimus is the preferred agent. If not an option, your second answer will be cyclosporin. So pharmacology. Cyclophosphamide does not work in steroid resistant. Steroid resistant, only one drug works, calcineurin inhibitor. Cyclophosphamide, again I repeat, does not work in steroid resistant nephrotic syndrome. It's a common mistake you will find in many of the guidebooks and some of the free material roaming around on Telegram. Something which is free is not always correct, and something which is free is not always bad. There is always that middle ground. You need to be a bit skeptic sometimes. 18-year-old patient with an ASARCA is having proteinuria of 4.5 grams per day. Hyperlipidemia, hypoalbuminemia, recommended first-line treatment. So massive proteinuria, hyperlipidemia, hypoalbuminemia, ASARCA means entire body is involved. It is nephrotic syndrome. What is the first-line therapy in nephrotic syndrome? A, B, C, or D? The first-line therapy is always prednisolone. Cyclophosphamide is not given. It is in the initial part. It is only given if steroid is not working, or more commonly it is given when steroid is causing side effects, right? If resistance word is used, then you have to go for calcineurin inhibitor. Okay, that is the important thing you need to. So topic is done. Next scenario, it's again an easy topic. Cola colored urine, examiner will say it, or dark colored urine or gross hematuria. Cola colored, dark colored urine is indicating gross hematuria. There is periorbital edema, but it is not as prominent as nephrotic. Urine protein is it is there, but it is not massive. RBCs are present and oliguria hypertension are present. So remember, proteinuria, hematuria with oliguria, that is acute nephritic syndrome. Acute nephritic syndrome. Sometimes it is also known as glomerulonephritis. These two terms are interchangeably used. Glomerulonephritis. Acute nephritic syndrome or glomerulonephritis. Okay, when you do microscopy in these patients, urine microscopy, you will find RBC cast and dysmorphic RBCs. देखो, अगर RBCs, if urine is red and there is hematuria, you need to see where the RBC is coming from. If RBC cast and dysmorphic RBCs are present, then it indicates glomerular origin of hematuria, and that will indicate acute nephritic syndrome. Okay. Now, acute nephritic syndrome, it is often triggered by infection. It is often triggered by infection. Membranous nephropathy is nephritic or nephrotic? Membranous nephropathy is nephrotic syndrome. Can it cause nephritic picture? Rarely, but it is generally considered to be nephrotic syndrome. Right? So often triggered by infection, nephritic syndrome. Now, two types of cases you need to remember. Suppose a patient had infection, it can be skin infection or respiratory infection, and 1 to 5 days later, there is onset of the disease. The answer will be different. And if it occurs 1 to 3 weeks of sore throat and 2 to 6 weeks of pyoderma, the infection started. The onset, if it occurs like this, the answer will be different. If infection occurs and 1 to 5 days later nephritic syndrome starts, the likely diagnosis is IgA nephropathy. And if onset occurs about more than a week later, then it is post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. IgA nephropathy will show mesangial deposits of immunoglobulin A, mesangial IgA deposits, whereas post-streptococcal glomerulonephritis will show subepithelial deposits. These deposits are called as humps. Can subendothelial deposit also occur? They can, but humps are typically produced due to subepithelial deposits. Both of them resolve with time, and post-streptococcal nephritis especially has a relatively better outcome. With supportive therapy alone, the patient will recover. Then, next MCQ, rapid loss of renal function, AKI or oliguria happening. So, rapid loss of renal function is happening. Biopsy shows crescent formation. This is the clinching clue. And electron microscopy shows rupture of glomerular basement membrane and proliferation of parietal membrane. My suggestion, when you are doing revision, ये जो बाकी के words mentioned है, even if you have known the answer, these words are important because you never know. In the actual exam, examiner may miss out the keyword, but he may mention other words. So all these words I have mentioned in this entire workbook, especially the ones in boxes, every single word is important. If you have a presentation like this, patient is likely having RPGN. RPGN. It is not MPGN, RPGN. What is RPGN? Rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. It is also known as, yes, correct. It is correct, Radha, correct, Swami. It is crescentic glomerulonephritis. Other name is crescentic glomerulonephritis. Now, what are the types of RPGN? Now, these types are generally asked in pathology, but we will do a quick review here based upon what Harrison says. There are 3 types of RPGN which are described. The first variety is type 1 RPGN. It is also known as anti-GBM disease. Remember, I told you that if Gout-Pasteur syndrome does not have lung involvement, only renal involvement, that is called as anti-GBM disease. So its another name is type 1 RPGN. Then we have type 2 variety. Type 2 variety is called as immune complex RPGN. So immune complexes are involved. And type 3 is called as quasi-immune RPGN. Quasi-immune means there is no immune complexes which are present. What are the conditions included here? This is seen in Gout-Pasteur syndrome. This condition is seen in SLE, Hanoch-Schönlein-Purpura, and post-infectious glomerulonephritis. And type 3 variety, I told you it occurs in MPA as well as GPA. In type 1 variety, there will be linear IgG and C3 deposits on the glomerular basement membrane. In type 2 variety, lumpy bumpy deposits will be present. Lumpy bumpy granular deposits will be seen. And in type 3, no immune deposits are seen. That is why the name is pausimmune. No C3, no complement is getting activated in these patients. So this is based upon the table given in Harrison. It's important, and they can help indirectly also if you get an MCQ on this. For those who are looking at their watch, then we will take the break. We will take the break. Don't worry. We are going fine without compromising any of the content we have planned. And we are also to the almost the last 5 pages of the class. So just a few more minutes and we will finish. So gross hematuria, cola colored urine, right? So hematuria is happening. There is mild to moderate proteinuria. Sensory neural deafness. So deafness is there and eyes are showing abnormality. Anterior lenticonus, anterior deformity of the lens of the eye. So eye involvement, ear involvement, and kidney involvement. This is a patient who's suffering from Alport syndrome. So what is the likely diagnosis? It is an inherited disorder known as Alport syndrome. So the diagnosis in the patient is Alport syndrome. What is the inheritance? X-linked inheritance is seen. This X-linked inheritance, it cannot be put directly into dominant versus recessive, and there are reasons for it. That is why Harrison and Robbins' new editions don't use the word dominant or recessive. They simply say X-linked inheritance is seen. It can occur sometimes in females also. Second common is autosomal recessive inheritance. Third common is autosomal dominant inheritance. If X-linked inheritance is involved, which is the most common gene it is involved? 𝗘𝗱𝗶𝗁 gene. 𝗘𝗱𝗶𝗁 gene means type 4 collagen is abnormal, alpha 5 gene is abnormal in these patients. Autosomal recessive, what is the gene involved? 𝗘𝗱𝗁3 gene. And autosomal dominant inheritance, 𝗘𝗱𝗁4 gene is involved. They all have abnormalities in which collagen? They have abnormalities in type 4 collagen. What will renal biopsy show? Renal biopsy shows basket weave appearance. Basket weave GPM. Why? Because there will be alternate thickening and thinning of glomerular basement membrane. That is, and this is a one-liner MCQ already in the previous year questions. Basket weave appearance. What is the drug of choice? First line agents are ACE inhibitors. They reduce proteinuria and control hypertension, which generally occurs in these patients. But there is a new drug which is available now. MCQ, potential MCQ. There is a drugs known as SGLT2 inhibitors. These drugs are more famously used for diabetes, type 2 diabetes, but they are useful in these patients also. There are two types of drugs where SGLT2 inhibitors are useful. Two types of drugs. One is canagliflozin, and second is rapagliflozin. So flozins are the agents which are useful here. So canagliflozin and rapagliflozin. Very, very important. SGLT2 inhibitors are useful in CKD, Alport syndrome, and also useful in FSGS patients. This is mentioned in New Harrison. It is a potential MCQ point. SGLT2 inhibitors are useful in all these conditions. So it's very, very important. I'm highlighting it here. Diagnosis everyone will make. These are the things. Pharmacology also, you can get a question on this. Next scenario. It's an easy one. We are on to AKI and CKD. In other words, we are on to the last two topics of nephrology. Don't try to run away. Acute kidney injury, previously called as acute renal failure. Rapid deterioration in renal function is acute kidney injury. Any one of the following, if it is present, we call it as AKI. First, if the rise in serum creatinine is equal to or more than 0.3 milligram per deciliter within 48 hours. That is first parameter. Second, if the serum creatinine is raised equal to or more than 1.5 times from baseline within 7 days, that is also acute kidney injury. And if there is a fall in urine output, that is oliguria, less than 0.5 ml per kg per hour for 6 hours or more, that is also a criteria. These are the criteria to define AKI. Any one out of these three criteria is fulfilled, we say नॉन डायबिटिक में तो हाइपोग्लाइसीमिया हो जाएगा, नो डॉक हाइपोग्लाइसीमिया नहीं होगा. And for that, you need to read the pharmacology of these drugs. We use them in low doses. And देखो हाइपोग्लाइसीमिया वही होता है जहां पर they are actually affecting the gluconeogenesis or similar conditions. Canagliflozins don't work like that. And that is why I would advise you read at least 2 hours only one topic, oral hypoglycemic drugs. It's very important and directly or indirectly asked in all competitive exams. So acute kidney injury, this is how you diagnose. Now, there is a classification known as KDIGO classification that we follow. KDIGO classification divides it into 3 stages, stage 1, 2, and 3, and 2 criteria are used, serum creatinine and urine output. So what is stage 1 acute kidney injury? If the serum creatinine rise is equal to or more than 0.3 milligram per deciliter, or it is between 1.5 to 1.9 times from baseline, you call it as stage 1. If it is between 2 to 2.9 times the baseline from the baseline value will be different for every patient. You need not remember the baseline value. And stage 3, if it is increased equal to or more than 3 times from baseline, or there is increase in serum creatinine, absolute value is equal to or more than 4 milligram per deciliter, or there is need for RRT. What is RRT? Renal replacement therapy, which is the technical name for dialysis. Or if the patient is having GFR, we write E, estimated GFR, there are formulas to calculate that, that is less than 35, then we say serum creatinine stage 3. Stage 3 has 4 criteria. Common mistake we make, we remember only 1 or 2 criteria. Examiner knows this. Tomorrow he may put a question, which of the following not compatible with stage 3 AKI, and we will be in a soup. So you have to remember them precisely. What about urine output? Urine output is easy to remember. Any urine output less than 0.5 ml per kg per hour for 6 to 12 hours, it is stage 1. So less than 0.5 ml per kg per hour for 6 to 12 hours. If the urine output is less than 0.5 ml per kg per hour for more than 12 hours, that will be stage 2. That will be stage 2. And third, stage 3, if it is less than 0.3 ml per kg per hour for equal to or more than 24 hours, or the patient is anuric for 12 hours, you call it as stage 3. Now, what are the types of AKI? Types of AKI. Types of AKI, there are 3 types of AKI depending upon the cause. Pre-renal, where the renal blood flow is compromised. Intrinsic renal, where the kidney damage to the parenchyma is happening. And post-renal, where obstruction is not causing urine to go out of the body. So, what are the types of AKI? 3 varieties are there. Pre-renal, renal, and post-renal. Pre-renal, the pathophysiology here is decreased renal blood flow. It occurs due to decreased renal blood flow. Pathophysiology here is renal parenchymal damage. Renal parenchymal damage. For example, ATN, acute tubular necrosis. And post-renal acute kidney injury, there will be obstruction to urine flow. That causes post-renal AKI. So some examples we will be writing. It's a long list, but we will only discuss the important points here. So pre-renal acute kidney injury will occur in dehydration or diarrhea. It will occur in patients with burns. It will occur in patients with shock. It will occur in patients with congestive cardiac failure, CCF. Renal acute kidney injury will occur in patients with ATN. ATN is acute tubular necrosis. You'll read about this in pathology. It will occur in glomerulonephritis. It will occur in drugs. It will occur with SLE. It will occur with prolonged pre-renal acute kidney injury. Prolonged pre-renal injury leads to renal acute kidney injury. And post-renal will occur due to stones in the urinary tract. It will occur due to strictures. It occurs due to BPH, benign prostatic hyperplasia. It occurs due to cervical cancer. And it can occur due to retroperitoneal fibrosis, a thing you read about in surgery class. Retroperitoneal fibrosis. Right. So, what is the treatment in pre-renal acute kidney injury? IV fluid bolus. Either normal saline or ringer lactate works like a charm. Here, treatment in these patients is treat the underlying cause. Underlying cause is treated. Plus, you give supportive therapy. And what is the treatment here? Catheterization to relieve the obstruction. Catheterization to relieve the obstruction. Catheterization to relieve the obstruction in the patient. And then there is a table on which question was asked in this FMG July 25. A lot of times people ask, see, जो मैंने causes लिखे हैं ये bare minimum causes हैं. These are just examples I'm writing. If you start reading, there will be about 25 to 30 causes for each. But you can't remember everything. Do eat what you can digest, read what you can revise, and what is relevant for the exam. Okay, so PYT, pre-renal versus renal acute kidney injury, Harrison table, you will write in bracket, question asked in July 25 FMG exam. There was a question asked on this. So look at these findings. It's a table you are supposed to mug up. How do you distinguish between pre-renal and oligouric acute renal injury or oligouric acute renal failure? In bracket, you will write renal, intrinsic renal. Many times you will find in your textbooks where they include the third one also, obstructive AKI also. If you have time, you can read that also. But I would suggest that close to the exam, when you have limited time, remove the third one. Only focus on these two. You have a higher chance of getting the answer correct. And in fact, Harrison does not even talk about obstructive cause much. So pre-renal versus intrinsic renal, how you are going to distinguish. The most important parameter is this parameter on which question was asked. Fractional excretion of sodium. How do you calculate? There is a formula for this given at the bottom. Urine sodium into plasma creatinine divided by plasma sodium into urine creatinine multiplied by 100. And if it is less than 1%, it is pre-renal acute kidney injury. If it is more than 2%, it is intrinsic renal acute kidney injury. Other are the values you are supposed to mug up, but this particular point is the most important thing on which question has been asked already. And let me tell you a historical fact. This has been asked not only now in FMG, it was asked in NEET PG when I was a student, when it was not called as NEET PG. The term NEET PG came in 2017. Before that, we had AIPGME. Same question, same examiner, name keeps on changing. So tomorrow, if National Board of Examination name changes, do you think they will change? They will not change. Similarly, the organizations remain the same, just the name change happens. So fractional excretion of sodium is the most important thing, and there was a question asked in my time as well. Whether I got it, I don't remember what was the question, which means that generally it was the correct answer. If you mark something wrong in actual paper, you will remember it lifelong. Let's go further. How to calculate GFR? There are numerical questions which are asked on this, and sometimes simple one-liner variations also asked on this. Schwartz formula was asked 2 times in the recent papers, once in NEET PG, once in INI set. It has not been asked in FMG. Can it be asked in FMG? The only logical reason is yes, they can repeat it and put it there. So Schwartz formula says, if you have to calculate GFR, we call it as eGFR, the formula is K multiplied by height taken in centimeter, divided by serum creatinine, that is milligram per deciliter. And K is a constant. The value of K is 0.413. This is the formula. You have remembered a lot of formulas in your school time. Again, some time to remember the formula. This is the first formula. But in adults, we don't follow this formula. Adults, we follow Cockcroft-Gault formula. And this formula says that for calculating GFR, for calculating eGFR, you will be using this formula. Children are simple, adults are complex, so formula becomes complex. 140 minus age, whatever is the age in years, multiplied by weight, divided by serum creatinine, multiplied by 72. This is the estimated GFR in males. What about females? Bracket you would write in female patient. You multiply this, whatever result you get, by 0.85 because females have slightly lower value compared to males. End of the day, there is no logic here. You have to mug it up. Now, what about CKD? CKD stands for chronic kidney disease, where the estimated GFR is progressively going low. We call it as CKD. So, what is the staging of CKD? Look at this staging of CKD. Staging of CKD will tell you that any patient who's having estimated GFR 90 or higher, it is stage 1. If it is between 60 to 89, GFR ml per minute per 1.373 meter square, that unit will be written in the MCQ, stage 2. 3A 45 to 59, 3B 30 to 44, stage 4 15 to 29, and stage 5 less than 15. This stage 5 is also sometimes called as end-stage renal disease. Now the kidney is not functioning. MCQ one-liner, absolute indication for dialysis in CKD. One-liner MCQ, uremic pericarditis. So urea and creatinine is so high, it is causing cardiac toxicity. That is called as uremic pericarditis. Absolute indication to do dialysis in the patient. I told you dialysis is also known as, it is also known as renal replacement therapy. It is also known as renal replacement therapy. Now, approach to tubular disorders. Now, sometimes question will be asked about tubular disorder. Now, how the examiner will put a question, examiner will say, there is a patient who's having polyuria polydipsia. See, kidney has, the functional unit of kidney is nephron. Nephron has two parts, glomerulus and tubule. What is the function of glomerulus? To filter. What is the function of tubule? To absorb. If tubule is not functioning, what will happen? Absorptive function will go away and there will be large losses of urine. That is called as polyuria polydipsia. Polydipsia is increased thirst to compensate for that. So polyuria polydipsia can occur in diabetes, but examiner will tell you polyuria is there, polydipsia is there, but diabetes mellitus and diabetes insipidus are ruled out. How would you approach? So there is an approach for this. Immediately do ABG in the patient. This scenario will work in some of the tougher questions when you solve them. So when you do ABG, there will be two possibilities. Either patient is having metabolic alkalosis or patient is having metabolic acidosis. Metabolic acidosis. If it is metabolic acidosis, there are two possibilities. Either we are dealing with RTA. What is RTA? Renal tubular acidosis. I'm writing in the bracket, renal tubular acidosis. Or there can be a syndrome known as Gordon syndrome. Gordon syndrome patient will always have hypertension. Hypertension will be the clue. If it is metabolic alkalosis, you look at the BP. If there is normal BP versus hypertension. If hypertension is present, it is likely to be a syndrome known as Liddle syndrome. If it is normal BP, you further see. If they say facial abnormalities, so facial dysmorphism is there, sensory neural hearing loss is there, increased prostaglandin levels, PGE2, but not increased PGE2 and increased urine calcium. Increased urine calcium means hypercalciuria. The likely diagnosis in the patient will be Bartter syndrome. Bartter syndrome. Bartter syndrome. And if the patient is having No facial dysmorphism. Hypomagnesemia, decreased magnesium level. Hypocalciuria, that is decreased urine calcium excretion. And a milder disease. The patient is having a syndrome known as Gitelman syndrome. The diagnosis in the patient will be Gitelman syndrome. Now, exact recall is not there. Many of the students who sat in July exam, if someone has sat, they can tell better. Ki, sir, there was a long question, 4 line long. It had all these features like hypomagnesemia, sensory neural hearing loss, facial abnormality, and polyuria polydipsia mentioned. They were asking the diagnosis. Now, what the question was, I have no idea, but this flowchart works like a charm. There have been questions asked on this in NEET PG. That is about the topic of tubular disorders. Miscellaneous scenario. Similar question asked in January 25 as well as July 25. Examiner will say, post-burn patient, post-electric injury patient, post-trauma patient presents with red-colored urine. What is likely? If post-burn, post-trauma, post-electric injury patient is presenting with red-colored urine, there are two possibilities. Either it is gross hematuria or it is myoglobinuria. Myoglobinuria. Gross hematuria will require supportive therapy, whereas myoglobinuria can cause acute tubular necrosis. They require admission, start IV fluids, and watch for acute kidney injury. And in the MCQ, which was asked in July 25, students said myoglobinuria was in the option. One version of the question says RBCs were negative. If RBC is negative, then you can be sure the answer is always myoglobinuria. Now, as I said, we will be taking up these 3 segments here. We'll be taking up CVS, neurology, and endocrinology. Hematology, number 1, there is a lot of integration with pathology, plus some scenarios are relevant. Okay, so let us start with the discussion. After this initial things, let us start with cardiovascular system. Cardiovascular system is huge, but there are certain trends you can find in cardiovascular system. Close to the exam, areas to focus on in cardiovascular system, you have acute rheumatic fever and rheumatic heart disease, which are important. Particularly, mitral stenosis is one of the favorite of examiners these days. Second is pulmonary embolism, which we have already covered in the pulmo part. Third is ECG findings. They will give an ECG and ask you details related to it. So ECG related diagnosis and next step in management. Fourthly, they will be asking questions on acute coronary syndrome, that is MI, unstable angina, non-ST elevation MI, details of these. They will ask you on questions on JVP, and they will be asking you to distinguish between constrictive pericarditis versus cardiac tamponade. So these are the areas you have to focus on. And if time permits, plus minus, you can have a look at infective endocarditis, you can have a look at cardiomyopathy, and you can have a look at pericarditis. These are plus minus topics. If I am a serious aspirant for cardiology part of medicine, you will find that at least 3 to 4 questions from these topics which I mentioned are bare minimum at least asked. Try to think like this. Entire anesthesia or an entire dermatology gives you 4 to 5 questions. Similar number of questions generally are asked from these particular topics. Again, cardiology is tough. Cardiology is something we cannot do in one day. Even if the entire day is available, still we will try our best to cover the maximum ground possible. And I'm assuming that most of you have done and you are thorough with at least the basics of physiology and basics about the disease already. So let us start. When I said HOC cardiomyopathy, it includes HOCM as well. Okay, so let us start with the discussion. First of all, I'll be starting with acute rheumatic fever. Acute rheumatic fever is a topic which falls between the gap. What is falling between the gap? Pediatricians will think a medicine person will teach. Medicine persons will say, we will teach RHD, rheumatic fever to बच्चों में होता है. You must have been taught in pediatrics. This topic gets isolated and then it gets asked in exam. Acute rheumatic fever, question asked in FMG July 25, question asked in NEET PG 24 last year, and INI set November 25 this year as well. And there were multiple correct options in the INI set question. What it means is rheumatic fever is on the radar of examiner, something from which is likely to be asked. And because many of you don't read this topic properly, I will go fast, but I will try to cover a lot of ground in this topic. So what is acute rheumatic fever? So let us start with acute rheumatic fever. What is the age in which rheumatic fever is important? First, let me tell you a simple thing. In simple words, then we will write the key points. Normally, suppose I am a child, age 7 or 8 years. I get a streptococcal infection and my body will try to fight against the infection. How? It will form antibodies. These antibodies will bind the antigen of streptococcus and normally they will be removed from a body. The immune cells will take care that they don't circulate. Now imagine they are not getting removed and they are persisting in the body. Now what will happen is this persistent reaction will lead to autoantibody kind of formation against the native antigens. In other words, there is a protein found in the outer layer of streptococcus called as M protein. Many times the antibodies which are formed against M protein also, because they are not getting cleared from the body, they will cross react with similar tissues of our own system. In other words, let me make it even more simple. स्ट्रेप्टोकोक हिंदी में बोलता हूं पहले स्ट्रेप्टोकोकस आया एंटीबॉडी बनी एंटीबॉडी ने स्ट्रेप्टोकोकस को तो मारा लेकिन अगर वो एंटीबॉडी लंबे समय तक परसिस्ट करे तो अपने ही टिश्यू को मारने लग जाती है उसको कहते हैं मॉलिक्यूलर मिमिक्री मैकेनिज्म नाउ द इंग्लिश पार्ट in streptococcal infection sometimes the antibodies against M protein component of streptococcus they persist longer and they start damaging the cardiac tissue, the joint tissue and the skin antigen. The disease so arising because of that is called as rheumatic fever and this mechanism is called as molecular mimicry, right? So let us write down. So let us continue with the flow. Acute rheumatic fever, what is the age of the patient? Typically occurs between 5 to 15 years. Which gender is it more common? Which gender is it more common? It is more common in males. It is more common in males compared to females. India lies in high risk population. India lies in high risk areas or high prevalence area for rheumatic fever. What is the most common cause? Sore throat or throat infection caused by Group A beta hemolytic streptococci. Group A beta hemolytic streptococci. And there are specific M strains which are responsible for producing this. What is the name of the mechanism? The mechanism is known as, this is MCQ point. The mechanism is known as molecular mimicry. Molecular mimicry. How do you make the diagnosis? It is always a clinical diagnosis. Diagnosis is made clinically, supported by, I'm writing in brackets, supported by ECG and blood tests. So it is a clinical diagnosis supported by ECG and blood test. What is this mechanism? I'm writing on the side. This mechanism of molecular mimicry is also known as type 2 hypersensitivity reaction. Remember that streptococcal renal involvement. Remember we did the word PSGN. That was type 3 hypersensitivity. This is type 2 hypersensitivity. So you can write in the bracket or on the side that PSGN, post-streptococcal nephritis, is type 3 hypersensitivity reaction, whereas acute rheumatic fever is considered to be type 2 hypersensitivity reaction. For those who do not know or they might have forgotten, there are broadly 4 types of hypersensitivities. Type 1 is immediate. All the allergies, anaphylaxis is type 1. Asthma is type 1. Type 2 is antibody-dependent cellular toxicity. Rheumatic fever is that. Type 3 is immune complex deposition. So PSGN, henoch-Schönlein purpura, they are all type 3 hypersensitivity. And type 4 is delayed hypersensitivity like you see in granuloma formation, like you see in tuberculosis patients, right? So streptococcus causes both type of reactions. Rheumatic fever is type 2 and renal involvement is type 3. Now, what is the modified Jones criteria, also called as revised Jones criteria? It was originally given in the 1940s and 50s, and it has been revised almost 6 to 7 times. Currently, we follow the 2015 criteria. This criteria says that the criteria remains the same in both low risk population and high risk population. LR population means low risk population. Low risk population. For example, United States of America. But slightly different criteria is used in moderate to high risk population, for example, India. Let us first look at what is happening in the United States. The criteria remains the same. So we have 5 major criteria and 4 minor criteria. Okay, what are the 5 major criteria? First is carditis. Carditis means heart involvement, heart inflammation. It can be symptomatic or it can be asymptomatic, means clinical or subclinical. Second is arthritis. Arthritis means joint swelling, redness, pain, inflammation, etc. That is called as arthritis. I'm highlighting this word. I will summarize in the end so you would understand why am I highlighting this. Polyarthritis only. At least 2 or more joints if they are involved. Only then we call it as a major criteria in low risk population. Third is chorea. What is chorea? Also called as Sydenham's chorea. Chorea is abnormal body movements. It is a CNS manifestation. Fourth is subcutaneous nodule, painless nodules which occur in the patient. So they are painless nodules. And fifth is erythema marginatum, which is a kind of rash. Erythema on the margin, center is clear. We call it as erythema marginatum. These are the 5 major criteria. Let us have a look what happens in high risk population like India. Let us go further. Then we will discuss minor separately. Look at this moderate to high risk population. Carditis was a criteria here. Carditis was a criteria here. Arthritis was a criteria there. Arthritis is a criteria here. But highlight this word. What is the difference? In low risk population like United States, only polyarthritis is considered a major criteria. Here, polyarthritis or monoarthritis or even multiple joints having pain without any inflammation, that is also considered to be major criteria. Chorea is criteria there, chorea is criteria here. Subcutaneous nodule there, subcutaneous nodule here. Erythema marginatum there, erythema marginatum here. So there are 5 major criteria in US also and in India also. What is the difference? In United States, only polyarthritis is considered a major criteria. In India, polyarthritis, monoarthritis or polyarthralgia, all 3 are considered criteria. Please put a Q here because there are statement-based questions on this in NEET PG exam. How do major criteria differ in high-risk population like India compared to Western population? This is how they ask questions. Once you have understood, you will be able to answer in the exam. Actually, it is not tough. Once you will be doing revision, you will just be, just having a look at this highlighted part. But somebody should have told it to you that this is the way question can be asked in the exam. So I hope this funda is clear in your mind. That in US, only polyarthritis is a criteria. In India or in high-risk population. What are the high-risk population areas? The entire Southeast Asia is high-risk population, right? So we all have rheumatic fever. So not just India, Sri Lanka, Nepal, Pakistan, Bangladesh, Afghanistan, Myanmar, all the way till Thailand. This is all the belt which we are seeing. This all belt, Cambodia, Laos, they are all high-risk population. Okay. Now, what about minor criteria? Let's have a look at the minor. There are 4 minor. In United States, the first minor criteria is polyarthralgia, that is pain in the joint. But 2 or more joints should have pain. Highlight this word. Polyarthralgia is a minor criteria in US. Fever is a minor criteria, but what is the degree of fever? Highlighted. More than 38.5. So high degree fever. Third is ESR more than 60 or CRP more than 3. Just you can remember the value ESR more than 60, CRP more than 3. Acute phase reactants should be high. Highlight this CRP also 60 is the value in US. And prolonged PR interval when you do ECG in the patient. So prolongation of PR interval. This particular thing was the INI-SET MCQ asked in November 25 exam. They had asked you to identify the incorrect statement. One of the statement was rheumatic fever patients have short PR interval. Wrong. Rheumatic fever patients have prolonged PR interval, and that was that was the answer. So I set November 25. Okay, so four minor criteria: polyarthralgia, fever, ESR CRP high, and prolonged PR interval. But ESR CRP, the ESR value is more than 60. Let us see what is happening in India in high risk population. In US, polyarthralgia was a minor criteria. Here, monoarthralgia is a minor criteria. So I'm highlighting it. On even a single joint having pain, we will consider as a minor criteria. Here, there is a typing error. There, fever more than 38.5 was the cutoff. Here, fever equal to or more than 38 is the cutoff. Cut this. Equal to more than 38 is the cutoff. And highlight this. During typing, sometimes errors can happen. Third, ESR and CRP was high there, ESR CRP high here. But what was the cutoff for ESR there? It was 60. Here in India, we follow the cutoff as 30. Prolonged PR interval there, prolonged PR interval, right? So this is the criteria. So major 5, minor 4. How do you make the diagnosis? Diagnosis of initial, now come here. Diagnosis of initial rheumatic fever is made if the patient is having 2 major manifestation or 1 major plus 2 minor criteria. And there should always be evidence of preceding group A streptococcal infection. Let us summarize it. What is the meaning? What it means is, first episode of acute rheumatic fever is diagnosed if a patient has 2 major criteria or 1 major plus 2 minor criteria. Yes, Aziz, CRP is only 3. It is milligram per deciliter. Many times the values are measured in milligram per liter, then the values change. So it is more than 3 is the cutoff that we take, milligram per deciliter. So first episode ARF, 2 major or 1 major plus 2 minor in the presence of any evidence indicating group A streptococcal infection, that is considered to be acute rheumatic fever. For any relapse, the criteria becomes 2 major or 1 major plus 2 minor or 3 minor alone in the presence of any evidence of group A streptococcal infection, right? There should be past evidence of streptococcal infection. It could be anything. Some blood test, some antigen test, some streptozyme test, some throat swab culture, ASO titer, anything, right? These are the tests that you will be reading in microbiology class. So microbiology educator will be telling you about this. So this is the diagnostic criteria. Did you notice I spent full 8 minutes talking about it? The reason is there is a recent question on this and fine points related to it are asked in the exam because examiners know people are reading rheumatic fever, but they are coming with a superficial knowledge. 5 major, 4 minor, dekh lenge. They check whether you know the thing to be remembered, different in low risk and different in high risk population. It will require a bit of reading again after the class, but once you read it 2 times, even a leisurely reading like reading Harry Potter, it should be fine for you, right? I hope you will never get the answer wrong, at least in these rheumatic fever question. Let us move further. Talk about treatment of rheumatic fever. Diagnosis already made. How would you treat? Treatment is different from prophylaxis or prevention. The type of treatment given in these patients is called as immunosuppressive therapy. You are trying to suppress the inflammation, but we don't use the usual immunosuppressive agents. It is also sometimes called as immunosuppressive therapy. First thing you need to remember is duration of therapy is always 12 weeks. You don't give therapy beyond 12 weeks in the patient. Treatment mein, there is no role of benzathine penicillin G. This is the mistake people make. We don't use antibiotic for treatment. Antibiotics are for prevention. क्योंकि देखो जब तक वो होता है तब तक already infection has been taken care by the body. So you suppress the antibody formation. So duration is 12 weeks. If patient has carditis with congestive cardiac failure, the drug of choice will be prednisolone given for 12 weeks. If it is carditis without CCF, carditis without CCF, you will be giving prednisolone. But if you feel prednisolone does not work, you can use aspirin also. And it is always a high dose aspirin which is used. It is always high dose aspirin. Low dose aspirin is antiplatelet, antithrombotic. I told you this funda yesterday also. And third, if there is no carditis, other manifestations are there. Others are there. For example, arthritis is there. Then prednisolone is not indicated. You use only and only aspirin. But the duration of therapy will always be 12 weeks. There have been questions asked on this. And people get it wrong because they immediately see benzathine penicillin G, mark it. Read the question. Are they asking treatment or are they asking prevention? Treatment, you give steroids or aspirin. Prevention, you give antibiotics. Right? So prevention is done by antibiotic prophylaxis. Prevention is done by antibiotic prophylaxis. What is the drug of choice? It is injection of benzathine penicillin G. They are given intramuscularly. Doses are there. You can remember the dose if you want, but those doses are not essential. They are given every 3 weeks. If the patient is having penicillin allergy, which is the agent you will be using? Either you can use macrolides like erythromycin, azithromycin, or you can go for sulfonamides. Either of the agents can be used. Right? So treatment के लिए different, prevention के लिए different. And then what is the duration? For how much time you will give prevention in the patient? This table will give you prevention or prophylaxis. So if there was rheumatic fever without carditis, the duration of prophylaxis will be 5 years after the last attack or 21 years of age, whichever is longer. Rheumatic fever with carditis, but no residual valvular disease. There was heart involvement, but no permanent damage to the heart valve happened. You will give for 10 years or till 21 years of age, whichever comes later. And if there is persistent valvular disease, suppose patient has developed mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, echo is abnormal persistently, you will give for 10 years or 40 years of age, whichever is longer. Sometimes lifelong prophylaxis is recommended. They will give a quick case scenario on this. There have been questions asked on this. They will say, a patient got rheumatic fever. This is the current age. This was the feature, carditis present, carditis absent, whatever they will mention, and they will ask, what shall be the duration of prophylaxis? This is the topic where MCQ solving is paramount important. Because if you don't solve MCQ, you will not get that confidence ki, question came and I was able to answer based upon the table. First thing is ratifying, mugging up the table. Second part is practicing it in MCQ. Anything goes wrong, read the table again, you will never forget. So this is rheumatic fever. I hope this is clear. Okay. So let us come to one-liners now. Let us do a rapid fire one-liner discussion. Most common manifestation in the Western world. In rheumatic fever के questions है. World West में सबसे common क्या है? Arthritis. High risk population इंडिया में सबसे common क्या है? Carditis. देखो 5 क्राइटेरिया है ना, तो इंडिया में सबसे कॉमन इज कार्डाइटिस. यू कैन रिमेंबर लाइक दिस. हम लोग थोड़े इमोशनल होते हैं, तो हार्ट कमजोर होता है, जल्दी इन्फ्लेम होता है. इट्स अ स्टूपिड वे टू रिमेंबर, बट यू कैन रिमेंबर लाइक दिस दैट कार्डाइटिस इज मोर कॉमन इन इंडियन rheumatic fever. Rare manifestation, erythema marginatum. Because we are brown people, our skin color is brown, and so erythema marginatum is not always visible. Erythema marginatum generally more commonly seen in the fair skin. Even small amount of melanin can sometimes obscure faint erythema marginatum. Late manifestation, which occurs many months after rheumatic fever, is chorea. Sometimes chorea comes. By that time, already rheumatic fever has been taken care by the body. Type of carditis in rheumatic fever, pancarditis. Pancarditis means all the 3 types of carditis are seen. There is pericarditis, there is myocarditis, and there is endocarditis. Among them, which is the one which is more severe? Generally, endocarditis is severe involved because endocardium is covering the heart valve, and endocardial involvement will lead to damage to the heart valve also. So all the 3 can occur. But which is the one which is severe and contributes to long-term morbidity? endocarditis, and I'm highlighting it here, you can get a MCQ on this particular point. Now, if you do myocarditis, what will you find? On myocarditis, you will find special nodules known as Ashkoff nodules. Ashkoff nodules is a pathology thing. This is already, it is a previous year question in pathology pond that you will see. Murmur in rheumatic fever, there is a murmur known as 𝗘𝗱𝗶𝗁𝗲 murmur. Carey and Coombs, two people described. Carey-Coombs murmur, it is a diastolic rumbling murmur. It is a diastolic rumbling murmur. Most common valve involved in rheumatic fever is mitral valve. Which valve is never involved? Pulmonary valve is never involved. So you can remember the sequence of valvular involvement like this. The sequence of valvular involvement is mitral, followed by aortic, followed by tricuspid, followed by pulmonary. Remember, in acute rheumatic fever, regurgitation is more common. Whereas in RHD, rheumatic heart disease, once permanent damage has happened, then stenosis is more common. Stenosis is. Let's move to the next thing. Mitral stenosis. Mitral stenosis, as I said, it's a hot topic right now. So narrowing of the mitral valve is mitral stenosis. It can be congenital mitral stenosis, which presents in the first 5 years of life. It can be acquired mitral stenosis. Acquired one generally occurs as a sequence, as a consequence of rheumatic fever and rheumatic heart disease. Now, what is the normal mitral valve diameter? There is a lot of controversy here. So normal mitral valve diameter is between 4 to 6 centimeters square. If it is less than 2 centimeters square, it is called as mitral stenosis. So normal is different and area to decide narrowing is different. If it is less than 1.5 centimeters square, we call it as severe MS. Some people say that it is less than 1 centimeter. That is also mentioned in some few textbooks, but we have to go by what are the current echocardiographic criteria. And these are the values which are given in American Heart Association AHA publication. So we are going with that. If the patient of ASD is having mitral stenosis together, that is called as a syndrome known as 𝗘𝗱𝗶𝗁𝗲 syndrome. 𝗘𝗱𝗶𝗁𝗲 syndrome. 𝗘𝗱𝗶𝗁𝗲 syndrome. Now, what are the findings that you will be see in a patient of mitral stenosis? This is the point on which maximum MCQs have been asked. First of all, when you do auscultation in these patients, see, clinical features are very non-specific. They are very difficult to distinguish. Symptoms are very difficult to distinguish from any other cardiac lesion. They may have features of dyspnea, cyanosis. They may have not cyanosis, sorry, dyspnea, CCF, fatigue. Those kind of symptoms can be there. Many times it is asymptomatic. When you do auscultation, first of all, you will find the first heart sound is loud, also written as accentuated. It is loud or it is accentuated. Second heart sound may be normal or it may have a loud P2 component, either normal or loud P2. But the hallmark of the disease, hallmark means something which is always present, that is abnormal sound present after S2, we call it as opening snap. It resembles S3, but with experience, you will learn that it is a different heart sound, opening snap. It is a high-pitched sound which occurs after S2. So opening snap is also written as OS. And a very, very important point, A2OS gap. A2OS gap means the gap between the second heart sound aortic component and the opening snap. It is inversely proportional to degree of mitral stenosis. Gap increases, MS is mild. Gap decreases, MS is severe. So it is inversely proportional to degree of MS. It is a statement-based question which has been asked in the exam. Opening snap is present. And what is the type of murmur which can be seen? Can a murmur occur? Yes, there can be a low-pitched A rumbling, diastolic murmur can occur in these patients. Low-pitched rumbling diastolic murmur can occur at the apex. These findings are extremely important. Now, what you will see in chest X-ray features of these patients. Chest X-ray feature, first feature will be left atrial enlargement. So there will be left atrial enlargement. Left atrial enlargement is the characteristic finding which is seen. Left atrial enlargement can lead to straightening of the heart border. It can lead to straightening of the heart border, and sometimes it can produce a sign known as double density sign. Double density sign is the sign which can be produced due to left atrial enlargement. Secondly, these patients can have a prominent main pulmonary artery. PA is pulmonary artery. Prominent main pulmonary artery. Third, these patients can have posterior displacement of the esophagus, although it may not be easily appreciated on a PA view of X-ray. Posterior displacement of esophagus. And fourthly, in long-standing or severe cases, in severe MS, there will be features of pulmonary hypertension. So pulmonary hypertension features will appear in the patient. Now, what is the treatment that we are going to do? Treatment part is interesting. If it is mild to moderate MS, then you will give medical therapy, symptomatic therapy for the symptoms will be given. But if it is severe mitral stenosis, the first line therapy these days is a procedure known as PMPV. What is PMPV? Percutaneous mitral balloon valvuloplasty. Basically, we don't do open surgery. So it is a relatively less invasive way. We pass a catheter through a femoral vein or through the subclavian vein, reach till the mitral valve, and we try to dilate using a balloon. We open it, inflate it, and try to dilate the stenosis. That is PMPV. However, PMPV is contraindicated if there is left atrial thrombus or if there is some coexisting abnormality. So if PMBV fails or it is contraindicated due to some other reason, then you have to do mitral valve replacement. And this particular thing is important. NEET PG questions have been asked on the treatment part. So this is mitral stenosis. I've gone slow, but I've tried to cover what the bare minimum important things that you need. Now let us move over to some ECG scenario and related points we will be doing in a rapid fire. Photograph, what is to be seen, what all can be asked, what is the treatment. That is how we will be proceeding. So let us start. There is aortic regurgitation also. Then we go for ECG pattern. Really sorry. Aortic regurgitation, what are the signs? Occasionally the signs are asked in the exam. There was an MCQ asked in the exam where they said all of the following are signs of aortic regurgitation except. Now, aortic regurgitation again is a feature of RHD. RHD is the common cause which can cause it. Aortic regurgitation, there are some signs. First of all, we have the Corrigan's pulse. What is Corrigan's pulse? There will be rapid and forceful distension of arterial pulse with quick collapse. Hits hard and then goes back fast. That kind of pulse is Corrigan's pulse. What is de Musset sign? We don't call it as de Musset, de Musset sign. If you observe these patients in a large AR, there will be subtle head bobbing happening. That head bobbing is called as de Musset sign. Then Muller sign is you examine the oral cavity with a torch. Ask the patient to open the mouth and look at the uvula. Uvula is present at the back of the throat. There will be pulsations present in the uvula. That is called as Muller sign. Then we have Quincke's sign. In Quincke's sign, there will be nail bed. When you compress it, you will find that now you can do one thing. When you compress your nail bed, the nail bed becomes the distal part becomes white and the proximal part is pink, right? Can you see any vessels? No. But in patients with aortic regurgitation, on the nail bed where this semilunar thing is there, you will find dilated vessels to be present or pulsations to be present where the skin part is attached. So small pulsations will start happening there. So these capillary pulsations, they are better seen than felt. They are Quincke sign. Then systolic and diastolic pistol short femorals, that is pistol short sound will be heard over femoral artery when you do auscultation, Probe sign. What is Durosia sign? Bruise will be heard over the femoral artery. And finally, Hill sign. You see the gap in the BP between lower limb and upper limb. See, in coarctation of aorta, the upper limb BP is more, lower limb BP is less. Here, reverse happens. The lower limb BP is more, upper limb BP is less. And the difference between them is 60 millimeters of mercury. Remember, the upper limb BP is on the lower side and lower limb BP is on the higher side in these patients in aortic regurgitation. And the difference between them, if it is 60 or more, that sign is known as Hill sign. Right? So these are some of the named signs. This table I've taken directly from a textbook. It is there in the Google images as well. So this is important and they are asked. What are the things on which question has been asked? Hill sign has been asked and Muller sign have been asked. So if nothing else, at least the previous year topic and previous year question one-liner, you have to remember. Now let us start with abnormal ECG. Look at this ECG pattern. They will not give you a random ECG. There will always be a history or something mentioned alongside. Those who have sit in the exam, they know. They mention a one line and then they mention ECG. At least they mention risk factor or age of the patient. Now they will say there is a patient with, look at these patterns. They will say patient with acute kidney injury, या chronic renal disease, chronic kidney disease, or acidosis patient, or tissue injury patient is having ECG abnormality as shown. What is the likely diagnosis? AKI, CKD, acidosis, tissue injury, all four conditions predispose the patient to hyperkalemia. With this in mind, V4, V5, V6 leads, we see what is happening here. This is your P wave. This is your QRS complex. And look at the T wave. The T wave is large. Giant T waves are present. Giant T waves, tall T waves, peaked T waves, if they are present. What is the likely diagnosis? The patient is suffering from. What is the likely diagnosis? The diagnosis is hyperkalemia. Absolutely right, Edwin. Hyperkalemia is the answer. What is hyperkalemia? When the serum potassium becomes greater than 5.5 milliequivalents per liter, that is called as hyperkalemia. What are the signs of hyperkalemia on ECG? I'm writing it here. I'm writing it here in this part because there is no space. Originally I had kept some space. So the ECG findings of hyperkalemia, there will be peak or tall T waves. That is an early sign. Then there will be widening of PR interval as well as widening of the QR interval. And later on, these patients will develop loss of P waves. But loss of P waves generally occurs late or in severe hyperkalemia. This is the sequence which occurs that you need to know. The sequence is also important. It is a NEET PG MCQ. This is the sequence that you are supposed to know. What is the management that you are going to do in the patient? Now, management of hyperkalemia has been asked 4 to 5 times in FMG exam already, and still people get it wrong. Let us do a quick fire management. Patient with hyperkalemia comes to you. What is the first step in management? Hyperkalemia can cause life-threatening arrhythmia. So our first thing is save the life. Potassium value we will manage later. First is save the life. So you stabilize the cardiac membrane so that arrhythmia does not happen. So first step is stabilize the cardiac membrane. And how do you stabilize the cardiac membrane? It is done by IV calcium gluconate. Doses they will not ask. IV calcium gluconate, that is always the first step in management. Good, absolutely right. After taking first step, after giving calcium gluconate, start with the second step. As a second step, you will try to reduce the serum potassium levels. You will reduce the serum potassium levels. How do you reduce serum potassium level? First thing, we start two things together. We do two things together. We start the patient on IV dextrose along with IV insulin infusion. IV dextrose and insulin, not given as bolus, started as infusion, and you need to monitor the blood glucose as well. Simultaneously, you nebulize the patient with salbutamol. Salbutamol is a beta agonist. Due to beta agonist action, it causes inward movement of potassium inside the cell. It also takes care of acidosis because acidosis can worsen the patient. Salbutamol helps indirectly without giving bicarbonate. Some degree of acidosis is also corrected in these patients. So nebulize with salbutamol. Salbutamol is also known as albuterol. If this is not working, as the second step, you will go for sodium bicarbonate. Second step, you will go for sodium bicarbonate. Remember that sodium bicarbonate is never the initial step, and generally the world is moving away from sodium bicarbonate. I'll write like this. Many of you might have forgotten the symbol of sodium. So sodium bicarbonate is given. It is given only in acidosis patient if acidosis is persisting. Acidosis is persisting. That will not allow hyperkalemia to improve. And if still not improving, you can consider loop diuretics or hemodialysis, that is renal replacement therapy, can be tried. This is the management of hyperkalemia. Remember that potassium binding resins do not have a role in acute management. They are useful in CKD patient, but they do not have a role in the acute management of the patient, right? So yes, insulin, this insulin, when we say insulin, we are talking about regular insulin. Okay, this is the nomenclature we follow. So regular insulin is the one which we are using. Okay, first topic, identification done. What else can be asked? NEET PG MCQ covered, and management related questions which are asked in FMGE covered. Let's go to the second one. There is a patient who has history of starvation, alkalosis. Acidosis causes hyperkalemia, alkalosis causes hypokalemia, dehydration, and drug intake. Many drugs have a tendency to cause hypokalemia. ECG is as shown. Now in this ECG, what you can see? You will see that the T wave is not tall. T wave is either flat or it has inverted. Here, inversion of T wave has happened. And after T wave, an abnormal U wave is happening. Between T and P wave, you have an abnormal wave. We call it as U wave appearing. Either flattening of T wave or inversing of T wave with a U wave in a patient with risk factor. The likely diagnosis in the patient is hypokalemia. So patient is having hypokalemia. What is definition of hypokalemia? Serum potassium less than 3.5 milliequivalent per liter. Serum potassium less than 3.5 milliequivalent per liter. Now, what are the ECG findings that you will see in these patients? So I'm writing on the next page, ECG findings. ECG findings of hypokalemia. ECG findings, early sign will be T wave flattens. First of all, T wave will flatten. Then patient will have T wave inversion. And when T wave inverts, only then patient will have abnormal wave known as U wave appearing. Apart from that, what are the other ECG changes which can happen? These patients can have prolonged PR interval, and they can also have ST segment depression. ST segment depression can also occur in the patient. So these are the other findings. They have not been asked, but because hyperkalemia, other ECG changes have been asked, so we have to remember these changes as well. Now, what is the management? Contrary to popular perception, hypokalemia is always measured more conservatively because giving potassium actually is problematic. Sudden potassium given IV can induce arrhythmias. So we always start with oral potassium supplementation. So oral KCl is always the preferred way, is always the best way. And how much we give? We add to IV. We give the maximum amount of KCl that is given is equal to or less than 200 milliequivalents of KCl of potassium in 24 hours. So the amount of potassium given is equal to or less than 200 milliequivalent of potassium in 24 hours. And we monitor for hypomagnesemia as well, because many patients can have associated hypomagnesemia as well. And there is an indirect MCQ asked on this already. The question is something like this. Listen to the question. It's a pediatric question. There is a severe acute malnourished child who presented with diarrhea. The patient was managed for dehydration but ECG revealed hypokalemia, which was corrected. However, muscle weakness is persisting in the patient. What other abnormality should be looked out for and corrected in the patient? The options were hyponatremia, hypernatremia. See, they would have already been corrected now because potassium correction we are doing very slowly. So which other thing can mimic and can lead to persistence of symptoms? And you need to watch it out for hypomagnesemia. And that is the answer. So there is an indirect MCQ already asked on this. Mechanisms, again, not needed from exam perspective. There are mechanisms, you can always reach out if you want, but not needed close to the exam. Right? Topic is done. Let's move further. Third scenario. What are you looking at in the third scenario? In the third scenario, there is a abnormal thing happening. There is a, look at this. There is a P wave, there is a QRS complex, and what has happened here? Can you see that there is something wrong? There is something wrong happening here. Some wave is happening close to this wave. What is this wave known as? Yes, this is the wave which is appearing. This wave which is appearing, this T wave is a bit delayed. Any wave which is present just after the QRS complex is over and forming a small, this point is called as the J point. This is also called as a J point wave. This is called as Osborn wave and it is indicative of hypothermia in the patient. So this is a Osborn wave. So label the image Osborn wave. What is Osborn wave? It is a small positive wave which is present at the J point on ECG. What is J point? J point is the point where QRS complex ends and ST segment begins. So that point is called as J point. And what is the most common cause of Osborn wave? It is seen in severe hypothermia. It is seen in severe hypothermia. Can it occur in other conditions? Yes, it can occur in hypocalcemia also. So hypocalcemia can also produce a Osborn wave in the patient. Let's move further. Now, this is a scenario which has been asked 2 times in INI CT also and once in FMG exam as well. So actually, I should be putting 3 questions on this. So there is a patient who presented with palpitation. Palpitation is a symptom. Patient feels, the beat in his chest. There is a, normally your heart is beating, but you don't feel it. When you feel, that is palpitation. And irregular pulse. This is a very, very important clue. There are very few causes of irregular pulse. When you look at ECG, what is the finding that you are seeing? You will find, first of all, there are narrow complex QRS in the patient. So these are all narrow QRS complexes which are forming. And there is absence of P waves. And there is a baseline which is fibrillating. Can you see this fibrillation of the baseline? And the frequency is variable. This is all fitting into a diagnosis of, absolutely right, atrial fibrillation. So the likely diagnosis in the patient, look at this photograph, we will label it. This is the patient with atrial fibrillation. The diagnosis is atrial fibrillation. Why do I say this is atrial fibrillation? देखो अभी तो आप सुन लोगे. Many of you are young MBBS students who are listening to this for the first time. Many of these things will make sense much later when you read in detail. But why am I saying this is atrial fibrillation? Pehla clue is irregular pulse. Watch out for this word. Second, in this patient, there is narrow QRS complex. Can you see any P wave? The P waves are hardly visible. So P waves are not clearly seen. And third, there is a, undulating baseline. So baseline is showing fibrillations. Baseline is undulating, it is showing fibrillations. That is why we call it as atrial fibrillation. Okay. Now, what is the management that we are going to do? Management is important. Management is divided into 2 parts. First thing, any atrial fibrillation patient comes to you. 2 possibilities are there. First possibility, the patient is hemodynamically stable. There is no shock. Many patients present in shock. So hemodynamically stable patient. And the duration of atrial fibrillation is less than 48 hours. It has been recent onset atrial fibrillation. In these patients, the therapy of choice, this is a previous year FMG question already. The therapy of choice will be cardioversion. You will be doing cardioversion. Absolutely right, Edwin Shaju. cardioversion. Two types of cardioversions you can do. Either you can go for electrical cardioversion. It is also called as DC cardioversion. Or you can go for drug-induced cardioversion. Drug-induced cardioversion, the drug used for this is ibutylide. Ibutylide is the drug which is preferred. It is a class 3 antiarrhythmic agent. Class 3 antiarrhythmic agent. On the other hand, if the patient is hemodynamically, see, this is unstable patient, hemodynamically unstable, you have to give shock. If the patient is hemodynamically stable, or the patient has already adjusted, he's adapting, the duration of atrial fibrillation is equal to or more than 48 hours. Then there are two problems. First of all, the response to cardioversion may not be adequate. Secondly, you need to provide anticoagulation because they may already have a thrombus formation happening in the atria, and that can cause embolism. So if it is hemodynamically stable or duration more than 48 hours, the first thing to do is do the rate control. Control the rate of the patient. The heart rate is very high, so control the rate. What is the heart rate in these patients? It is quite high. It is somewhere around 160 per minute. So you will control the rate. The drug of choice for these patients is short-acting beta blocker like esmolol. Okay. And after controlling the rate, if beta blocker is not possible, second possibility, you can go for calcium channel blockers like verapamil as well. After the rate has been controlled, as a second step, you will add anticoagulation in the patient. You will do anticoagulation in the patient. Anticoagulation in the patient. Generally, warfarin is preferred if there is a patient with underlying RHD or MS patient. So any rheumatic heart disease or mitral stenosis patient with atrial fibrillation, warfarin is used. But in the other agents, in the other conditions, you can go for apixaban or dabigatran in case of other causes or unknown causes of atrial fibrillation. And lastly, once anticoagulation has been maintained, then you will go for rhythm control. In these patients, as a third step, I'm writing on the next page, there is no space here. So as a third step, you will go for rhythm control. And this rhythm control can be done by either beta blockers or by catheter ablation. So you will ablate the focus from where this fibrillation is arising. I'm zooming out. It's tough, I know, but you have to remember stepwise management. It's a tough topic. It's a topic in which a lot of scenario-based things are asked. So defibrillation, cardioversion, see these terms, again, it's not the place where we should be discussing. If there is defibrillation, cardioversion are basically many times synonymously used, but they are not the same. So cardioversion means you are reverting to normal rhythm, right? So defibrillator is the name of the device through which you can do cardioversion. But the name used in the standard guidelines is cardioversion. So returning to normal rhythm. Okay. So stable patient, you will be going for drugs. Unstable patient, you will be going for either electrical cardioversion, shock to the patient, DC shock, or you will give drug-induced cardioversion. Right? I hope it is clear and you will not get it wrong again. Okay, easy thing. Next question. Look at this. What can you see in this patient? These are the waves. Remember this photograph. These waves are what you call as sawtooth waves. I'm mentioning it here. Sawtooth waves. Examiner will say there is tachycardia. ECG is showing sawtooth waves. What is the likely diagnosis? The sawtooth waves are seen in a patient with atrial flutter. Atrial flutter. Atrial flutter is relatively less common compared to atrial fibrillation. Treatment of atrial flutter, if the patient is hemodynamically unstable, you will again do cardioversion, DC cardioversion. Shock will be given. But if the patient is hemodynamically stable, you will start the patient on IV beta blockers. IV beta blockers will be given. No, adenosine is not the first line therapy. Adenosine is preferred in SVT, that is supraventricular tachycardia, also called as PSVT. So we'll be coming to PSVT, don't worry. In fact, the next topic is PSVT. Look at these images. First of all, these patients are having a narrow QRS complex. Examiner will say there is a patient with palpitations or some risk factor will mention there is narrow QRS complex. There is P wave is not visible. P wave is not visible. Okay, there is no P wave visible, and there is no, and the rhythm is regular. It is not irregular. The rhythm is always regular. Because if it is irregular rhythm and undulating baseline, it will go in favor of fibrillation. So narrow QRS complex, P wave not visible, rhythm is regular. This is fitting into, remember this photograph. Sometimes ST segment depression can occur, although it is not visible in these patients. The likely diagnosis is PSVT, also known as SVT. PSVT, there is sinus rhythm. Yes, it is sinus rhythm. So PSVT, that is paroxysmal supraventricular tachycardia. There is another name of this. It is also known as AV nodal reentrant tachyarrhythmia. This is the other name. Other name is very important. Many of us have other names. One is our name which is written on our degree. Second is the name by which we are called at home, right? Home name. Third is the name you get in MBBS time. Your friends call you by that name. Fourth name is the name you get in your personal life. I'm quite sure these three milestones you have attained. Fourth milestone you may or may not have been attained, but nobody passes or becomes a professional before going through all these four milestones. So similarly, MCQs, questions get repeated. Examiner changes the name of the condition. So PSVT is the same. AV nodal reentrant tachyarrhythmia. This is the technical name of the condition. So PSVT, what is the treatment we are going to do? Treatment of PSVT was asked in FMGE and NEET PG 2023. There was a question on PSVT management. So treatment, again, same. If the patient is hemodynamically unstable, you will be doing synchronized DC cardioversion, also written as simply cardioversion. And if the patient is hemodynamically stable, first you will do vagal maneuvers like carotid massage or Valsalva, and then you will arrange and immediately try to give adenosine to the patient. Adenosine is always given by flush method. Adenosine is given by flush method. Adenosine is given. Alternative to adenosine is verapamil. So very, very important. Please add it to the notes. This is something you have done already. This is something you have already read about. So PSVT is done. All these ECGs are easy to remember. I'm just asking you to have a look, take a pause again. They will say acute kidney injury patient, trauma patient, V5 is showing the following. Now look at P wave. P wave is normal. Is there any tachycardia? No, tachycardia is not visible. QRS looking fine. What about T wave? Where is the T wave going? Tall T wave. This is hyperkalemia. And the options will also have hyperkalemia, hypokalemia, hypomagnesemia, and so on. You understand? Look at this inverted T wave and U wave. They will not give you a very borderline ECG. They will give you such an ECG, provided you are not partially blind and you know what is to be seen, you will reach the correct answer. Third thing, look, they will say there is a patient, who has come from a hiking expedition and his heart is showing waves like this. So there is a J point wave where the ST segment begins. There is a small positive wave happening just close to that, to the QRS complex. Adjacent to that, that is Osborne wave. Look at this. Undulating membrane, irregular pulse, QRS complex. Rhythm is not sinus, atrial fibrillation. Look at this sawtooth wave, very easy to identify. In fact, same photograph I have been seeing since so many years in the exam. And finally, PSVT. Regular rhythm, sinus rhythm, and narrow QRS complex, P wave not visible. And options will have options like adenosine, cardioversion, etc. You will immediately come to know it is PSVT. Let's move further. There is no space, extra space has been given where it was not needed. Look at this photograph. What you can see in this patient. What you can see. Now, this is a patient where delta waves are coming. Normally what happens is, let me tell you, Normally you have P wave, then you have QRS, and then you have T wave, right? In these patients, what happens is there is P wave, then instead of a sharp rise, there will be a gradual rise. There will be a curve like this, and then the QRS complex will come. This elevation which has happened, let me show it like this. Ideally, it should have come to baseline and then it should have gone like this. This elevation which has come here, this angle which has formed is called as delta wave. So this is a patient having delta wave. So I'm labeling it. This is what you call as delta wave on ECG. And delta wave on ECG is characteristic of which condition? It is seen in patients with WPW syndrome. WPW is also known as Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. These are the patients who are having antidromic tachycardia. The mechanism involved is antidromic tachycardia because there is an accessory pathway which is found in these patients. So they have antidromic tachycardia. What is the MCQ point? What is the underlying congenital heart disease? Congenital heart disease with WPW syndrome. It is Epstein's anomaly. It is Epstein's anomaly. Epstein's anomaly. Treatment of the patient. Again, same thing we will remember. If it is an unstable, hemodynamically unstable patient, you will go for cardioversion. And if it is a stable patient, the drug of choice will be procainamide. Intravenously, procainamide will be given to the patient. IV procainamide will be given to the patient. Yes, DC cardioversion or DC shock will be given. WPW syndrome. Close to the exam, keywords are important. Diagnosis ban jayega. Word miss nahi hona chahiye. Next thing, look at this photograph. Examiner will say, now what we are having here is, can you see oscillatory changes in the amplitude of QRS complex? Slow se bada घट गया, went up, came down, went up, came down. And plus, you will find that there is no P wave visible, right? This is a generalized electrical activity. So you would write like this. There is oscillatory amplitude, increasing and decreasing of QRS complexes, and there is no visible P waves or significant T waves. And there is a irregular kind of a rhythm which is happening. This condition is called as Torsades day points. Torsades day points. Torsades day points can lead to, yes, polymorphic ventricular tachycardia, and Torsades day points can be associated with prolongation of QT interval as well. The drug of choice in Torsades day points is magnesium sulfate. This is a previous year question. So drug of choice in Torsades day points is magnesium sulfate. Next photograph. What you can see in the next photograph? Can you see that there is tachycardia with very broad QRS complexes and absent P waves? Absent P waves. So this is what you call it. So I'm labeling it broad QRS complex, absent P wave. Remember the photo also. Absent P waves. But there is no undulation which is happening. This is a patient with ventricular tachycardia, also called as monomorphic, because the morphology is same throughout. QRS complex is having the same morphology. So monomorphic ventricular tachycardia is there, right? So this is monomorphic ventricular tachycardia. So all examiner will ask you is to make the diagnosis. Because VT, VF, eventually management we will do in the end. We have to make a small chart out of it. Finally, they have given space where it was not needed. They have not given space where it is needed, but it's okay, we'll manage. Look at this photograph. What is happening here? Chaotic rhythm, chaotic wave, and no P wave, no QRS, no T wave, irregular rhythm, non-specific rhythm. And intermittently, the baseline starts fluctuating as well. So this is ventricular fibrillation. Ventricular fibrillation. In atrial fibrillation, the QRS complex is narrow and QRS complex is still present. Here, no identifiable P or QRS complex is there. So this is ventricular fibrillation. It is the easiest to identify in the exam. If you're not able to identify ventricular fibrillation, something seriously wrong. Remember photograph like this. The photograph will be something like this. Let me tell you, photo will be something like this. If I have to make, I will be making like this. Right? You get photo like this, something which you can make is ventricular fibrillation. One straight line is cardiac arrest, and second easy line to make is ventricular fibrillation. So ventricular fibrillation, there is chaotic electrical activity with no pattern. There is chaotic rhythm, chaotic rate. There is no P wave, no QRS, and no identifiable T waves. No identifiable T waves. It is also known as, it is an example of shockable cardiac arrest rhythm. It is an example of shockable cardiac arrest rhythm. How do you treat these patients? Any patient comes to you with, any patient is found unconscious. Any unconscious patient, unresponsive patient is C. Unresponsive patient is C. Immediately start CPR. Start CPR. So first thing to do in any unresponsive patient is start CPR. CAB, compression airway breathing. That is the sequence to follow. Check the rhythm. Check the rhythm. Check the rhythm. There will be two possibilities. It is shockable rhythm. Shockable rhythm will be ventricular fibrillation or pulseless ventricular tachycardia, as it is written as PVT. In shockable rhythm, you will give shock to the patient. Give shock to the patient. And if it is non-shockable rhythm, that is, there is no rhythm at all, asystole is there. Asystole. In these patients, you will give epinephrine. You will give epinephrine and continue CPR. You will continue CPR. There have been 3 MCQs asked on this. 3 MCQs asked on this. It's very, very important. Let me tell you a very interesting fact. Very, very interesting fact. What happened was, like about 2 or 3 years back, if you solve PYQ, you will find a question in FMG exam. The question was, they had given this rhythm. Like, I'm not showing it here. Let me show somewhere. So they had given a rhythm like this. They said there is a person and the patient has a rhythm like this. This is the rhythm. Okay. They said, what is the immediate next step in management? Many people marked DC shock as the answer. When I asked them, ki, sir, why did you give DC shock? Why did you give DC shock? They said, sir, movies mein to yahi dikhaya hai. Have you seen those movies? Not just our Indian movies, but even in Hollywood movies. Cardiac rhythm becomes flat, ECG becomes flat. What people do? Everyone get away. They take those two, those pads of giving defibrillator, and they start giving shock. 1 shock, 2 shock, 3 shock, 4 shock. Sometimes they keep on giving 7, 8 shocks, sad music playing in the background. Then somebody starts praying, or a heroine comes and picks up the hand of the hero. Shock is being given, by the way. And suddenly the rhythm comes back. This is absolute rubbish. This is not the way you treat a patient, right? Everything is wrong with this thing. Actually, what happens is, if there is asystole and there is no cardiac rhythm, it is not a shockable rhythm. What you are supposed to do, you are supposed to give CPR and give epinephrine to the patient, and that will be your answer. It's a small thing, but people make this mistake. It's a mistake we all make. So you have to see the rhythm and then decide. And even if the rhythm, you don't have the time, the first thing to do in any unresponsive patient is what? You have to start CPR. Compression airway breathing is what you have to start in the patient, right? Very important. Keep this. You can get a fresh question on this as well. Absolutely right. Let's move further. So where have we reached? We are on to the scenarios now. So let us look at the first scenario. Examine now these 2 scenarios which I'm going to discuss. They are very important and they have not been asked in the recent couple of exams. So they are waiting to be asked. It's like a high quality batsman not scoring runs. It's like Virat Kohli not scoring runs, people saying Virat Kohli finished. Then there is a match against Australia or Pakistan, and suddenly he comes back into form. It's like that only, right? So I'm just giving an example. So this topic is like that. So look at the first topic. A patient is being evaluated. The patient is having muffled or absent heart sound on auscultation. There is low BP, that is hypotension, but the JVP was raised. If all the three are present, this is considered to be the classic triad. It is called as Beck's triad in the patient. And if there is Beck's triad present, Beck's triad has been asked 2 times in FMG exam. The likely diagnosis in the patient is cardiac tamponade. Cardiac tamponade. Cardiac tamponade. Now, regarding cardiac tamponade, what is cardiac tamponade? It is not the same as pericardial effusion. Small amount of fluid in the pericardial space is pericardial effusion. Any massive pericardial effusion which does not allow expansion of the chambers interferes with filling of the heart. That is called as cardiac tamponade. Now, cardiac tamponade can have multiple causes. It can be a part of trauma. It can be traumatic. It can be due to tumors. Many times, lung cancers can cause it. Breast cancers can cause it, or metastasis to the heart can cause it. Now, about cardiac tamponade, there are a few one-liner points which are important. First of all, cardiac tamponade patients will be having raised JVP, but it is non-pulsatile. The pulsatile nature of JVP is not there. Second, these patients have low ECG voltage because the cardiac signal will be muffled by all the fluid which is surrounding the heart. So low ECG voltage will be there. Some patients will have alternation of the electrical activity. We call it as electrical alternance. And Kussmaul sign will be absent. Kussmaul sign will be absent. What is Kussmaul sign? Kussmaul sign is normally when you take deep inspiration, there is a fall in BP. If the BP doesn't fall or it paradoxically rises, that is Kussmaul sign. Kussmaul sign is absent. It is used to distinguish cardiac tamponade from similar conditions. And some patients may have pulsus paradoxus. Pulsus paradoxus may be present. And what is the treatment of cardiac tamponade? It is pericardiocentesis. You try to drain the fluid which is there. Pericardiocentesis, right? These are the key points. There are more points, but these are the ones I would make sure to remember, revise before I sit in the exam. Then second point, second group of symptoms, examiner will say congestive cardiac failure is there. So pedal edema, raised JVP, all these features are there. Jugular venous distension. Kussmaul sign is present. If Kussmaul sign is present, it cannot be your cardiac tamponade. And pericardial knock is present. What is pericardial knock? It is a early S3 sound. Early S3 sound, also known as a diastolic sound. It is a loud diastolic sound which is heard in these patients. If you have a presentation like this, the likely diagnosis in the patient, constrictive pericarditis. How do you distinguish between the two conditions? On JVP, I will be coming to that. There is a separate table for this. I know, don't worry. मैंने भूला नहीं हूं मैं, वो लिखा है नीचे, ये देखो टेबल है आगे, आएंगे उसके ऊपर भी. So let's finish the topic first of all. So constrictive pericarditis is the likely possibility. What is the most common cause in India? It is TB pericarditis. Tuberculosis is the most common cause of constrictive pericarditis. And in these patients, you will have sometimes there will be a sign known as broad bent sign. Broad bent sign. Second sign which can occur on echocardiography is a sign known as square root sign. The name of the signs are important. Details you can read from your detailed notes if you have. So echo will show square root sign in these patients. And what is the treatment that we are going to give? In these patients, the treatment will be pericardial resection. So pericardium needs to be removed. It is also known as pericardial peeling or pericardial resection will be needed in constrictive pericarditis. Now, a very interesting thing on which a lot of questions are asked is, how would you distinguish between the two conditions, cardiac tamponade and constrictive pericarditis, based upon jugular venous pressure? JVP is elevated in both. It is always non-pulsatile there. It may or may not be pulsatile here, right? but JVP waves help you in reaching the correct answer. So what do we find in these patients? Look at this table. So we look at the two descents on the JVP wave, X descent and Y descent. In constrictive pericarditis, the X descent is present, it is prominent, and Y descent is also present. So both X and Y descent present is constrictive pericarditis. However, only X descent present and Y descent absent goes in favor of cardiac tamponade. This particular thing again has been asked multiple times. It has been asked multiple times. And you can put a star and write upwards that the rapid X descent, sorry, the rapid Y descent in constrictive pericarditis is also known as Friedrich sign. So Friedrich sign is again present only in constrictive pericarditis and not cardiac tamponade. Right? So this is the difference between the two conditions. So इसीलिए मैंने बोला XY descent हम करेंगे लेकिन end में अलग से करेंगे. Right? So these are some of the ECG scenarios. Next thing, acute coronary syndrome. Now, acute coronary syndrome is a condition in which there is acute interruption of oxygen supply to the cardiac tissue. The syndrome arising because of that is called as acute coronary syndrome. First thing you need to understand that your anginas, MIs, they all come as acute coronary syndrome. But there is another variety known as Prinzmetal angina, which is generally not considered a part of this. Because Prinzmetal angina is more of a vasospasm rather than an obstruction of blood supply and oxygen to the cardiac tissue. Right? So acute coronary syndrome is a general term whenever a patient presents with retrosternal pain with or without associated with radiation of the pain, diaphoresis, that is increased sweating, or any other symptom which can be attributed to cardiac illness. So whenever acute coronary syndrome patient comes to you, how you are going to approach and how you are going to manage the patient. So it's a summary kind of a thing we will be discussing. A lot of scenarios I will be discussing here. Suppose there is a patient who comes to you with retrosternal chest pain. See, the details are there in your existing notes as well. So what I will be doing is retrosternal chest pain. So retrosternal chest pain patient comes to you. What is the first step in the management? The first step in the evaluation will be do ECG. Never do cardiac biomarkers directly. Always do ECG in the patient. Now there will be two possibilities if it is acute coronary syndrome. First possibility, there is no ST segment elevation. And second possibility, there will be ST segment elevation. Whether ST segment elevation is there or not, as a second step, you will be doing cardio biomarkers. Do cardiac biomarkers. So biomarkers like troponin I. I is better than T, so troponin I will be done, and you will be doing CPK-MB. Many times LDH is mentioned in the theory notes, but it is not generally done. If there is no ST segment elevation and you do cardiac biomarkers, there will be two possibilities. So remember the findings here. First step is always ECG. Second step is always cardiac biomarker. When you do cardiac biomarker, there will be two possibilities. The cardiac biomarkers are normal. And second possibility, biomarkers are elevated. The biomarkers are high. If biomarkers are normal, the patient is likely suffering from a disease known as unstable angina. And if the patient is having biomarkers which are high, the patient is likely having non-ST elevation MI. We call it as NSTEMI. Non-ST elevation MI is known as NSTEMI. Okay. If the patient is having ST segment elevation along with biomarkers being high and ST segment elevation is also there, the likely diagnosis in the patient is STEMI. That is ST segment elevation MI. So you will have three possibilities: unstable angina, non-ST elevation MI, and ST elevation MI. Remember that unstable angina as well as unstable angina, there is no role of fibrinolysis. There is no role of fibrinolysis. Whereas in patient of ST segment elevation, fibrinolysis is effective. So dissolving the clot is effective in ST segment elevation MI in the patient, right? So this is first how we make the diagnosis, the diagnostic approach to making the diagnosis. Also, whenever you talk about ST segment elevation MI, ST segment elevation, you have to see the type of MI also, where the elevation is happening. If the ST segment elevation occurs, if it occurs in leads V1 to V4 as well as AVL lead, the patient is likely to have anterolateral MI. Anterolateral MI. If the ST segment elevation occurs in leads 2, 3 and AVF, then the patient is having a inferior wall MI. Inferior wall MI. If the patient is having ST segment elevation in V1 to V3, if it is associated with, you would write reciprocal depression. The word is reciprocal depression in leads V1 to V3. Instead of elevation, there is a reciprocal mirror image depression happening. Then you would suspect patient is having posterior wall MI. These terminologies are important, and most of the MCQs which will be asked to you in FMG exam, they will be either anterolateral MI or there will be inferior wall. Posterior wall MI can occur, but generally examiner will mention that it is posterior wall MI, right? Because it is very unlikely that entire detailed, that strip is given to you. Let me tell you why. In the actual exam, the ability to zoom in is not there. Have you noticed those who have given the paper? You cannot zoom in. And so it becomes very difficult to put up multiple images as along with the MCQ. So generally examiner will put questions. This is a technical thing to understand. Generally they will put questions on anterolateral MI or inferior wall MI where you have to make the diagnosis. If they have to make a question on septal MI or posterior wall MI, they will not ask you to make the diagnosis. They will mention that posterior wall MI is there in the patient, right? It's a small hack which you can utilize when you are answering the question. Now the question arises how you are going to actually manage the patient. So management, first of all, initial therapy. So I'm giving the heading. The next page is empty. I'm giving the heading management of acute coronary syndrome. So any acute coronary syndrome patient comes to you, whether it is MI or non-ST elevation MI, the initial therapy will always be starting the patient on MONA. Starting the patient on MONA. Now, when you start MONA, the conditions include, now variations of MONA have been described, but still the traditional teaching has been you talk with MONA and then you add the other drugs. So morphine is given for pain relief. Oxygen will be needed in these patients. Nitrates will be needed in these patients. And antiplatelet agents will be needed in all patients. They had to be started in all of these patients. Antiplatelet agents will be added. Now, what is the best antiplatelet agent? It is not aspirin alone. We always give a combination of aspirin along with another antiplatelet agent, ticagrelor. So you will combine it with ticagrelor. So aspirin with ticagrelor will be used. Sometimes you can substitute with clopidogrel also if it is not available. Now, management of acute coronary syndrome. After this, the management will be different in patients of non-ST elevation MI and ST elevation MI. So unstable angina as well as NSTEMI, the treatment will be different. And if there is a patient with ST segment elevation MI, the treatment will be different. If it is unstable angina or non-ST elevation MI, there is no role of fibrinolytics, no role of fibrinolysis. So what you will be doing, you have already given nitrates and antiplatelet agents. So you will add beta blockers in these patients. Beta blockers will be added. For example, metoprolol will be added. Metoprolol acts by producing relatively bradycardia and reducing the oxygen requirement of the cardiac tissue. So rate is controlled a bit and oxygen requirement of the cardiac tissues is improved if you add a low dose beta blocker in the patient. So metoprolol is the one which is generally recommended. Plus, you will consider adding anticoagulation in the form of low molecular weight heparin. For example, enoxaparin will be added. Enoxaparin will be added in the patient, right? Then, if the patient is not responding, you will take a clinical decision to add plus minus. You will add 𝗘𝗱𝗶𝗁. You will take a clinical decision to add. There are indications for that, but it is not added in all patients. Those specific indications you need not remember for FMG exam. So plus minus 𝗘𝗱𝗶𝗁, it is a IV antiplatelet agent. So it is IV drug which will be added as an antiplatelet agent in these patients. So this will be the treatment of unstable non-ST elevation MI. When it comes to ST segment elevation MI, the therapy of choice, the initial therapy of choice, the first or ideal therapy will be PCI. What is PCI? Percutaneous coronary intervention. So I'm writing in bracket percutaneous coronary intervention. Percutaneous coronary intervention. In normal language, it is called as percutaneous angioplasty, right? This is the cash cow of cardiologist. So percutaneous coronary intervention, and primary PCI has to be done within, ideally it has to be done within 90 minutes. Within 90 minutes. So first medical contact to device time, it is called as first medical contact, FMC, to device time. When the first procedure is performed, it should be done within 90 minutes. It's a previous year question also. However, if you anticipate, if the anticipated time needed, anticipated means हमें नहीं पता कि हमें लग रहा है कि ज़्यादा time लग सकता है. We are thinking that more time can be taken. If anticipated time is likely to be more than 120 minutes, if it is likely to be more than 120 minutes, in these patients, you will be doing fibrinolysis. Do fibrinolysis. And fibrinolysis should be done ideally within 30 minutes of arrival. Within 30 minutes of arrival. And see, you need the basic difference is coronary intervention can be done only by a DM cardio person. But fibrinolysis can be done by MD medicine person also. If you feel that the facility to do within 90 minutes is not possible, it is going to take more than 120 minutes. Patient comes, don't wait for cardiologist. You will give a call, but as a MD medicine person or as a resident, you will do fibrinolysis. Fibrinolysis can be done by residents also, right? So fibrinolysis, when you do, what are the drugs which are useful? The most commonly used agent is alteplase. You can use other agents like streptokinase and reteplase as well. So alteplase, for example, alteplase is to be used in the patient. And the more you delay the patient, the more worse is going to be the outcome in the patient. So this is the stepwise management that we perform related to management of acute coronary syndrome. However, if the examiner says there is a female patient, she has chest pain at rest, not related to exertion, and the chest pain increases more in the cold environment as well as in the morning hours, and there is a history of Raynaud's phenomena. Which cardiac condition you will think of? Any possibilities? You will think of a condition known as Prinzmetal angina. You will think of a condition known as Prinzmetal angina. In Prinzmetal angina, remember, the cardiac biomarkers are generally normal. Cardiac biomarkers are generally normal. And what is the drug of choice for Prinzmetal angina? You can go for nitrates. Second line drug, you can go for calcium channel blockers also. And these patients will be having angina with ST segment elevation. So remember, Prinzmetal angina has ST segment elevation despite normal cardiac biomarkers. It's a very, very interesting thing, and there is an MCQ on this. So whenever you find ST segment elevation, immediately it comes to your mind, the answer could be STMI. There was a very interesting question asked on this in the old NEET PG exam, but they had mentioned the values of TROP-I and CPK level to be normal. So what was the possibility in the patient? It was a 40-year-old female patient. The answer was Prinzmetal angina, right? So answer will be Prinzmetal angina. This is how questions will be asked to you in the exam. Let us immediately move into the world of neurology. Now, I'm going to take neurology again as scenarios, but I will be making a lot of flowcharts and atypical ways because neurology can be again very vast and overwhelming. So let us start with the first scenario in neurology. Patient presents to you with headache and neck stiffness. Neck stiffness is also sometimes written as nuchal rigidity. So they will not use the word neck stiffness, they will use the word nuchal rigidity. Nuchal rigidity. What is the possibility? Now, two possibilities are there. First possibility, if the fever is present in the patient, the likely diagnosis is going to be meningitis. But if the fever is absent in the patient, plus the patient is having very severe headache, they will say worst headache of my life. It is also called as thunderclap headache. The likely possibility in the patient is going to be SAH, subarachnoid hemorrhage. Dear friends, there is an MCQ on this. There is an MCQ on this. Both scenarios MCQs have been asked. I know you know it, but you need precision close to the exam. And this is something you need to remember. If the patient presents with headache, neck stiffness, fever, it is meningitis, infection of the CSF and meninges. If it is headache and neck stiffness, but no fever, sudden onset, and very severe headache, they will say worst headache of my life. That is subarachnoid hemorrhage as the possibility. Let us quickly do a recap of what you need to remember from meningitis point of view. In patients of meningitis, there will be a differential diagnosis. What is the investigation of choice in meningitis? It will be lumbar puncture for CSF analysis. But if patient has raised intracranial pressure, lumbar puncture will be contraindicated. So investigation of choice becomes CECT of the brain. It becomes CECT of the brain. This is again a MCQ. How question is asked? A patient has fever, headache, vomiting, photophobia, and neck stiffness. What is the investigation of choice? Lumbar puncture. Second question. Fever, headache, vomiting, photophobia, neck stiffness, papilledema. What is papilledema? Swelling of the optic disc. What does it indicate? Significantly raised intracranial pressure. What is to be done? Lumbar puncture is contraindicated. So CECT, contrast enhanced CT scan of the brain, needs to be done in the patient. Right? Both scenarios, questions can be asked to you in the exam. Now, when you do lumbar puncture, so differential diagnosis of CSF findings. If examiner says there is high fever, if the patient has neutrophilia in the CSF, there is raised protein and low glucose, the patient is likely to have bacterial meningitis, also known as pyogenic meningitis. What is the therapy of choice in bacterial or pyogenic meningitis? The treatment of choice is combination of ceftriaxone along with vancomycin. Single drug is ceftriaxone, but these days combination therapy is used. Ceftriaxone plus vancomycin will be your therapy of choice. If the examiner says there is a patient with moderate grade fever, lymphocytosis, very high protein, and low glucose, the possibility in the patient will be tubercular meningitis. And tubercular meningitis Tubercular meningitis, you have to use, treatment will be anti-tubercular therapy plus dexamethasone will be needed. Steroids are indicated. Dexamethasone is needed. How to find if the patient has ICP? Papilledema will be mentioned. So ICP, write in bracket, you can write, for example, examiner will mention papilledema. Patients who have significantly raised ICP, there is swelling of the optic disc. So when you do fundus examination, papilledema is seen. This papilledema, try to see. If the pressure is high, it will be transferred to optic nerve, and optic nerve opening, which is present in the fundus, that will be inflamed and there will be edema in that region. So they will mention in the question, papilledema is seen. So your answer will become CECT of the brain. Okay. Third possibility, if the examiner is saying patient is having moderate grade fever, lymphocytosis in CSF, raise protein, but normal to high glucose. Glucose is not reduced. What is the possibility? Patient is having aseptic meningitis, also known as viral meningitis. And treatment in these patients is supportive, no specific therapy is available. Some people give acyclovir empirically, but acyclovir is given for herpes. And herpes is not a common cause of aseptic meningitis. It causes encephalitis. And lastly, if the examiner says HIV patient, raised cells, raised protein, normal to increased glucose, and they will say India ink stain is positive. India ink stain is positive for an organism. You will think of cryptococcal meningitis. Cryptococcal meningitis. And in these patients, you need to add HIV, ART, antiretroviral therapy needs to be continued along with amphotericin B will be needed. Amphotericin B will be needed. So what was the first thing that we discussed? That was neck stiffness in the patient. So headache and neck stiffness with fever, that is meningitis. So this is the DD and the one-liners related to meningitis. If the patient says fever with very severe, fever is absent, fever is negative, but very severe headache is there, it is likely to be subarachnoid hemorrhage. Patient will say that is the worst headache of my life and thunderclap headache is seen. When you do non-contrast CT scan, when you do CT scan of the patient, you will find this appearance. What is this appearance? Look at this photograph. You will find blood in the sylvian fissures and blood in basal cistern. It is a spotter image. It is likely to be subarachnoid hemorrhage. So this is a patient with subarachnoid hemorrhage. Regarding subarachnoid hemorrhage, what is the most common cause? Most common cause is trauma. Among non-traumatic causes, it is a rupture of berry aneurysms, also called as saccular aneurysms. Rupture of saccular or berry aneurysms. What is the grading system followed in SAH? There are two grading systems which are followed. Hunt-Hess scale and WFNS scale. WFNS scale. What is the immediate investigation of choice? It is NCCT of the head, non-contrast CT scan of the head. If you do lumbar puncture, and the patient will develop initially bloody CSF, later on 6 to 12 hours later, the patient will develop xanthochromia, yellow colored CSF. So yellow staining of CSF, xanthochromic CSF will be seen. But what is the gold standard investigation? It will be conventional 4-vessel angiography. So conventional 4-vessel angiography will be needed. 4-vessel angiography will be needed. What is the treatment you give in SAH patient? Immediate patiently, we start the patient on nimodipine. It is a calcium channel blocker, which is neuroprotective, and it is a relatively safe in SAH, followed by definite management. So you plan neurosurgery in the patient. You will either put coils or you will put clips during neurosurgery therapy. So neurosurgery details is something you will be reading in surgery class. So this is the first disease and the quick rapid fire review of the topic SAH. So we have done meningitis, we have done SAH, at least the MCQ should not go wrong. Then we have some easy, smaller topics which are mentioned here. Look at the road traffic accident followed by coma. Neuro MRI as well as brain biopsy done post-mortemly found punctate hemorrhages in the brain. What was the cause of death in the patient? The patient developed an injury known as DAI. Yes, absolutely right. DAI is diffuse axonal injury. Punctate hemorrhages scattered throughout the brain is the clue. Diffuse axonal injury. These are the patients who have a very poor outcome. So these patients have a very poor outcome. Yes, absolutely right. Coiling is preferred over clips these days. Coils, endovascular coils are now available. But again, it comes down to the treating surgeon also. It's a surgical decision. But generally, in one-liner, if you have to remember, coiling is better than clipping. That's true. Next scenario, examiner will say, there was a patient who had road traffic accident, trauma, or falling from a height. NCCT was done. This is the image. Two types of images can be seen. What is the likely possibility? Either they will show this part or they will show this part. Now, what are you seeing? First of all, can you see this type of swelling? This type of concavo-convex swelling. This concavo-convex swelling is what you call as lemon sign. Lemon sign. Lemon sign. And lemon sign will indicate what? The patient is having extradural hematoma. And what is the second sign showing? Look at this particular thing. Can you see this? This semi-lunar shape, concavo-convex thing, which is forming here. So this type of appearance is what you call as banana sign. Banana sign. And banana sign indicates what? SDH in the patient. Subdural hematoma in the patient. And what is the diagnosis in this patient? The diagnosis in this patient. Triangle is the word we use for diagnosis. Most of you, all of you who will be interns next year, let us think positively. You will be not writing the full form diagnosis. You will be putting triangle. Triangle is the word, is the diagnosis. This is the short term that you use in clinics. So diagnosis in this patient is EDH with SAH. And obviously the outcome in this patient is not going to be good. And is it a acute or is it a subacute bleed? Anything which is white on non-CT scan is always a acute bleed. If it is isodense, it is difficult to identify. That is a subacute bleed. And anything which becomes dark, black than the remaining brain tissue, that is a chronic bleed. That is a chronic. Some of you might be thinking कि sir इतना easy चीज क्यों बता रहे हो? अरे easy चीज भी important है. And many times we read hi-fi things and we forget these simple things. Like in this question, examiner will be putting this photograph asking you what is the diagnosis. 4 options: EDH, SAH, both A and B, DAI. Now there are no diffuse punctate hemorrhages here. Now generally what happens is we don't mark the option with both of them or none of them. But here the answer will be both EDH and SAH are visible. Okay. So this is the diagnosis. Differentiating between EDH and SDH is very important. This is a very, very useful table, very, very high yielding table. First of all, EDH versus SDH. EDH is unilateral. SDH can be unilateral or it can be bilateral. EDH occurs from artery, SDH occurs from veins. There are exceptions, of course. EDH, the source of bleeding is middle meningeal artery. Middle meningeal artery. What is the source of bleeding in SDH? It is bridging cortical veins. Bridging cortical veins. Bridging cortical veins. What is the presentation? EDH or SDH? Where would lucid interval be present? EDH. So initially there will be trauma, then there will be apparent normal period. So lucid interval will occur. Lucid interval will occur followed by deterioration. Here there is no lucid interval. There is no lucid interval. There is simply headache followed by progressive deterioration. No lucid interval. There will be progressive deterioration. Which out of them is associated with skull fracture? Which is the one which is superficial, extradural? So association with skull fracture present, and generally it is absent. Which of the one is limited by suture lines? The extradural one is limited by suture lines. SDH is deeper. It is not affected by suture lines. Shape on CT scan. This shows biconvex shape. Biconvex means like a lens. This shows concavo-convex shape, also known as semilunar shape. So this will be something like this. Surgical drainage, ASAP, as soon as possible. SDH may or may not be needed. In fact, many times, SDH patient already comes with a small SDH and it has, already patient has recovered. But when you do CT scan, there will be history of trauma and small black SDH, that is chronic SDH, may be persisting in the patient. But EDH patient will require surgical drainage always. And what is the prognosis? Prognosis is good if small and urgently evacuated. If you are late, obviously the prognosis will become bad. SDH, if it is associated with low GCS, the outcome is always poor, irrespective of evacuation. Whether you have evacuated it or not, if there is low GCS at the time of presentation, the outcome is generally poor. It's a very, very important table. Yes, the surgery done in EDH is burr-hole drainage. So it's very, very important. Cerebrovascular disease. Cerebrovascular disease is also known as CVA, that is cerebrovascular accident. Now, cerebrovascular disease is of two types. Sudden interruption of blood supply to the brain causes focal neurological deficits. These are called as cerebrovascular disease. Okay. If these deficits resolve within 24 hours and the CT or MRI is normal, there is no brain infarction, you say TIA, transient ischemic attack. Full form is something you already know. If neurological signs persist for equal to or more than 24 hours, or the symptoms have gone away, but when you do CT MRI, there is brain infarction present anywhere, that is called as stroke. Risk of stroke after TIA. Maximum risk of stroke after TIA is seen within first 48 hours. It is seen within first 48 hours. Now, one patient had TIA. Would stroke happen or not? What is the scoring system for that? So risk of future stroke is predicted by a score known as ABCD2 score. It has been asked 2 times in the FMG exam. It has been asked 2 times in the FMG exam. Now, what does ABCD2 score looks like? Have a look at this page. ABCD2 means A, B, C, D 2 times. So A is age. 1 point is given if the age is more than 60 years. Remember, yesterday we did pneumonia 𝗘𝗱𝗁𝗁𝗱 criteria. That was different. There the cutoff was 65. Here, the cutoff is 60. Then B stands for BP. 1 point is given if the BP is equal to or more than 140/90. Third is clinical feature. If there is speech disturbance, that is slurring of speech, but no motor weakness, 1 is given. If one side of the body weakness has come, that is, weakness doesn't mean that there should be complete paralysis. Even weakness, plagia, is also considered to be a feature. Then duration. You will be giving 1 point for the value between 10 to 59 minutes duration. And if the TIA or the symptoms persisted for equal to more than 60 minutes, you will give 2 points. And finally, if the patient has diabetes mellitus, for diabetes mellitus, single point is given. So then we take out the total score. Total score says if the total score is 0, the 3-month rate of stroke in the next 3 months possibility is 0%. Total score 1, 2%. 2 score, 3%. 3 score, again 3%. 4 score, possibility 8%. 5 score, 12%. 6 and 7 will have very high percentage. Would they be asking this? No. All they will ask is this particular thing. This is the only thing you are supposed to know. The lower table, it is there, but even if you leave it, it's okay. You are not going to be penalized for missing out this particular part, right? So this is ABCD 2S score. Now the interesting thing, the important thing comes, how you are going to manage a patient of stroke. Just like we did for acute coronary syndrome, we will be making a handmade chart here as well. So when would you suspect stroke in the patient? It should be suspected if the patient is having any acute onset neurological deficit. Any acute onset neurological deficit. What are the neurological deficits? So F is face drooping, A is arm weakness, S is speech difficulties. If any of them is present, there is T, that is time to call. It's a medical emergency. You need to treat the patient as soon as possible. So patient with either face drooping or slurring of speech or arm weakness comes to you. What is the first thing that you will do? Any suspected stroke patient, we are not sure. Any suspected stroke patient comes to you, you will do A, B, and C. What is A, B, C? Airway breathing circulation, right? You will do airway breathing circulation and do an urgent NCCT, non-contrast CT scan of the head. Now people will ask, sir, MRI, isn't it more sensitive? Yes, but MRI takes about 30 to 60 minutes. And for those 30-60 minutes, patient is inside, not receiving therapy. Once the patient comes out, photo is good, but patient is dead. So what is the point? So any emergency, we always go for NCCT head. Raised ICP patient, NCCT head. Stroke patient, focal neurological deficit acutely developing, NCCT head. Trauma patient, NCCT head. So urgent NCCT head is done. Now there will be two possibility. It will be inferior to MRI, but it is not that bad also, right? So do an urgent NCCT head. So hemorrhage is present. Two possibilities. You find any evidence of hemorrhage in the brain. And second possibility, there is no hemorrhage detected. No hemorrhage detected. If you are suspecting hemorrhage in the patient, the possibility is hemorrhagic stroke. We call it as hemorrhagic stroke. Hemorrhagic stroke is strongly associated with high BP. And these are the patients in which fibrinolysis or thrombolysis is contraindicated. So thrombolysis will always be contraindicated, right? So what is the most common site of bleed? Most common site of bleed in hemorrhagic stroke? It will be basal ganglia. Particularly in basal ganglia, it will be putamen, which will be the common site where bleeding will occur. So putamen is the site. And the strongest risk factor for hemorrhagic stroke will be high BP. BP equal to or more than 160 by 100 is considered to be the strongest risk factor in the patient. So what is the management that you are going to do? Treatment in this patient? You will do BP control. You will manage raised intracranial pressure if present. And any hematoma, if hematoma size is very large, if hematoma is more than 3 centimeter, you will plan neurosurgery, neurosurgical evacuation in the patient. Evacuation means you need to remove it. Neurosurgical evacuation will be needed. But if the patient is having no hemorrhage, then stroke is there. It is a non-hemorrhagic stroke. What you will do? In these patients, there will be two possibilities. First possibility, the window period by which the patient presented is small. Window period is less. The patient presented within equal to or less than 4.5 hours. 4.5 hours. You will be doing thrombolysis in these patients. Thrombolysis. See, never try to normalize the BP in these patients. Rapid fall in BP can further compromise. See, there is a auto-regulation of blood supply to the brain. So any rapid fall in BP should be avoided. And generally, we don't use IV agents. We use oral agents if provided the patient can take. Or low-dose IV agent, the same class which the patient is taking, being hypertensive, that can be given. Generally, more than 10%, 10 to 20% fall should be avoided in the systolic BP. There are separate guidelines for that, so that we can discuss separate. So window period is less within 4.45 hours. Thrombolysis has to be done. You will be using alteplase. You will be using alteplase. But if thrombolysis fails, then you have to go in for mechanical thrombectomy. Neurosurgery will be done, so you will do mechanical thrombectomy. Mechanical thrombectomy. We allow some degree of hypertension to occur. Good. Permissive hypertension. Good. Second possibility, if the window period is more than 6 hours, in these patients, you will consider endovascular revascularization. And if it fails, take expert opinion. If it fails, take expert opinion. Means let a neurologist handle. You can take neurosurgery opinion as well. So this is the management of, and once upon a time in a FMG exam, they have asked the dose of 𝗘𝗱𝗂𝗃 also. So remember, the dose of 𝗘𝗃𝗃 is 0.9 mg per kg. That is the dose of 𝗘𝗃𝗃. It has been asked once, so we are writing it as a one line. But generally, doses are not to be remembered unless it is a very, very important protocol that we follow. So 𝗘𝗃𝗃 dose has been asked once, so we have written it here, right? So this is the stroke management that you will be doing. So if I zoom out, this is very easy to remember and it is very easy to reproduce as well. Now, when you solve MCQ, some occasional point comes in, some additional thing you find in your regular notes, add to this particular thing. Look at this MCQs. Let's solve some MCQs. FMG July 23. 60-year-old man presents with acute right hemiparesis. His BP is 220 by 100 and NCCT head is shown. All should be done except. So acute right-sided hemiparesis, hypertensive patient, and look at the bleeding which is happening in the basal ganglia putamen region. This is the basal ganglia putamen region. All should be done except का मतलब क्या नहीं करना? थ्रोम्बोलाइसिस नहीं करना. देखो बीपी कंट्रोल करना है, सेरेब्रल एडिमा होगा मैनेज करना है, इलेक्टिव हाइपरवेंटिलेशन करना है. क्यों करना है? Because if there is risk of raised intracranial pressure, hyperventilation can transiently decrease the ICP. It can transiently decrease the ICP. तो ये करना है. क्या नहीं करना? Thrombolysis कभी भी नहीं करना. Right? So they're asking, don't miss the words except in the MCQ. A patient presented with contralateral face, arm and leg weakness, one-sided hemiplegia, NCCT revealed intracranial hemorrhage. So hemorrhagic stroke has happened. What is the most common location of hemorrhagic stroke? Again, the answer is D, that is basal ganglia. So what is the answer? D is your answer. Let's go further. There are some stroke syndromes. The nomenclature is important. You have to mug up these tables. So you cannot remember every stroke syndrome. There are other rare stroke syndromes as well, but these bare minimum ones you have to remember. If examiner says after stroke, there is same-sided third nerve palsy, that is oculomotor palsy, but cross-sided, opposite side hemiplegia, the patient is having a syndrome known as Weber syndrome. Weber syndrome is a typical brainstem stroke syndrome. Ipsilateral third nerve palsy with contralateral tremors. It is Claude syndrome. Claude syndrome. Yes, doc. ये इसीलिए लगा blank आप इसलिए हुए because that precision is lacking. So limited चाहे आप पढ़ो, लेकिन जो पढ़ा है ऐसा होना चाहिए. It's like there are certain players, they can't play every shot, but they know कि मेरे को मेरे एरिया में बॉल मिल गया तो छोड़ूंगा नहीं. You understand? They actually do better than people जो कि एक डिफ्यूज सी गेम खेलते हैं. You have to be good in whatever you are doing. So accuracy comes into play in these topics. Next question. Next point. Ipsilateral third nerve palsy, contralateral weakness with tremor. तीनों आ गए. So then you will call it as Benedict syndrome. Benedict syndrome. It is not C wala Benedict, K wala Benedict. Benedict syndrome. And ipsilateral facial weakness with contralateral hemiplegia. It's a very important question. 2 times it has been asked. It is what you call as Millard-Gubler syndrome. इनफैक्ट ये चारों के अंदर सबसे कॉमन सिंड्रोम जो है दैट इज मिलार्ड गुबलर सिंड्रोम एंड all the 4 conditions are considered to be brainstem syndromes. Then if there is contralateral palsy with Broca's motor speech area getting affected, the patient is likely to have middle cerebral artery involvement. But which segment of middle cerebral artery? You will write superior division of left middle cerebral artery is affected. If the examiner says contralateral palsy with Wernicke's sensory aphasia, then inferior division of left middle cerebral artery is affected. Remember, right middle cerebral artery does not cause Broca or motor aphasia. And finally, cortical blindness with the lack of awareness. It is called as Anton syndrome. Anton syndrome. It is seen due to bilateral cortical infarcts. Both the cortex are gone. And the interesting thing about it is, patient will be blind, but he will not know that he's blind. He will try to walk and he will stumble and fall. You will tell him ki, dude, you cannot see. He will be like, no, 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 I can see. I can see you. That lack of awareness will go away as a part of stroke syndrome. That is why it is not a normal thing. It is called as stroke syndrome. Anton syndrome will be the answer to this question. Let us have a look at Glasgow Coma Scale. This Glasgow Coma Scale you will be doing in surgery class also. Surgery faculty will be telling. 3 components are there. Eye opening, 4 types of scores can be given. Verbal response, 5 types of scores can be given. And best motor response, 6 types of scores can be given. You are supposed to mug it up. There is no rocket science. Minor brain injury is between 13 to 15. 9 to 12 is moderate. And severe brain injury is 3 to 8. Maximum possible score is 15. Least possible score in these patients is still 1 plus 1 plus 1, that is 3. Now, about Glasgow Coma Scale, there is one liner you can write here that any patient with Glasgow Coma Scale, it's an MCQ point, less than 8 requires intubation. To secure the airway, there is a chance of aspiration in the patient. So immediate intubation is needed in the patient. Right? So this is a Glasgow Coma Scale, not Glasgow. It's a misprinting again. Glasgow Coma Scale. Glasgow is a beautiful city in United Kingdom. This is where the coma scale was devised. So we call it as Glasgow Coma Scale. Let's move further. Now we have some scenarios. And in these scenarios, we will be discussing some of the recent MCQs as well. Look at the first scenario. There is a child or adult with dysentery 1 to 3 weeks back. Now he's coming with symmetrical ascending flaccid paralysis. You know that paralysis can be of 2 varieties. See, it should be equal to, at 8 GCS, it is a elective decision. It comes down. Less than 8, absolute indication to intubate the patient. If there is stroke, generally the weakness in the limbs is upper motor neuron type. Upper motor neuron means there is spasticity, there is brisk reflexes, and there is Babinski sign, which is positive. But this patient is having flaccidity. The tone is gone and the reflexes are gone. So acute onset, symmetrical paralysis, both sides. Ascending means starts in the lower limb and rises. Weakness increases as the days progress. CSF is giving a clue. Albuminocytological dissociation. Bladder bowel usually spared. What is the likely diagnosis in the patient? The patient is likely suffering from GBS. It is not ALS. ALS is amyotrophic lateral sclerosis. This is GBS, Guillain-Barré syndrome. Sometimes they use the word Landry-Guillain-Barré syndrome. LGBS, they are the same. So the same condition है Landry-Guillain-Barré syndrome or Guillain-Barré syndrome. Now, what is the most common infectious trigger? It is diarrhea or dysentery caused by Campylobacterium jejuni. MCQ. Campylobacterium jejuni. And 1 to 3 weeks later, patient can develop GBS. There are predominantly motor symptoms, but if pain or numbness occurs, can it occur? Yes, it can occur. It is due to demyelination. It is a demyelinating disorder of which fibers? This was the MCQ asked. Medicine Physiology Integration, July 25 FMGE exam. It can occur due to involvement of A beta fibers. A beta fibers. This was the MCQ asked this time. It was a tough one, but now it is a previous year question, right? A beta fiber. You need to understand what is happening in GPS. There it is a condition in which there is initial trigger. Either it is a diarrhea, sometimes vaccination, sometimes unknown trigger. It causes antibody formation. These antibodies target the neurons and they target the motor neurons, the myelinated neurons. 2 types of neurons are there, myelinated and unmyelinated. They target myelinated neurons and they lead to conduction block. Paralysis happens. That condition is called as GBS. So it is a predominantly motor symptom with demyelination, but if pain occurs, A beta fibers involvement can produce this type of presentation. Now there are four broad varieties of GBS. We have AIDP, Aman, Amson, and Miller-Fisher syndrome. AIDP, the full form is acute inflammatory demyelinating polyneuropathy. This is the full form. It is a very common variety, AIDP. This is the variety which is more commonly seen in adults. So this is seen in 90% cases. So this is the most common variety. And these patients will be having anti-GM1 antibody in the blood. Second is MN. What is MN? Acute motor axonal neuropathy. Acute motor axonal neuropathy. This is the variety which is seen generally in younger population. And these patients will have antibody anti-GD1A. Anti-GD1A antibody will be seen. Third is AMSN. This is acute motor neuropathy, acute motor sensory axonal neuropathy. This is the variety, again, it occurs in adults, but it is a rare disease and antibodies may or may not be present. So plus minus antibodies. And these patients have incomplete recovery. The response to therapy is also not great. And finally, we have Miller-Fisher syndrome. This is characterized by a triad of three things. Three things occur. They have ophthalmoplegia. They have ataxia, that is unstable gait, and they will have loss of reflexes, that is areflexia. And these are the patients who are having anti-GQ1B antibodies. If you see, all of them are anti-ganglioside antibody, and gangliosides are found in the myelin sheath. That is why they have a tendency to attack and damage the myelin sheath. Myelin sheath damaged, that is a demyelinating disorder. It is considered to be a demyelinating disorder. It's a demyelinating disorder. What is the treatment in these patients? What is the cause of death? These patients can die due to respiratory muscle paralysis. The drug of choice in these patients is IVIG. IVIG is the drug of choice, and alternative second line therapy is plasmapheresis. Plasmapheresis. There is no role of steroids. This is an MCQ. There is no role of steroids in GPS patient. There is no role of steroids in a GPS patient, right? So scenario is done, topic is done. Let us move into the world of DDs of headache disorders. So let us talk about DDs of headache disorders. Now let's talk about differential diagnosis of headache disorders. Three headache disorders we will discuss. There was one question on headache disorder asked this time also in FMGE July 25. Let us go one by one. The first scenario, examiner will say there is a young adult patient. There are recurrent attacks of severe pulsatile word is important, and unilateral word is important. And duration is more than 4 hours, aggravated by movement and associated with nausea and photophobia. If somebody has got it, you know what I'm talking about. This is migraine disorder. There are many types of migraine which are described. We have migraine with aura, migraine without aura. There is variant migraine these days, and so on. But the diagnosis in these patients is migraine. If aura is mentioned, then you mention aura, but generally most migraines do not have an aura, right? So migraine is the diagnosis. Now, how you are going to treat the patient? Now, treatment wise, we will not go into details. In pharmacology, you will anyways be reading it. So first of all, when a patient comes to you with acute attack, immediately you will be starting according to the severity in the patient. Suppose it is a mild attack and it is not debilitating, you will be starting non-steroidal anti-inflammatory agents. You can use aspirin or you can use ibuprofen or similar drugs. Some people use diclofenac and naproxen, but aspirin and ibuprofen are generally good enough. And second possibility, you can consider paracetamol, that is acetaminophen. And they can be combined plus minus. If vomiting is present, you can use metoclopramide. This is the first line therapy in mild patient. But if it is moderate to severe attack, and in fact, most of the attacks are moderate to severe. If they don't mention, you have to manage according to moderate to severe. You will be giving triptans in the patient. What are triptans? They are selective 5-HT 1B by 1D receptors. Selective 5-HT 1B by 1D receptor agonists. What are the triptans you will be using? Now, the most commonly used one is sumatriptan. Sumatriptan. But if they say most efficacious is rizatriptan. Riza is also costly. Rizatriptan. And remember that these triptans can aggravate the patient if there is an underlying heart disease. So previous history of congenital heart disease, previous history of MI or stroke, these triptans should be used very carefully. And if they fail, you can go for rimegapant. What is rimegapant? It is a CGRP antagonist, CGRP receptor antagonist. CGRP antagonist. And second part of therapy is starting the patient on prophylaxis. Prophylaxis. For prophylaxis, you have various options available. You can go for beta blockers like propranolol. You can go for flunarizine. You can go for topiramate. You can go for valproate. Some people like to go for amitriptyline. And lastly, some patients can go for venlafaxine. But in clinical practice, it is beta blockers, flunarizine, and topiramate, which are more commonly used. Again, it will come down to the other comorbidities, like some of them will cause weight gain, some of them will cause insomnia, some of them will cause their own side effects. So which prophylactic agent to use? Now it's a pharmacology again, so you have to read it from pharmacology as well. My suggestion, please read the treatment of migraine in details and do it from pharma as well. The mechanism of these drugs, their side effect, where used, where not used. Sometimes it looks like a migraine question, but actually it is a pharma question they are asking you. So this is one topic, please, you can write on the side. Also do from pharmacology. It's going to be useful in your exam. Integrated questions. Anyways, pharma is mostly coming integrated these days. Standard standalone pharma is, it is asked, but it is not as much as it used to be before. Second scenario, examiner will say that there is a patient who has episodic or chronic headache. या तो कभी कभी हेडेक होता है या क्रॉनिकली चलता रहता है. दिस वर्ड इज इंपॉर्टेंट. देयर इज अ टाइट बैंड लाइक डिस्कम्फर्ट. ऐसा लगता है किसी ने टाइट बैंड बांध दिया है थ्रू द फोरहेड. इट इज माइल्ड टू सीवियर. इट कैन बी माइल्ड, इट कैन बी मॉडरेट, इट कैन बी सीवियर. But nausea, vomiting, and throbbing are rare to absent. So these are not seen. There is no nausea, no vomiting, no throbbing. If you have a presentation like this, what it is a very, very common headache. I am quite sure many of you would have got it as well. This is tension headache, also known as tension type headache, also known as TTH. TTH stands for tension type headache. Tension type headache. Tension type headache. Now, what is the treatment you are going to do in tension headache patient? Now, the initial for it, because it is not a migraine, so first line therapy is always non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Ibuprofen is usually good enough. Books say paracetamol also, but let me tell you, Dolo 650 doesn't work anymore in headache. I'm telling it from a clinician's perspective. Theoretically, yes, we use it, but there has been so much of overuse of paracetamol, crocins, and dolos that it doesn't work anymore, except if there is a very high fever or the patient is having some, you can't use non-steroidal drugs. It doesn't work anymore. Young kids, it works. Adults, headache, at least in me and every single patient I have used in, including my family members, headache does not respond at all to paracetamol. Books do write paracetamol also, but first line therapy for all practical purpose is non-steroidal anti-inflammatory agents. Remember, there is no role of triptans. There is no role of triptans in these patients. And what is if there is a recurrent equal to or more than 15 times per month and it is debilitating, then you can consider low dose amitriptyline as a maintenance therapy. Low dose amitriptyline can be started in the patient. It will be given regularly for about 3 to 6 months and slowly you will try to taper it. The second headache is done. Third headache. Dear friends, this third headache is the one which was asked. So I'm putting it like this. It was asked in July 25 FMG exam, case scenario MCQ in medicine. So July 25. So they will say there is a young adult male. He has clusters or groups of headache, but periodicity is seen. It comes periodically at a certain pattern. There is severe deep retroorbital pain, and plus there will be watering from the eyes and autonomic dysfunction will be there. Increased or decreased sweating, increased or decreased BP, increased or decreased heart rate, autonomic dysfunction will be there, and patient will be restless and move about. Now, if a person is having headache and he's moving about, people think it is tension headache. No, the patient is restless not because of the headache alone, but also because of he's not feeling well at all. And there is severe pain happening deep in the head and there is watering from the eyes. If these words are mentioned, these pattern, it will be, patient will be like, you ask the patient, pehle bhi hua hai? The patient will say, yes, it has happened 2 months back. And every 2 to 3 months it happens and it stays for a few days. This is cluster headache. This is cluster headache. Cluster headache. What is the treatment that you do in cluster headache? The first line therapy in any cluster headache is starting the patient on oxygen. Giving oxygen alone works. If it is not responding to oxygen, you can consider adding triptans to it. This was the MCQ asked. Consider adding triptans to it. And if it is still not responding, you can consider vagal nerve stimulation. You can consider vagal nerve stimulation. It is written as VNS. It is generally done non-visibly. Vagal nerve stimulation, some maneuvers are there. And how can you prevent? Prevention can be done by steroids, low-dose steroids. But steroids have a problem of causing Cushing syndrome. Second possibility, you can go for verapamil. And these days, a lot of people are using melatonin as well. Books will say lithium also, but lithium is generally the new guidelines say lithium should not be used. Side effects outweigh the benefit, right? So melatonin is the one, and melatonin is available easily and it has lesser side effects as well. So these days, melatonin is being tried before we go for the more sophisticated therapies and the new drugs, right? Cluster headache, important topic. And finally, we come to the miscellaneous CNS disorders. Now, many of the answers you would know already. You have to make the diagnosis and write four or five important points about it. First scenario, middle-aged or young adult, female more common than male. Paroxysmal means intermittent, episodic. Paresthesias are there. Paresthesias are tingling, numbness, etc. Pain is there, weakness is there, and vision loss occurs due to optic neuritis. And many times these patients will have Lermit syndrome, shock-like sensation, particularly when they are taking a bath. And CSF, when it is done, it shows oligoclonal bands. What is the likely possibility the patient is suffering from? Multiple sclerosis. It is not a good thing to be. So multiple sclerosis is the likely possibility. Now, in multiple sclerosis, what are the additional things you should know? Multiple sclerosis has multiple types. The most common variety is the relapsing form, RMS form. RMS means relapsing multiple sclerosis. There is when you do MRI in these patients, you find an abnormality known as Dawson's fingers. Dawson's fingers are found. Then these patients will be showing central demyelination. Dawson fingers along with central demyelination. What is the criteria that we use in the diagnosis? There is a criteria known as McDonald's criteria. So you need not remember the details. McDonald's criteria. McDonald's criteria. And what is the first line? What is the therapy? A lot of, yes, finger-like projections occur. So treatment in these patients, the highly effective are first line therapy. Any of the following biological agents can be used. Either you can go in for rituximab. Rituximab, you all know it is anti-CD20 monoclonal antibody, or you can go in for natalizumab. Natalizumab is anti-integrin antibody. It is anti-integrin antibody. And sometimes these days we are using alemtuzumab as well. They are highly efficacious. It is anti-CD52. Anti-CD52 antibody which can be used in these patients. Baki, there is a complete list of drugs, and remember, interferon beta has also been found to be useful. Remember the funda that interferon alpha is useful in viral infection. Interferon beta is useful in demyelinating disorder. Interferon gamma is not used for therapeutic purpose. I repeat, interferon alpha useful in viral infection. For example, SSPE. For example, chronic hepatitis B. For example, chronic hepatitis C. There interferon alpha is used. Interferon beta is useful in certain demyelinating disorder like multiple sclerosis and its variants. And interferon gamma, it is important in the body, but it is not used therapeutically in any common condition. This, I hope you will remember this funda. Let's move further. Now, this is a very, very easy thing. Look at the question and tell me the answer. This scenario is mentioned. Old age, insidious memory loss. Insidious means gradually progressive memory loss. Anomic aphasia, patient cannot take the name. And there are severe visual specific deficits. The answer is Alzheimer's disease. It is the most common dementia occurring in old age. Can you use melatonin for sleep? People do use it, but before you start, always take consultation from a qualified medical professional. You can use low dose, you can start, but again, end of the day, a drug is a drug. So Alzheimer's disease. So this is a patient. The words are old age, anomic aphasia, visual specific deficits. Alzheimer disease is having, when you do MRI brain in Alzheimer disease, these patients are having NFT. What is NFT? Neurofibrillary tangles. Recent MCQ in NEET PG exam. Can be repeated. So neurofibrillary tangles and plaques composed of A beta amyloid. A beta amyloid plaques. A beta amyloid plaques will be found. And the most important genetic risk factor, genetic cause of Alzheimer disease is epsilon 4 allele. It is written as epsilon, right? It is not E, epsilon 4 allele present on ApoE gene on chromosome 19. Another reason is APP gene present on chromosome 21. And that is why Down syndrome has early onset Alzheimer's disease. This is also a MCQ because Down syndrome has 3 copies of the gene which is involved in producing Alzheimer's disease in the patient. Regarding the therapy, not many therapies are currently available. So you use neurotransmitter-based therapies like donepezil, rivastigmine, and memantine. And these days there is a new A beta targeting therapy. The name of the therapy is aducanumab. Aducanumab is the new A beta targeting therapy in the patient. So aducanumab can be added. Finally, we come to this scenario. Mask-like expressionless face, no emotions are coming. Rigidity, tremors, bradykinesia, unstable posture, decreased blinking, drooling of saliva, autonomic disturbance, shuffling gait. 2 or 3 of these, if they mention together, the patient is likely to have the disease known as Parkinson's disease. Parkinson's disease. Parkinson's disease. In short, it is written as PD. Parkinson's disease. Now, Parkinson's disease is a basal ganglia dopamine defect. In these patients, what are the key things you should know? There is a lack of, progressive lack of dopamine secreting neurons. There is a loss of dopamine secreting neurons. Substantia nigra, pars compacta region of the basal ganglia. This is a very, very important area. Substantia nigra, pars compacta. This is the site where damage maximally happens. These patients will have gene mutations in alpha-synuclein gene mutations. Alpha-synuclein gene mutations can occur. What is the therapy? First line therapy is, first line treatment in these patients is levodopa, or you can use dopamine antagonists. Dopamine agonists. For example, ropinirole can be used. See, there are many other things. These are the things which are discussed in details in your medicine as well. It is not a theory class, it's a revision class we are doing. So we are trying to cover the maximum things and focusing on the things you can remember. You need to have a look before you sit in the exam. So dopamine agonists like ropinirole will be used in these patients, and many times you will add COMT inhibitor, which slow down the breakdown of dopamine. So you will add COMT inhibitors in these patients. For example, 𝗘𝗱𝗶𝗁. 𝗘𝗱𝗶𝗁 is added. 𝗘𝗱𝗶𝗁 is added. I have a question to ask. There is a 25, see, Parkinson disease, Alzheimer disease, these are all diseases of the old age. 25-year-old person, 25-year-old, I will repeat, 25-year-old person presents with rigidity, tremor, bradykinesia, hallucination, shuffling gait, unstable posture. Okay. He also has hepatomegaly and ocular abnormalities. What is the likely diagnosis? What are we dealing with? Wilson disease is what we are dealing with. So remember, early onset Parkinsonism before 30 years. All one differential diagnosis you need to rule out is Wilson disease. What I just told you is a NEET PG MCQ. Right? It is not written here. Remember, you can write as a one-liner if you want. I'm not in the mood to write. I have to write more for the next 1.5 hours. So early onset Parkinsonism, liver involvement, eye involvement, strong possibility Wilson disease should be thought of. Okay. Let us start with the endocrinology part. Let us start with endocrinology. So what you can see in the photograph. First of all, examiner will show a picture like this and they will ask you what is the likely hormonal deficiency. What you can see in this patient, there is a single central incisor. Whenever examiner says there is single central incisor, whenever examiner says there is single central incisor or overcrowding of teeth, along with short stature, the likely diagnosis in the patient is growth hormone deficiency. So remember, it's a very, very important funda that you need to know. It is a very important identifying point. The patient is having growth hormone deficiency. If it is a male child, they will additionally have problems above features. Along with that, they will also have micropenis. As well. What is the type of short stature seen in these children? These patients have proportionate short stature. What is proportionate? The body proportions are otherwise normal. What is the screening test in these patients? The screening test that you can do is serum IGF-1 levels. Serum IGF-1 levels are found to be decreased. They are found to be decreased. But if they say investigation of choice in growth hormone deficiency, it is always growth hormone stimulation test. We never do a standalone blood level of growth hormone. We do a growth hormone stimulation test. If the value of growth hormone, despite stimulation by agents like clonidine, etc., is less than 7 nanograms per ml, it is less than 7 nanograms per ml, it is considered to be diagnostic positive test for growth hormone deficiency. And the treatment in these patients, the only good thing is if you start early, there is a recombinant human growth hormone available. Recombinant growth hormone injections can be given. Dose will not be asked. Just remember the route of giving growth hormone is subcutaneous route. It's an MCQ point as well. You can add it to the notes. It is not acromegaly, dear friends. It is growth hormone deficiency. It is the opposite of acromegaly. So the first disease that we have discussed is growth hormone deficiency. Let us go to the second disease. In the second disease, now you have spade-like broad hands. Normal height is there. It is important. Normal height. They have prognathism. The jaw is protruding forward. Heel pad thickness is increased. And there is tachycardia, arthritis, and galactorrhea from the breast, even in male patients. The likely diagnosis in the patient is acromegaly. And acromegaly occurs when there is excess growth hormone secretion beyond 16 years of age, because the growth plate has already fused, so patient will have no increased height. The height will be within normal limits, but acromegaly will be produced in the patient. Right now it is acromegaly, yes. So in acromegaly, what is the most common cause? What is the most common cause of acromegaly? It is generally caused by pituitary microadenoma. In the pituitary, in the brain, there are benign tumors which overproduce growth hormone. So pituitary microadenoma is the most common cause. What is the diagnostic test in these patients? See, the screening, if they ask you screening for acromegaly, for the purpose of screening, you can do serum IGF-1 levels, which will be found to be increased. But if they say diagnostic test, then in these patients, we go for glucose challenge test, also known as growth hormone stimulation test, and it will show very high growth hormone levels. Plus, if they ask you which test is done for evaluating the cause, because the most common cause is brain tumors, pituitary adenoma, then you have to do MRI brain as well. What is the most common cause of death? It's a NEET PG MCQ. It is congestive cardiac failure, which is the most common cause of death. And finally, what is the treatment? See, because tumor is the cause, so you will do neurosurgery, you will do transsphenoidal resection of the tumor. Secondly, you will do drugs. Now, many of the textbooks and many of the places in one online platform also, I saw that drug of choice is pegvisomant. Pegvisomant is the effective drug, but it is not the drug of choice. And this was the MCQ asked in FMG exam as well. According to Harrison 22nd edition, the preferred drug always are long-acting somatostatin receptor ligands, which inhibit the secretion and the action of growth hormone. You can use either depot preparation of lanreotide, it is a long-acting form, or you can go for depot preparation of octreotide. Remember, it is always the first line agent to be started. Only when it is not responding to the usual management, then you will go for growth hormone receptor blockers or growth hormone receptor antagonist like pegvisomant. So pegvisomant is always a reserve drug. It is never a first line drug in the management of acromegaly. Small thing, but you need to remember for exam. Many times octreotide will not be in the option, lanreotide will be in the option. Either of the two will be mentioned and that will be the answer. So short review, short topic, but important. Preferred management of acromegaly in the patient is. Preferred management in acromegaly is. Look at the options. What is the likely diagnosis? It is long-acting form of depot formulation, lanreotide. Many people marked octreotide in the answer. It is the IV octreotide जो है वो तो देखो within 8 to 12 hours it will be metabolized. You need a long acting constant inhibition, and for that you will be going for lanreotide depot formulation in the patient. So B is your correct answer. The mistake many students make is they mark octreotide. Don't remember certain important things as one-liner. You need to know the context of the topic as well. This is the second disease, that is acromegaly. Let us look at the third disease, the third syndrome. Young adult patient has constipation and renal stone. Whenever there is constipation and renal stone, you will think of more calcium in the body. Investigations revealed hyperparathyroidism causing hypercalcemia. They also have Zollinger-Ellison syndrome, which is a type of gastrin secreting tumor, and they have brain tumor like prolactinoma. So hyperparathyroidism, gastrin secreting tumor, and brain tumor. We are dealing with a syndrome known as Men syndrome. And which Men syndrome are we talking about? We are talking about MEN1 syndrome. MEN stands for multiple endocrine neoplasia. These are the group of disorders in which multiple endocrinological tumors occur in the body. Generally, they are benign, rarely they can be malignant as well. Many varieties have been described. Common varieties are three: MEN1, MEN2A, and MEN2B. Remember, MEN2B is also known as MEN3. So MEN3 is the other name of MEN2B. Due to MEN1 gene mutation present on chromosome 11, whereas MEN2A and 2B, the type of mutation varies, but the gene location is same. On long arm of chromosome 10, you have the red gene which is implicated. All the three varieties can be sporadic. If they are inherited, they can be autosomal dominant. MEN1 is also known as Wermer syndrome, and MEN2A is known as Sippel syndrome. MEN2B or MEN3 does not have any underlying nickname. So first of all, what is the triad of three things seen in MEN1 syndrome? First thing, these patients have parathyroid adenoma. Adenoma means a benign tumor. This is the most common presentation. And these patients will have hyperparathyroidism, hyper PTH, that is hyperparathyroidism will be produced. Secondly, these patients will have neuroendocrine tumors. They will have gastrinomas. Gastrinoma tends to produce a tumor known as Zollinger-Ellison syndrome. And thirdly, these patients will have pituitary adenomas. Which pituitary adenoma is common? Prolactin secreting tumors known as prolactinomas are important. So this is the classic triad seen in MEN1 syndrome. Remember that in MEN1 syndrome, there is no pheochromocytoma. Presence of pheochromocytoma takes the diagnosis away from MEN1 syndrome. Remember this important funda. What about MEN2A and MEN2B? MEN2A has some features similar, some features different. First of all, these patients will always have thyroid cancer, but we have a thyroid cancer known as medullary carcinoma of thyroid. Medullary carcinoma of thyroid. It is the most common manifestation. It is written as MTC, and this is the most common manifestation of MEN2A syndrome. Second, they can have pituitary, they can have parathyroid adenoma, so they can have hypercalcemia. And thirdly, these patients will have pheochromocytoma. Pheochromocytoma. What about MEN2B syndrome? So medullary carcinoma of thyroid will be here as well. So I'm just writing in the short form, medullary thyroid carcinoma will be there. It is again most common manifestation here. Secondly, these patients will have marfanoid habitus. Marfanoid means they have long legs, long arms, and thin extremities. So marfanoid-like features will be there. Thirdly, these patients will have pheochromocytoma. And fourthly, these patients will have mucosal neuromas. What is the treatment? See, it's a genetic condition. It's a syndrome. So there is not much therapy except for, supportive therapy that you can do in these patients. So this is the three syndromes important. You have to revise. It's likely to be asked as a fresh question in the upcoming exam. So first thing is MEN syndrome in this topic. Let's go further and talk about two important syndromes on which questions are very frequently asked: Conn syndrome versus Addison's disease. Now, if you look at the parathyroid, if you look at the adrenal gland, it has two parts. There are two adrenal glands. They're also called suprarenal glands. Two parts are there, cortex and medulla. Medulla produces epinephrine and norepinephrine, and the cortex has three layers: zona glomerulosa, fasciculatus, and reticularis. Right? So what exactly is Conn syndrome and what is Addison disease? If there is destruction of cortex, the cortex does not function, that causes Addison disease. But if there is a tumor which overproduces aldosterone, that causes Conn syndrome. So one is a excess, one is a deficiency. So Conn syndrome, what is Conn syndrome? Conn syndrome is a condition in which there is a adrenal adenoma. There is a benign adrenal mass. Rarely it can be malignant also, but adrenal adenoma which produces hyperaldosteronism. This is the primary defect. Hyperaldosteronism means the aldosterone levels are very high. It doesn't produce other types of hormones, but generally it produces high aldosterone. On the other hand, Addison disease occurs due to destruction of the adrenal cortex. Most commonly, it occurs due to autoimmune causes. In a country like India, tuberculosis is also a common cause. But overall, most common cause worldwide, it is autoimmune destruction. And so these patients will have decreased adrenal cortical hormones. So they will have decreased cortisol also, they have decreased aldosterone also, and they have decreased sex hormones as well. So 𝗘𝗱𝗶𝗁, etc. will also be reduced in such patients. Now, what will ABG show in the patient? When you do ABG, let us first discuss Conn syndrome. What is happening in Conn syndrome is aldosterone is high. Aldosterone will cause increased secretion of hydrogen ion into the urine. And so patient he will have a tendency to develop 2 times asked in FMG exam, metabolic alkalosis. So patient will have metabolic alkalosis. Addison disease, if it is mild, it may be normal, but generally, due to the deficiency of aldosterone, they will have features suggesting metabolic acidosis. What will you find in the hormone levels? In Conn syndrome, the serum aldosterone levels, S means serum aldosterone, that will be low. That will be increased because it is hyperaldosteronism, right? So aldosterone will be high. Aldosterone will cause feedback inhibition of renin, and so the renin levels in the patient will be low. And there is a test that we do known as ARR test. ARR test will show increased activity in these patients. What is ARR? We take the ratio of aldosterone divided by renin ratio. Aldosterone by renin ratio. This test will show increased activity in the patient. How will Conn syndrome patients present? Now, these patients have obviously hypertension. So they will present with hypertension. They will have muscle weakness and they will have cramps. These cramps will occur because of the presence of metabolic alkalosis in these patients. Now, try to think what will happen. Aldosterone will cause sodium retention and BP increase, but potassium will decrease. And that is why these patients, the muscle weakness and cramps occurs because of hypokalemia, because these patients have hypokalemia. Remember, hypokalemia is a feature. This is again a MCQ point asked in the exam. So in patients of Conn syndrome, you will have hypokalemia. What happens to BP? BP is increased. It is called as low renin hypertension because the renin levels are low renin hypertension. What is the investigation of choice? There is a test that we do known as saline infusion test. Saline infusion test. You infuse about 2 liters of saline over 4 hours and see if the aldosterone is suppressed or not. If aldosterone continues to be high, it indicates it is autonomous production, and so you need to treat the patient. So what is the therapy of choice? Initially, you can give a trial of spironolactone. Spironolactone is a aldosterone antagonist, but it is only a temporary measure. It works, it has efficacy only in 30 to 50% patients. It is not a very efficacious therapy. It is generally more commonly used as a temporary measure for managing the patient. The definite therapy in the patient will always be adrenalectomy. Adrenalectomy. Many times the adenoma is big and it is located in such a way that only resection of the tumor is not always possible. So we do unilateral adrenalectomy in most of these patients. So one adrenal gland is generally removed. So this is the definite therapy in these patients. It's a very, very important topic. I've gone slow. I've tried to cover a lot of ground. All these points which we are writing, they are very, very important. What happens in the other thing? What happens on the other side? Now, in the other side, you will see that the adrenal cortical hormones are not getting produced. So there will be deficiency of all these enzymes. There will be the cortisol levels will be low, aldosterone levels will be low, sex hormones levels and their precursors like DHEAS levels will be low. Because cortisol is low, so feedback inhibition is gone. So ACTH levels will be high. So ACTH levels will be increased. And because aldosterone is low, so the feedback inhibition to renin is gone. So renin levels will be high. Renin levels will be high. What about the clinical presentation in these patients? These patients, the clinical presentation is in the form of all these manifestations will occur. Cortisol deficiency, so they have hypoglycemia. Aldosterone deficiency, generally they have normal BP, but postural hypotension will occur. This word is important. Postural hypotension will occur. Fall in BP on erect posture or prolonged standing for some time can occur. These patients can have delayed puberty or absent puberty. Pubertal disorders can occur. And because ACTH levels are high, you know that ACTH क्या करता है? ACTH causes melanocyte stimulation. So it will cause hyperpigmentation in the patient. So hyperpigmentation will also be produced in these patients. Hyperpigmentation will be produced. Now, what will happen to the BP? The BP will be normal to low. So it can be normal, it can be low. And because there is no hypertension, so we have already discussed the renin in these patients is on the higher side. And because aldosterone levels are low, these patients, the potassium levels in the body, they are normal to increased. Remember, they can have normal to increased potassium level. Many times, the total body potassium is on the normal side as well. But serum potassium can sometimes be on the higher side. What is the investigation of choice? Here we do a test known as ACTH stimulation test. So ACTH stimulation test can be performed. Details of the test will not be asked to you in the exam. And finally, what is the treatment? Obviously, you will do hormone replacement. Hormone replacement will be needed. So you need to add hydrocortisone. You need to add fludrocortisone. And you need to add sex hormones as well, plus minus others. And if there is autoimmune cause suspected and there is some residual function, you can give a trial of a drug known as 𝗂𝗡𝗃𝗓 in these patients. A trial of 𝗂𝗡𝗃𝗓 can be given in these patients. I'm zooming out and see this is, let us solve some MCQ. Look at the first MCQ. A patient presented with hypertension and hypokalemic alkalosis. Hypokalemic alkalosis. CT revealed a small mass in the suprarenal location and there is elevated ARR. What is the best management? You have to make the diagnosis. What is the diagnosis? Cohen syndrome. And what is the best management of Cohen syndrome? It is unilateral adrenalectomy. Now the question looks easy because we have understood it, right? Questions are solvable. These are solvable questions. Next question. All of the following are seen in Cohen syndrome except Cohen syndrome. You know the answer. What happens in Cohen syndrome? These patients have more aldosterone. Aldosterone causes hydrogen loss. So patient tends to develop alkalosis. So what is not seen? A. Next question. Patient presents with hypertension, palpitations, and sweating. Now, palpitations and hypertension can occur in, Cohen syndrome also. It can occur in other conditions also. So we will discuss those other conditions as well. So look at the keywords: hypertension, palpitation, sweating. Potassium is low, aldosterone is high. What is the likely diagnosis? Again, the answer is Cohen syndrome. So it's a very, very easy question. It's a very, very easy question if you just get the hang of it. Same things being asked again and again. The only question is, do you have that? Which of the following is a cause of hypertension with low renin and high aldosterone? The answer will be Cohen syndrome. But there is another syndrome where there is hypertension with low renin and low aldosterone. Low renin, low aldosterone. The disease is Liddle syndrome. Liddle syndrome. Liddle syndrome is there. Yes, hypertension, palpitation, sweating can occur in pheochromocytoma also. But that is why it is not pheochromocytoma, because in pheochromocytoma, the cause is not aldosterone being elevated. If aldosterone is elevated, pheochromocytoma is ruled out. Pheochromocytoma occurs due to catecholamine excess. And these patients will have episodic hypertension. These words will come. I will discuss that scenario also. So it will be very clear in your mind why the answer is not pheochromocytoma. Commonest mistake people make, they mix up Cohen syndrome with pheochromocytoma. We will not mix up after today's session. Let us move to the next one. First, we need to talk about Cushing syndrome. Let us finish adrenal gland, the deficiency and excess part first. So examiner will say there is a patient with moon-like face, chand sa chehra. Centripetal obesity. It is also called as lemon on stick appearance. So they have central obesity, but the limbs are very thin. They have hypertension, hirsutism, and cataracts. The patient is likely suffering from a disease known as Cushing syndrome. Cushing syndrome, right? So answer is Cushing syndrome. Now, what are the causes of Cushing syndrome? There is a table of Harrison that we need to make, and it's a very important table. Tough questions are also asked. This has been asked once in FMG and has been asked 2 to 3 times in the other exams like NEET PG as well. Let us talk about the causes. Causes of Cushing syndrome can be divided into 2 parts. Either patient has exogenous Cushing syndrome, also known as iatrogenic Cushing syndrome. Iatrogenic means it is happening because of somebody's taking steroids more. So exogenous or iatrogenic Cushing syndrome is generally due to excess steroid intake. It is seen due to steroid intake. It is seen due to excess steroid intake. For example, there is a patient with frequently relapsing nephrotic syndrome. तो क्या होगा? Patient with SLE क्या होगा? Patient with frequent flares of Sjogren syndrome क्या होगा? Cushing syndrome will occur. On the other hand, second possibility, patient is having endogenous Cushing syndrome. So increased cortisol is there, but this increased cortisol, Cushing syndrome is bracket you can write increased cortisol levels. This increased cortisol is endogenous. It is forming in your own body. It can be of 2 varieties. First is ACTH dependent form, which is seen in 90% patients. And second is ACTH independent. ACTH independent form. ACTH dependent form will have increased ACTH in the blood. So basically क्या हो रहा है? ज्यादा ACTH बनने से Cushing syndrome प्रोड्यूस हो रहा है. ACTH इंडिपेंडेंट में क्या होगा? There will be normal to low ACTH. ACTH independent causes. The typical example for ACTH independent is adrenal adenoma and adrenal carcinoma. Adrenal carcinoma. देखो कुछ एड्रिनल एडिनोमा जो होते हैं वो क्या करते हैं, दे प्रोड्यूस एल्डोस्टेरोन, वो करता है कॉन सिंड्रोम. कुछ बनाते हैं डायरेक्टली कॉर्टिसोल, तो वो करते हैं एसीटीएच इंडिपेंडेंट कुशिंग सिंड्रोम. ओके, सेकंड पॉसिबिलिटी इज एसीटीएच डिपेंडेंट वेयर मोर एसीटीएच इज गेटिंग प्रोड्यूस्ड. अब सवाल ये है कि ये एसीटीएच ज्यादा बन रहा है तो आ कहां से रहा है? 2 पॉसिबिलिटी. 75% ऑफ दीज केसेस आर ड्यू टू पिट्यूटरी एडिनोमा. पिट्यूटरी एडिनोमा तो ब्रेन से आ रहा है. इसको कहते हैं कुशिंग डिजीज बिकॉज इट इज सेंट्रल इन नेचर. इसे कुशिंग डिजीज कहते हैं. एंड अबाउट 90% में से 15% कहां से आ रहा है? एक्टोपिक एसीटीएच प्रोडक्शन. एक्टोपिक एसीटीएच प्रोडक्शन. इट इज टिपिकली बीइंग सीन इन ओट सेल कैंसर, also called as small cell cancer of the lungs. I already told you small cell cancer of the lung will have ectopic ACTH production. What about approach to MCQs in Cushing syndrome? Now there is a very interesting approach that we need to follow. एक chronic smoker है, उसमें weight gain, hyperglycemia, hyperpigmentation is there, and आपने किया high dose dexamethasone suppression, ACTH high रहा, तो diagnosis बताओ. You need to understand 2 things. There are 2 types of dexamethasone suppression test which are used in Cushing syndrome. Listen to me carefully. स्क्रीनिंग के लिए हम करते हैं लो डोज डेक्सामेथासोन सप्रेशन टेस्ट. Low dose dexamethasone suppression test tells Cushing is there or not. To find the cause of Cushing, we do high dose dexamethasone suppression. How do you reach the answer? Let us form a generalization. सबसे पहले in suspected Cushing syndrome, suspected patient, you do a low dose dexamethasone suppression test. Low dose dexamethasone suppression test. Low dose कितना होता है? 1 milligram dexamethasone is used. Low dose dexamethasone suppression test. Now, when you do this test, there will be two possibilities. When you give overnight dexamethasone low dose 1 milligram, दो possibility होगी. देने से it is a steroid, so cortisol level will be decreased, या cortisol level will be found to be increased. You try to suppress it. If the cortisol level is decreased, you will say no Cushing syndrome, normal patient. And if cortisol level is increased, then the patient is having Cushing syndrome. तो पहला टेस्ट हम किस लिए करते हैं? Cushing syndrome आइडेंटिफाई करने के लिए. Cortisol is increased. If cortisol is increased, the patient has Cushing syndrome. Now, if Cushing syndrome is there, now we do the second test. Second test is called as high dose dexamethasone suppression test. High dose dexamethasone, and high dose कितना होता है? 8 milligram suppression test. Now, when you do this test, you have two further possibility. When you do high dose dexamethasone suppression test and you check the cortisol level, the first possibility, cortisol is decreased. Cortisol is decreased. If cortisol gets decreased on high dose dexamethasone, it is central cause, also known as Cushing disease. Cushing disease should be suspected. Central cause is suspected. यानी कि the pituitary adenoma is producing more tumor in the patient. But if you find that cortisol continues to be high, you check the blood ACTH levels. If you find that the blood ACTH is low, the patient has adrenal cause of cortisol production. And if the blood ACTH levels are found to be increased with increased cortisol, the possibility is ectopic ACTH production. Let me tell you this flow chart, if you have not read before, when you read it for the first time, it seems a bit tricky and it is tough. Let me tell you. But once you get a hang of it, you will find that this is a very, very useful test, very, very useful chart, which will simplify life if you get a tough question on Cushing syndrome. Chronic smoker presented with abnormal weight gain, hyperglycemia, hyperpigmentation. High dose dexamethasone test was done. Before and after test, ACTH was found to be consistently high. It is not getting low. If ACTH is consistently high in a chronic smoker patient, we are probably dealing with ectopic ACTH production. Right? Ectopic ACTH production. ACTH is also high. What is the likely cause? Oat cell cancer or small cell cancer of the lung. So D is your correct answer. So this particular page, again, apart from the page I showed you, this page is important and this page is very, very important. Treatment of Cushing syndrome. Treatment simple है. पहला cause क्या है? Treat the cause. अगर पिट्यूटरी एडिनोमा है तो क्या करेंगे? Obviously ट्रांसफिनोइडल रिसेक्शन कर देंगे. एडिनोमा है ना, तो वही ट्रीटमेंट करेंगे, ट्रांसफिनोइडल रिसेक्शन ऑफ द ट्यूमर. और एड्रिनल कॉज है तो एक तरफ की एड्रिनल ग्लैंड इन्वॉल्व होगी तो यू विल डू यूनिलेटरल एड्रिनल एक्टमी. लेकिन सेकेंडली अगर नहीं पॉसिबल कभी कभी, सो यू विल यूज ड्रग्स टू अपोज कॉर्टिसोल एक्शन. यू कैन गो फॉर मिटाइरापॉन, ketoconazole, mitotane, and pacirotide. Pacirotide is a somatostatin receptor agonist, and this is particularly useful in severe Cushing's disease. If immediate treatment is not possible, then in severe Cushing's disease, Cushing disease क्या था? यहाँ वाला, pituitary वाला. So that you can use Spasireotide in the patient. Sudden flushing हो जाता है, लाल हो जाता है face, lasting 5 minutes, associated with watery diarrhea, asthma like wheezing, and urinary 5-HIAA and VMA levels are increased. What are we dealing with? We are dealing with a disorder known as carcinoid syndrome. So carcinoid syndrome is your likely possibility, right? What is the metabolite which produces it? It occurs due to increased serotonin production. Serotonin is also written as 5-hydroxytryptamine. So 5-hydroxytryptamine or serotonin production produces it. What is the underlying cause? There is a neuroendocrine tumor which is the cause of this. So there are neuroendocrine tumors in the gut which produce large amounts of serotonin, leading to carcinoid syndrome. What is the investigation of choice? Investigation of choice is 24-hour urine for 5-HIAA. 5-HIAA. This will be used to, if it will be increased, that will indicate presence of carcinoid syndrome. However, you need to understand that to locate the site of tumor, पता लग गया carcinoid है, लेकिन cause कहाँ है? For that, you need to do either PET scan or radionuclide gallium scan. Radionuclide gallium scan. Either of the two can be done. Both are equally efficacious. And what is carcinoid heart disease? Certain patients with carcinoid syndrome develop tricuspid regurgitation along with fibrosis of right-sided heart walls. Fibrosis of the right-sided heart walls. And what is the treatment in the patient? Treatment in these patients will be somatostatin analogs, octreotide or lanreotide can be used. They are the therapies useful. Plus minus, you will do resection of the tumor if you can identify and if it is resectable. So resection of the tumor can be tried in the patient. Resection of the tumor can be tried. So which of the following is not correct about carcinoid tumor? Look at the options. TR can occur, asthma-like symptoms can occur, flushing can occur, urinary 5-HIAA, it is not normal, it is increased, and that is the not only screening test, it is also investigation of choice. It is looking like a, such a childish question. It is childish only if you have read the topic recently. Let's go further. There is a differential diagnosis of pancreatic neuroendocrine tumors which are asked in the exam. So what is the DD? If examiner says there is a tumor in the body, pancreatic tumor is there, the tumor is producing peptic ulcers, GERD, that is GERD, and diarrhea. The likely possibility is gastrinoma, also called as Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. Second possibility, if they say pancreatic neuroendocrine tumor, hypoglycemia, weight gain, and confusion is happening. Weight gain because some anabolic hormone is getting produced. So this is a patient with insulinoma. Confusion occurs due to low-grade hypoglycemia, which continues in the patient. Third, dermatitis is there. Which kind of dermatitis? Very important. It's a NEET PG question. Necrolytic migratory erythema. I'm putting a Q on top of it. Affecting the groins and buttocks, the likely diagnosis in the patient is glucagon excretion, which is excess. We call it as glucagonome. Glucagonome. Glucagon-oma. Oma is a tumor. Watery diarrhea with hypokalemia with achlorhydria. Achlorhydria means lack of acid production. The patient is suffering from VIP secreting tumor, also called as Werner-Morrison syndrome. Werner-Morrison syndrome. Werner-Morrison syndrome. And finally, if the MCQ says that the patient is having diabetes mellitus, steatorrhea, gallbladder disease with diarrhea. Gallbladder disease with the diabetes mellitus are the clue. The patient is having somatostatin secreting tumor. Somatostatinoma should be thought of. Somatostatinoma should be thought of. Somatostatinoma should be thought of. So We are done with these pancreatic endocrine tumors. Let us come to the thing you were asking about कि सर pheochromocytoma कब आंसर होगा? यहाँ होगा. Look at the buzzwords, look at the keywords. इसमें कभी भी ना मेंटेन बीपी नहीं रहता, फ्लक्चुएशन इन बीपी आता है. दिस इज इंपॉर्टेंट. सो इंटरमिटेंट, एपिसोडिक और paroxysmal ऐसा वर्ड बोलेगा ऑफ हाइपरटेंशन. Second important clue, whenever they have put question on pheochromocytoma, whether it is FMG, NEAT-PG or INISET, in fact, I was looking at one of the clinical cases in USMLE also, not in step 1, but the later steps. There also they have used this word, that is profuse sweating, diaphoresis. It is very, very important word. Diaphoresis will be there. Palpitations will occur, anxiety will occur, headache will be there, weight loss will be there. And another clue they may add, urinary VMA is increased and sometimes urinary metanephrines are also increased. If you have a presentation like this, what is the likely diagnosis? Patient is suffering from pheochromocytoma. Pheochromocytoma. Pheochromocytoma is a endocrine tumor. Most common site of pheochromocytoma is adrenal medulla. Adrenal medulla. And it produces your catecholamines. It is a catecholamine producing tumor. Your epinephrine and norepinephrine are more produced. What will microscopy show? See, the name pheochromocytoma means, chroma means black. So there is a black pigmentation when you take out the tumor grossly. But when you do microscopy, you will find files of cells arranged in a pattern. This pattern is called as Zell-Ballan pattern. Zell-Ballan pattern of cells will be there. So there will be files of chief cells surrounded by sustentacular cells. And this photograph, it looks the same in all the histopathological images. So this is the typical Zell-Ballan pattern that you will find in patients of pheochromocytoma. If you do CT scan or MRI with contrast, what will you find? CECT or MRI, if you do, you will find a sign known as light bulb sign or light bulb appearance. You will find a light bulb appearance in the patient. Light bulb appearance. Pheochromocytoma also shows rule of 10. What is rule of 10? 10% of these tumors are extraadrenal, outside the adrenal gland, 10% found in childhood, 10% run in the family, 10% can be malignant, 10% are associated with Men's syndrome, and 10% do not have any problem except for occasional mild diaphoresis and mild rise in BP, which cannot be picked. So 10% are incidentally detected in the patient. So blood will show increased catecholamines and urine test will show increased VMA, increased metanephrines, and so on. What about the treatment in these patients? Treatment obviously will require surgical resection. So surgery will be needed. But during surgery, we need to do pre-operative alpha plus beta blockade, because during handling of the tumor, निकालने के लिए पकड़ना पड़ेगा. When you hold these tumors and cutting them, they can suddenly release epinephrine or epinephrine, which can actually, worsen the patient on table. So pre-operatively, you need to give alpha plus beta blockade. So, dear friends, listen to the words carefully. Hypertension, hypokalemia, alkalosis, raised ARR, low renin. This is Conn syndrome. Hypertension, low renin, low aldosterone, but no mass detected, Liddle syndrome. Episodic hypertension, palpitation, diaphoresis, mass seen in the CT scan or PET scan or MRI, pheochromocytoma. I am quite sure if you just remember this and listen to this video probably again in 1.5 or 2x, you will never forget it in the actual exam. Now, there should be no reason why you should get it wrong. Pheochromocytoma कौन? ये गलती होती है, बहुत लोग करते हैं. Let's not make this mistake if it gets asked in the exam. Right? We are done. Great. Let's move further. Rule of 10 is, let me tell you, what Sir said is, yes, it is correct. It is historical importance. Why do I say it is historical importance? See here. See here. This 10% childhood thing, this itself has changed. I'm a pediatrician and I train students for super specialty in pediatrics. So in pheochromocytoma, it is seen that 10% rule is never favored, and already 10% familial thing has already been disproved. Many of these pheochromocytomas occur as part of other syndromes. We call them as APS syndromes. It is just that we did not know about APS syndromes initially. So because the more and more data is coming, so this rule of 10 is only of historical importance. But at the same time, ask yourself, are historically important things not asked in the exam? If they ask you a question, won't you say, would you say to the examiner, ki, sir, this is of not no longer followed, it is of historical importance? No, you're supposed to answer. And rule of 10 has been asked in exams. So we are supposed to. There is a difference between two things which we sometimes forget. One is clinically treating a patient and talking the right thing. And second is solving an MCQ. Solving an MCQ. Personal anecdote I'm saying, two personal anecdotes important for you to understand. Number one, when I teach for pediatrics, I always tell watery diarrhea in a child, no other symptoms, just give ORS and zinc, don't give antibiotics. That is what you should remember from exam perspective. When you sit in OPD, many times E. coli can have a presentation like this. And if I don't give antibiotic, or if there is a clinical suspicion, I want to get a test done, but parents are not uh, ready to get it done, would I not add antibiotic? I will add. So what we do versus what you need for the exam, that is different. Probiotics, no role in diarrhea actually. But we have to remember that probiotics are used in practice. Similarly, pheochromocytoma, no longer followed in practice, let me tell you. I agree with sir what he said, but it is of historical importance and it is asked in the exam, so we are supposed to remember. Okay, let's scenario. A female with tachycardia, palpitations, staring appearance. Staring ka matlab, eyes are like this, staring into your eyes, staring into your soul. And legs are as shown. What are these appearances? These are what you call as pre-tibial myxedema. Pre-tibial myxedema. Okay, pre-tibial myxedema. So tachycardia, palpitation, staring appearance means staring appearance indicates there is lid retraction which is happening. And pre-tibial myxedema, what is the likely diagnosis? The patient is suffering from primary thyrotoxicosis, also called as primary hyperthyroidism. The most common cause of primary thyrotoxicosis is Graves' disease. It is Graves' disease. Yes, it is a shin bone sign. So Graves' disease, right? Graves' disease, what will you find in these patients? What are the things you should know? First of all, it is more common in females compared to males. These patients have thyroid scan. When you do thyroid scan, because the gland is overactive, increased uptake will be seen in the gland. And these pre-tibial myxedema is always a non-inflamed orange-red plaques, which will give a typical appearance in such patients. What is the therapy that we give in Graves' disease? The first line therapy is always anti-thyroid drug. We start with anti-thyroid drugs. Anti-thyroid drugs. What are the anti-thyroid drugs? 3 drugs are available. You have propylthiouracil, you have carbimazole, and you have methimazole. Out of them, propylthiouracil is the one which is preferred in pregnancy as well as when the patient presents with thyrotoxic crisis. So propylthiouracil is the one which is used in pregnancy as well as crisis. But the side effect of propylthiouracil, these patients have hepatotoxicity which can occur. Second possibility of therapy is that you can go for ablation therapy. We call it as iodine 131 ablation therapy. Remember that iodine 123 is preferred for scan, but iodine 131 is used for thyroid ablation. And if that also fails, you will go for total thyroidectomy and put the patient on lifelong thyroid supplements. Total thyroidectomy will be needed in the patient. Yes, methimazole is unsafe. Methimazole, in fact, is the most unsafe drug in among the antithyroid drugs in pregnancy. So this is a quick review of the topic of Graves' disease. Now, DD of thyroid scan. What are the one-liners you should know? If you form, examiner says thyroid scan was done, worm nodule was found, it will be a normal test. If they say hot nodule was found, it is generally normal, but watch for future malignancies. Watch for future malignancies. There is a 1 to 2% risk of developing malignancy in later life. Cold nodule. Cold nodule will be seen in thyroid cancer. It will be malignancy, so thyroid cancer. And most commonly, it will be seen in papillary carcinoma of the thyroid. If there is diffusely increased uptake, this is what you call as Graves' disease. If there is mixed hot and cold nodules or asymmetric presentation, the patient is having toxic MNG, that is multinodular goiter. Toxic multinodular goiter. And if there is diffuse decreased uptake, the patient is likely having Hashimoto's thyroiditis, also called as Hashimoto's disease. So Hashimoto thyroiditis or Hashimoto disease, these are the patients who have anti-TPO antibody positive. Anti-TPO positivity is seen. So this is the DD. Some one-liners are related to thyroid cancers. Thyroid cancers are generally covered in surgery, so I'm not going into the details. Next thing, thyroid cancers. What is the sequence of thyroid cancers as per prevalence? What is the most common thyroid cancer? I hope you all know. It is papillary cancer, which is most common, followed by follicular cancer, followed by medullary cancer, medullary thyroid carcinoma, followed by anaplastic. Rarely lymphomas can also occur, but we are not including it. Hashimoto thyroiditis increases the risk of what? It increases the risk of papillary cancer as well as lymphomas in the thyroid. What is the most common thyroid tumor in the iodine sufficient areas? Again, the answer is papillary cancer. Papillary cancer. Orphan aneroid nuclei and psammoma bodies are seen in which condition? They are seen in papillary cancer. But iodine deficient area में कौन सा tumor is common? It is follicular cancer. Which tumor is associated with a long-standing goiter? Again, the answer is follicular cancer. So goiter or iodine deficiency, they are associated. So follicular cancer. FNAC is not useful in follicular cancer, that can miss. So you have to do the proper biopsy, and many times, you need to go in for partial thyroidectomy also as a part of diagnostic cum treatment workup. Raised calcitonin with normal calcium level, medullary carcinoma of thyroid. And where is radioactive iodine not useful? Because increased uptake or decreased uptake is not very significant. It is again medullary cancer. Medullary cancer. So simple things, one-liner things. You can add through the notes. Let's go further and talk about this table. So we are on to the second last topic, and then last topic will be diabetes. Diabetes, we will discuss some, subtopics. So examiner will ask you questions related to diabetes insipidus versus SIADH. This is a table I always teach. This table is there in my detailed videos also. There is not much to discuss in this table, but it is just that I have put this table and you are supposed to revise this table. Now, posterior pituitary releases two hormone. I'm not saying synthesizing, releases two hormone. One is vasopressin, also called as ADH, antidiuretic hormone. Second is oxytocin. If there is deficiency of vasopressin, it causes diabetes insipidus. If there is excess of vasopressin or ADH, it causes SIADH. Diabetes insipidus can be of two varieties. One variety is true deficiency, where the pituitary is not releasing it. That is central diabetes insipidus. Second is, it is there, but receptors are not there. It is not acting on the kidney. That is called as nephrogenic diabetes insipidus. PYQ, lithium is a cause of nephrogenic DI. And another PYQ, thiazide diuretics are useful for treatment of nephrogenic DI. So two different MCQs you have to remember. Now diabetes insipidus में क्या हो रहा है? Because ADH is deficient, so water will not be retained and urine output will be high. ADH is involved in insertion of channels into the distal tubule. And so these channels are not coming, water is not getting reabsorbed, polyuria is happening. Because there is extensive loss happening, so sodium level becomes high, Plasma osmolality also becomes high. It is a concentrated. Body is losing water and urine is dilute, so urine osmolality falls. On the other hand, SIADH में क्या है? Urine output is normal to decrease because there is excess ADH production. And because water is getting retained, क्योंकि ADH क्या करेगा? Water को retain करेगा. Even if the total body sodium is normal, it will be diluted. So dilutional hyponatremia will be seen. Because water is getting retained, so blood will be diluted, osmolality will be less, but urine will be concentrated. Which of the following is true about all of the following true about DI except all of the following true about SIADH except this is how MCQs are asked. With a cooled mind, if you just say it out 2 times, you will not get the answer wrong. Simple questions are asked, but they are still you need to read about. Finally, we come to diabetes mellitus. Now, diabetes mellitus, India is right now in the middle of a diabetes epidemic. Diabetes mellitus, when do you make the diagnosis? Sign and symptoms of diabetes, polyuria, polydipsia, polyphagia, sudden weight gain, sudden weight loss, etc. With random blood glucose, anytime you check random blood glucose, it is equal to or more than 200 milligram per deciliter. You call it as diabetes mellitus. Now there is a spectrum of diabetes, normal, pre-diabetic and diabetic, and these values are asked. It has been asked 2 times in exam, once in FMG, once in NEET PG. Now what about fasting plasma glucose? Normal people, the fasting plasma glucose is less than 100 milligram per deciliter. Pre-diabetes, it is between 100 to 125. And diabetes is said to be there where fasting blood glucose is equal to or more than 126 milligram per deciliter. What about the normal HbA1c level? HbA1c tells you the glucose control, glycemic control in the preceding 3 to 4 months. So HbA1c will be less than 5.6% in normal people. In pre-diabetes, it is 5.6 to 6.4%. And any value equal to more than 6.5 is the diabetic range. Third, there is a glucose tolerance test that we do. 2-hour plasma glucose is checked after loading with glucose. How much glucose is used? If you check glucose loadings, you give 75 gram glucose orally and then check the plasma glucose 2 hours later. If the value is still below 140 milligram per deciliter, normal value. If it is 140 to 199, it is pre-diabetes, and equal to or more than 200, it is diabetes in the patient. So this is the spectrum of diabetes mellitus. Simple thing, but still you need to remember it. Now, in treatment of diabetes, obviously, if it is type 1 diabetes, you will be using insulin. It is insulin dependent diabetes. Type 2 diabetes is insulin resistance. And in type 2 variety, oral hypoglycemic agents will be used. Let me tell you, oral hypoglycemic agent, if you spend even half a day, but you can say in the end of half of the day, sir, any oral hypoglycemic you ask me, I can tell you the correct answer. If you have that confidence, that is a half day well spent. Would question be asked? As I said, we cannot predict, but oral hypoglycemic, very important from pharmacology point of view. Go through the details, right? What about the type 1 diabetes? Type 1, the treatment is insulin. Many types of insulins are there. You have the ultra short acting, you have the short acting, you have regular insulin, and then you have the long acting, glargine, 𝗘𝗱𝗓, etc. Now, 2 types of phenomena are confusing and they are sometimes asked in the exam: Somogyi phenomena and Dawn phenomena. So let us do a quick review of the 2 phenomena. Let us have a look here. We'll come back to the treatment part because then we have to discuss the treatment for diabetic control. Let us skip one page and first talk about Somogyi versus Dawn phenomena. Now, whenever you have a chart like this and 2 curves are shown, remember कि D पहले आता है, S बाद में आता है अल्फाबेटिकली. तो ऊपर वाला हमेशा D होता है और नीचे वाला हमेशा S हो. You understand? It's a stupid, crude way to remember कि अगर लेबलिंग करने का आ जाए तो ऊपर वाला D है, नीचे वाला S है. और इसमें इंपॉर्टेंट चीज ये है कि जो आपका कट ऑफ है, एक यहां पर कट ऑफ दिया जाता है 70 मिलीग्राम पर डेसीलीटर. जो डॉन फिनोमेना है हमेशा 70 के ऊपर रहता है ब्लड ग्लूकोज. इट नेवर फॉल्स बिलो 70. Whereas in Somogyi phenomena, the blood glucose dips below 70, it can reach the hypoglycemic range. So let us try to break it down. What is the meaning of these 2 conditions? Now, both of the phenomena एक चीज पहले ये समझनी है कि जब हम अर्ली मॉर्निंग कहते हैं, अर्ली मॉर्निंग, अर्ली मॉर्निंग का मतलब आपके और मेरे लिए क्या होता है, 6 बजे 7 बजे, है ना। लेकिन फ्रॉम मेडिसिन पॉइंट ऑफ व्यू, अर्ली मॉर्निंग इज पीरियड बिटवीन 3 to 4 a.m. दैट इज अर्ली मॉर्निंग. It is also called as Brahma Muhurtam in Sanskrit. And what is the pre-breakfast time? Pre-breakfast time is considered to be 7 a.m. Have you seen that most of the breakfast in most hotels that starts from 8 o'clock till 10 or 11 o'clock? So pre-breakfast is 7 a.m. These are the two things that you need to remember. And these will be useful for your later life also. Not in real life, but from when you will be reading in medicine. So सबसे पहले पहला फिनोमेना जो हमें देखने को मिलता है, that is Somogyi phenomena. So I will be writing the first phenomena is Somogyi phenomena. What is Somogyi phenomena? You can remember like this: so much insulin हो गई. If you give more insulin, the side effect, the repercussion of that is called as Somogyi phenomena. So much insulin हो गई. So more insulin causes this problem. What is the cause of Somogyi phenomena? If you give increased bedtime insulin. If you give increased bedtime insulin, what it will do? It will cause early morning hypoglycemia. It will cause early morning hypoglycemia. Can you see in this photograph as I am writing? 3 a.m. पे हाइपोग्लाइसीमिया हो गया है. 3 बजे सुबह के अर्ली मॉर्निंग हाइपोग्लाइसीमिया हो गया है. लेकिन बॉडी क्या करेगी? अब बॉडी फाइट बैक करेगी. तो अर्ली मॉर्निंग हाइपोग्लाइसीमिया से क्या होगा? ग्लूकागॉन का रिलीज होगा, बिकॉज बॉडीज काउंटर प्रोडक्टिव हार्मोन विल बिकम एक्टिव. और उससे क्या होगा? जो आपने इंसुलिन दिया था वो उसका कोई मतलब ही नहीं रहेगा. दैट विल नॉट बी एबल टू sustain blood glucose and glucose will start rising and patient will have pre-breakfast hypoglycemia, pre-breakfast hyperglycemia. So can you see at 7 a.m. it is in the hyperglycemic range. So this phenomena is called as Somogyi phenomena. So much insulin हो गई. 3 a.m. पे hypoglycemia and 7 a.m. पे hyperglycemia. This is Somogyi phenomena. Okay, that is the first thing. Second phenomena is dawn phenomena. Not the D-O-N dawn, dawn phenomena. Dawn is again in the morning time. So dawn phenomena, it is relatively more common. What happens in dawn phenomena is it is more commonly seen. It's more commonly seen compared to Somogyi phenomena. In these patients, there will be slight in sleep, in normal people, including diabetic people, there will be slight dip in the blood glucose levels. But this slight dip will produce no hypoglycemia. Can you see in this photograph? Look at the blue curve. No hypoglycemia is getting produced. Dip is happening during sleep, but there is no hypoglycemia happening. This slight dip in blood glucose will lead to increased cortisol. Cortisol secretion will start rising. Some amount of growth hormone and glucagon can also be increased, but it is predominantly cortisol mediated. They all will start rising and they will make insulin receptors. In the effect of these, the insulin receptors become refractory. And that leads to pre-breakfast hyperglycemia. Temporarily, the receptors become refractory, leading to pre-breakfast hyperglycemia. तो दोनों में हो क्या रहा है? 7 a.m. पे hyperglycemia is happening. But one variety is due to increased bedtime insulin, glucagon is involved, and a dip of hypoglycemia is happening. Dawn phenomena में dip does not happen. Ideally, both should not happen. Lekin which is more dangerous? Somogyi is more dangerous because hypoglycemia, the dip is more. And physiologically, we have seen that rapid fluctuations in blood glucose again is not good for the patient in the long run. Ideally, both should not happen, but Somogyi is something that we need to target and more aggressively target in the patient. Dawn phenomena to some extent occurs in many diabetic patients as well. So this is Somogyi versus Dawn's phenomenon. So this is your Somogyi phenomena versus Dawn phenomena. Now, talking about diabetic ketoacidosis, it's one of the favorites of examiners these days. A lot of questions are being asked. So we will again be making flowchart. Both flowchart बनाए हैं, we'll be ending with flowchart. But it's not random flowcharts. We have understood and made them. So what is diabetic ketoacidosis? You would write, it is a complication commonly seen in type 1 diabetes mellitus. It is rare in type 2, but it can occur in type 2 as well. But however, it is more commonly seen in type 1 diabetes. Three parts are there. Diabetic means hyperglycemia. Keto means ketone body formation. Acidosis means acid pH of the blood is falling. So there are three things that you need to watch out for. First diagnostic criteria, any patient having blood glucose equal to or more than 200 milligram per deciliter. That should be there. Generally इनका blood glucose almost 300-400 होता है, 500 भी हो सकता है, but it is above 200. Second, these patients will have metabolic acidosis. It is always a high anion gap metabolic acidosis. High anion gap. And if you check serum bicarbonate in these patients is less than 15 to 18 millicoulomns per liter. Different guidelines use different cutoffs. Age का भी difference होता है. So 15 to 18 is what you should know. And third, these patients will have ketosis. Either ketone bodies in the blood, we call it as ketonemia, which is more specific. Some patients can have ketonuria as well. So which is the most common antibody which is produced? It is beta hydroxybutyrate. For example, there will be beta hydroxybutyrate. That is the common ketone body which is produced in these patients. Diabetic ketoacidosis is always an emergency because it can cause death. MCQ, what is the cause of death? Diagnostic criteria also an MCQ. Most common cause of death in DKA, it is cerebral edema. Cerebral edema is the cause of death. Now, what happens and how you are going to treat these patients? Let us talk about the management principles. As soon as the patient presents to you, first of all, any emergency, you will check for airway breathing circulation and you will make DKA diagnosis. पहले पता भी चलना चाहिए ना diagnosis है कि नहीं. Patient will not say I am having DKA. You will make the DKA diagnosis. Once the DKA diagnosis has been made, what is the management we do in the first hour? In the first hour, you will be starting the patient on IV fluids. Start the patient on IV fluids. Very, very important. Start the patient on IV fluids. Okay. Now, which fluid should be preferred? Normal saline is generally preferred over ringer lactate. Let me tell you, if it is a pediatric patient, ringer lactate is not to be used. In adult patient, ringer lactate can be used. Because we are talking medicine, so we will talk. But normal saline, the latest data, if you go by all the standard guidelines, including the book which is lying on my side, normal saline is the one which is generally preferred in practice. So start IV fluids in the patient. Normal saline is 0.9% normal saline. Right? Start IV fluids. Plus, क्योंकि क्या होता है कि सभी patients of diabetic ketoacidosis में there is a cell level dehydration which is happening even if there is no shock. Now the question is कितना fluid दे? Fluid का type तो पता लग गया. If there is mild decay, what is mild decay? Whenever the bicarbonate is between 10 to 15, we call it as mild decay. Second, तो आप कितना दोगे? You will be giving 10 ml per kg IV fluid per kg body weight over 30 minutes. Now adults you use in liter, but ideal way to remember is always in ml per kg. It is always the best way to remember. Second is moderate decay. Moderate decay is said to be there where bicarbonate value is between 5 to 10. You will be giving 20 ml per kg over 30 minutes. And if it is severe decay, the bicarbonate value will be less than 5. You will be giving the same amount, 20 ml per kg, but the time over which you give it is 20 minutes. Generally, shock is rare in these patients and shock management is not needed. कोई भी shock होता है तो what you do, you always start bolus therapy in the patient, right? So bolus will be needed. Now, when you give fluid, after this starting IV fluid, you will shift the patient to maintenance fluids. Shift to maintenance fluids. When you are giving maintenance fluids, you will add KCl to the fluid, even if serum potassium is normal. Maintenance fluid will be added because even if the serum potassium is normal, many of them have low potassium levels in the body. That's a part of the physiology. And secondly, you will start insulin infusion. Adults, sometimes you use bolus, but remember the preferred way of giving insulin, regular insulin is given. It is regular insulin which is used. It is always started as an infusion. We start in a dose of 0.05 to 0.1 unit per kg per hour insulin infusion. And you titrate as per response. You titrate as per response. This is the initial therapy. Subsequent therapy will not be asked to you because that will depend upon the status of the patient, how blood glucose is rising or falling. कभी-कभी क्या होता है, actually blood glucose falls more dramatically. So you have to add glucose into the maintenance fluid also. This is something also you have to do sometimes, right? So this is the initial management and this is what examiner is interested in knowing. Remember, no role of sodium bicarbonate except pH of the blood is less than, except pH of the blood is less than 6.7 with cardiac depression. This is the only condition, cardiac dysfunction. This is the only condition where you will be using sodium bicarbonate, but sodium bicarbonate will never be the answer. There is no role of sodium bicarbonate, right? And anytime, absolutely rightly said, if blood glucose falls below 250, you will add dextrose to the maintenance fluid. You will add dextrose to the maintenance fluid. You will add dextrose to the maintenance fluid. Okay, every single MCQ on DKA related to therapy which has been asked, including some tougher ones in INISET and NEET PG, are now in your notes. The only thing is you need to remember it precisely. This also means that we reach the end of the session. Thank you so much. Take care. God bless everyone.